osteoarthritis and rheumatoid. It impacts physical health and quality of life, major global change health concerns. So the challenges with current therapies include conventional treatments often lead to adverse side effects, and we are looking for complementary strategy to enhance management. So you can see that this is just a pictorial representation of how the both joints look like in normal and arthritic conditions. So, so you can see that the onset is after the onset of this disease after 2 and after 10 years people are unable to work. So in Indian population, the prevalence is almost 1 in 15% suffer from this joint pain related disease. That is almost 6% of the population. So there are treatments which are NSAIDs, DMARDs, and ballistic DMARDs. Antioxidant activities as compared to the standard, that is ascorbic acid or other standards which are used routinely during the studies. So we also showed here that it can prevent the DNA damage. So and free radicals lead to the DNA damage, and this is a very classical experiment which is done with the plasmid. So you can see that there is conformational change in the plasmid when there is so just for students or audience, the plasmid exists in two forms. One is the common form is supercoiled undamaged form, and when it gets damaged to because of the free radicals or other things, it gets converted to. So there is a proportionate change in the conformation from supercoiled to circular form. So on the basis of that, we can make a statement that whether and we have used hydrogen peroxide for as antioxidant as DNA damage agent. So we did SPTLC to identify the biomarkers like benzoic acid, sesamol, beta-pyrin, and 1,8-cineol, as well as quercetin. So this was the study on the, we checked the acute toxicity on the rats to observe the effects of formulation. So the results indicated no observed skin side effects or adverse reactions in the tested rat. Then we measured the weight, and we could show that there was no change with a very high amount of formulation, that is 200 mg per kg. We could show that there was no significant adverse effects or toxicity from the formulation, and there was no decrease in the weight. So, chronic toxicity study reveals that there is no treatment-related mortality observed, and which fulfills the OECD 410 guidelines. So, animals showed normal behavior and activity, no signs of systematic toxicity during a study period, normal body weight, and no significant change in food and water intake. Application site, so intact skin condition. So you can see here that there was no significant change in body weight across the observed groups. So in the male and female rats. So this then the anti-inflammatory assays by measuring the rat paw edema and by administering carrageenan. So we can show that you can see that there is a significant increase in the rat paw volume in the disease condition from 35 to 69, and standard there was no significant change, and standard the indomethacin drug was used and unim R. You can see that there was not significant change in the rat paw value. That indicates that it is working as anti-inflammatory. Then we used Prince adjuvant induced arthritis. You can see that there is no significance. In fact, with the use of Unim R, there is a decrease in the CFA response, the progressive decline after peak and greater separation. But so percent change in body weight, you can see that disease condition there was no change in the body weight. On the other hand, standard drug and UNIMR showed a gradual increase in the body weight compared to normal controls. This is the X-ray of right hippo. You can see the difference between the normal and disease. The disease group exhibits severe joint space narrowing, bone erosion, and deformity, which is curated in the presence of when standard drug or unim R is given. And this is the histopathological study of the revealed severe synovial hyperplasia, dense inflammation, infiltration, and marked bone erosion, the disease control group. So, in the presence of unim R or standard, there is a reduction in the synovial fluid thickening, infiltration, and bone erosion. So after that, we have measured the cytokines. We have measured both anti-inflammatory and pro-inflammatory. So on the basis of these results, like pro-inflammatory, we can see that there was an increase in the, you can see that increase in the TNF alpha, IFN gamma, IL-02, IL-10. So IL-2, there is an increase in these cytokines in the disease condition, and you can see with standard and unim R, there is a substantial decrease in these cytokines. So, same with the hyaluronic acid and prostaglandin. So you can see that. So these some of these works have been published. And coming to conclusion, so natural formulation perform comparatively to a standard drug, showing a better potential than the standard drug. UNIR shows no skin effects on that, no mortality or behavioral changes, no significant changes in the body weight, and there was a dose-dependent anti-inflammatory effect. So there was a decrease in the anti-inflammatory for the cytokines and increase in the anti-inflammatory cytokines and decrease in the pro-inflammatory. So, as a future study, we are doing the gene expression studies of these cytokines, and we are doing the protein analysis through Western blot. So, in a month or so, that those results will be also available to correlate our results whether these things are happening at the gene level or at the post-translational level. So, this work has been done by three of my project students. Pawan and Vinita are here, and this is a collaborative work with the SVKM, CP, and with the regional Research Institute of Unani Medicine, Harvard, Mumbai. So, and this work has been funded by CCRU, and we are in the last stage of work. Then we can take it to clinical studies. Thank you, sir.
Thank you so much, sir. I request Dr. Idris to felicitate sir with a memento. Dr. Zaki Ahmad Siddiqui and Professor Dr. Mohammad Idris, sir. And this is a felicitation of Dr. Ahmad Ali, sir. Thank you so much for this felicitation, and also Madam Amina Al Hadan is also a chairperson. Ma'am, I request you. So we are moving ahead with our first session, Innovations in Unani Formulation and Drug Development. Chairpersons are Madam Amina Al Hadan, Chairperson, Lotus Holistic Health Center Institute, Abu Dhabi, UAE. A very warm welcome, ma'am. Also, chairpersons are Professor Dr. Mohammad Idris, former Principal, Dean, Ayurvedic and Unani Tibbiya College and Hospital, Karol Bagh, New Delhi, and Dr. Zaki Ahmad Siddiqui, Deputy Director, Regional Research Institute of Unani Medicine, Kharghar, Navi Mumbai, Maharashtra. Moving ahead, I would like to invite Dr. V.N. Asgar, sir. And also, I would like to announce the speakers for this session. Dr. Yogita Goyal is also here. Very warm welcome, ma'am. Dr. Dinesh Mani Tripathi ji, very warm welcome, sir. And now, after the first speech, would like to invite Dr. V.N. Asgar Dushakir, sir. He is Scientist E and ICMR International Fellow at Department of Bacteriology, National Institute of Research in Tuberculosis, Chennai. He has authored first corresponding author papers and co-authored 13 papers, and he has a great contribution in research in tuberculosis. A very warm welcome, sir, and I request you to start with your presentation. जोरदार तालियों के साथ हम सर का स्वागत करेंगे.
Good morning, and thanks for the nice introduction. And also thank the organizers for inviting me for presenting my study. This study was actually funded by CCRM, and this was an idea proposed by Dr. Zahid when he was the director of the RREM Chennai. And before this, I don't have an introduction slide for this disease. I'll just brief you. And we are coming from National Institute of Research in Tuberculosis, and we are concentrated on the disease TB. And as you know, it is one of the contagious and leading, second largest leading killer disease in the world. And it's actually a chronic infection, and it has been, it's still the chronic infection and the tissue remodeling and inflammation, as well as the lung destruction persists still after the cure of the disease. And this leads to post-TB lung disease, and 50% of the TB survivors actually have this post-TB lung consequences. With this deep background, I'll jump into the presentation. And this study was titled as Evaluation of Anti-TB Safety and Immunomodulatory Activities of the Unani formulations, Pussy, Tabashir, Satani, and Arki, Arabra. This is through in vitro and in vivo methods. These two formulations are given together. One is a tablet form and another one is a liquid form. It is mixed and it has been administered for the patients. And so we want to find out whether we have the paper already with Dr. Noman and his team along with NIR. They did a safety profiling in an uninfected animal model. They found that and they claim that it is effective protectant. So we want to test this hypothesis in infected animal model. Along with this, we just proceeded with the basic stuff. And so the objectives of the proposal is to determine the in vitro efficacy of the formulations along with alone and as well as along with that over first line anti-TB drugs for treating TB. The phase 2, we want to determine the in vivo toxicity of the formulation in the infected animal model using guinea pigs alone and in combination with the regular anti-TB drugs as it is given in the human, and to determine the immunomodulated role played by the formulation. So this is in vitro whether the formulations are having any efficacy towards laboratory grown strains as well as clinical strains of mycobacterium tuberculosis. We included multi-drug resistant tuberculosis, which are resistant to first line drug, which we call it as MDR, and multiple strains of MDR and drug sensitive clinical isolates were used, and we found that it was still high. The effective concentration which was able to inhibit the mycobacterium was at 5 milligrams, and it was in some other strains it even showed up more than 10 milligrams. It was quite high. So we wanted to find out whether it is given along with the anti-TB drugs as an adjunct mode of therapy, whether it is going to inhibit the potential of the existing anti-TB drugs and the current use. And we found that it doesn't have any antagonistic property. All these combinations with isoniazid rifampicin were tested in vitro, and we found that most of them had an additive as well as few with isoniazid and isoniazid rifampicin. It got even a synergistic form of activity also. So it is going to be safe if it is going to be given, administered along with the anti-TB drugs. We found out in the in vitro assays. And so we went for the immunomodulatory phenomena, whether these formulation immunomodulators. So we used the blood from TB infected patients. We isolated PBMCs, and we tested the role of the cytokines in this MTB infected PBMCs, and we actually stimulated them with ESAT, one of the early secondary antigenic for TB, and without stimulated and unstimulated, with stimulated with ESAT, along with all the different panel of immunocytokines tested, which are playing a very role in TB. And we found that we tested it in two models, PBMC from a latently infected person and another one with actively infected TB patient. We found that they have a strong IFN gamma secretion. It was with QTS, but the AHP it was moderate. Both together it was moderate. TNF alpha moderately high with this one together, both the formulation given together. IL-12 it's polarizing TH1 T helper polarizing cytokine. It was also moderate when it is given together. IL-6 pro-inflammatory marker, it was again moderately, so on. So balance the outcome as a whole, it was that together if this formulation are given to the patient, is going to be supportive modulator, and found that they were modulating the immune mechanism. It was not in a great deal, but that is not expected actually. It was going to be very strong immunomodulator, strong in producing the cytokines. It is leading to lung tissue destruction. So it was moderatory, supportive, as well as an actively growing active in the infected patients. PBMC also ended up with the same kind of balanced modulator potential with all these cytokines tested. So this gave an idea. So it is a potent immunomodulator, which is expected to be treatment, and we went further to test it in the in vivo models. So this is the groups, early infection control, late infection control, along with the animals were after the infecting, the animals were tested with one group will be treated with anti-TB drugs, isoniazid rifampicin, ethametol, and pyrazinamide. All these 4 drugs are being given to patients in the first 2 months, and later on it's continued for another 4 months with 3 of these drugs. So we want to stimulate the same kind of as it is given in human. So all these 4 drugs were treated in one of the animal groups, Another animal groups were for Unani formulation alone in 3 different dosages, and another 3 group of animals with Unani with the anti-tubercular in 3 different dosages. So these are the animal groups we wanted to test and find out the efficacy of this and the safety of these combinations. So this is a actual scenario study design. So these animals, after procuring, they were kept in isolation for 4 weeks to get acclimatized to the lab setup. And it was carried out in BSL3 animal lab in Agra, CHAVAN, one of the ICMA center. And we infected animals, all the animals left it for 4 weeks for the disease to develop. After the disease has spread, then the animals are divided in 9 groups, 5 in each group, and continued further then treatment phase for 8 weeks. So that is equivalent to 6 months of treatment in human. So we wanted to simulate the same condition. So one of the group with anti-TB drugs or these 4 drugs, and the other groups were, as I said, 3 other groups were with Unani combination alone in 3 different dosages, 1,500 and 250 milligram per kilogram of body weight. 500 milligrams per kilogram of body weight as actual prescribed for human for this population in other diseases. So we want to use 500 as well as one lower and one above. And so this another 3 groups with UPF with ATT. So these were the 9 groups. So these were the animals when it was sacrificed, the right hand side panel. And so 2 of the animals were sacrificed really controlled after infecting the animals. 2 G2 were late controls. And then we sacrificed at the end of 8 weeks. We the lungs, spleen, liver, and later are recorded. The outcome measures, we went for the viable count measurement for the bacteria, and for histopathology, serum biochemistry, as well as CBC. Apart from this, after getting these results, we carried out another experiment for 1 month. I'll be telling you the purpose after seeing some of the results from this experiment. Then we went for further extrapolation also with another set of experiment with 1 month of data. So this was the original experiment plan, and it was carried out, and I'll be discussing the results. So this shows the lung gross morphology of the lung, spleen, and liver, and subsequent slides. So here in infected animals, as expected, it was granuloma, confluent granuloma was seen there in the top left-hand side. Figure shows the full of granuloma, full of hematogenous spread of this granuloma present in the lung lobe. The second in the top panel shows the anti-TB drug filtered with a reduced distant burden, vesical discrete granuloma was seen as well as focal consolidation. With the Unani formulation alone, with high and medium and low dosage, still we saw a dose different infection reduction in the lesions. Only partial improvement was seen when it was given alone. When it was given and along with the anti-TB drugs, marked enhanced protection was seen. This was gross appearance only. So high dose in high dose near normal lung architecture, minimal scattered lesions. Lower doses had moderate improvement. So this was the cross pathological observation. This is for spleen as expected in the untreated infected model group. We have found a splenomegaly, irregular surface with multiple tubercles. ATT alone, we saw the reduction in the spleen size. But again, the Unani formulation alone group had partial dose difference reduction with ATT. Strong synergetic effect was seen, almost near normal spleen morphology with less of enlargement, almost in the size of the normal healthy spleen was seen. So we went for the weight measurement. Here we used the lung weight as well as the body weight was together taken, and we found a markedly elevated lung and spleen body weights ratios. So reflects severe pulmonary inflammation in the untreated group. ATT alone, we saw lung spleen ratios result to close to live levels. With I go for a lot of time, I exactly go for the Unani formulation with ATT. We saw strong synergistic protective effect. The ratio were quite low as that of NAIV, and the ratios are equal to or lower than the ATT alone. So the lung body weight and organ to body weight ratios were comparably lower than ATT. That was a significant finding here with in aspect to the weight of the organ versus the body weight. So when we went for the bactericidal activity, we measured the viable counts. We did a viable count of the microbial tuberculosis. We found in untreated infected organs. We found a heavy load of 4.7 log of this bacteria. With 83 alone and EB alone, it was totally zero. That is expected in at the end of 2 months. We expect no viable counts. With Unani, partial suppression of bacterial burden was seen. Unani alone. Pictures you can very well appreciate here. The ATT in the second row is equal to zero. With the ATT 1500 along with the Unani formula 250, it was totally zero. But with 250, we saw some spleen viable counts in spleen with 250,000. It was the lowest dose we tested. That's bacterial burden was there. But at 500 and 1000 with ATT, totally it was zero. This was then we did 1 month of experiment. As I said earlier, it was not planned. It was with a different purpose. I'll tell you later in subsequent slides. With at the end of 1 month of treatment, some of the animals, all these animals sacrificed. We saw some amount of bacterial burden for ATT as well as in ITT with Unani. That is expected. At the end of 2 months, only complete releasing activity is seen. But at 1 month of it was equivalent to the Unani with ATT when compared to ATT alone. But slight moderate increase was that, it was not statistically significant. So when we went for the histological examination, the ATT had partial bacterial control, but the inflammation was persisting. We could not see the top left panel. You see the alveolar was very minimal. With granuloma was seen with 250, 500 and 1000 dosage of granuloma with ATT. Almost the granular architecture was retained here. And so with you can see the combination therapy significantly improved pulmonary pathology compared to the ATT alone. Still, the granuloma was seen in ATT group, but it was very minimal in Unani formulation with ATT. I have the scores in subsequent slides. This was in liver, ATT with Unani formulation. There was no granuloma in all the dosage, showed minimal hepatic changes. Lung architecture, liver architecture, hepatocytes were very intact. But even in ATT group, you saw reduced dissemination, but with mild hepatic stress was present. In spleen, it was very interesting. In UPF with ATT, majority section showed no abnormality at all. Significant reduction in the dissemination, but in ATT alone, still the granuloma was persisting. So these are the scores done by pathologists, trained pathologists from Agricultural University. And the lung granuloma scores were counted here. And as you see, the ATT, the scoring was for all the lung sections, it was 4. But with ATT 500, you see, it is just 1. And with 250, it was 0.2 only. This was in spleen. This is the scoring, the granuloma destinations, the pathological scoring. When you compare with the ATT, I have removed the other sections which are not significant, that is infected controls and all. Just ATT versus the Unani combination with ATT. The significant reduction was seen in 500 and 250. So 4 versus 1 and 4 versus 0.2 in spleen. This is in liver. Again, it was comparable with ATT. At 250, you see some reduction there. And it is histopathological using hematoxylin eosine staining alone. So this is for lungs. There was again gross improvement in the scoring for ATT with Unani. 3.2 versus 2.2 in 500. 500 was the optimal dose. That's why I'm just keep on repeating 500 with ATT. I'm talking about 500 dose. So then after this one, that was manual scoring. We went for an automated scoring using we call it as morphometry. It was done in another lab. It actually scores the entire section of the tissue. And so we can quantitate the amount of granuloma present, and the size of the granuloma can be measured. And as well as we want to look for the fibrosis present, because this fibrosis is a lot of worrying factor which causes post-TB lung damage. And so here that is being represented as a Ascroft scale. It was done by a trichome, mycelis trichome screening, was a special screening to screen the fibrosis. Here the unique features, unique slides only I'm just presenting. The first two are for the lung with Unani formation with ATT at 500. There was totally no granuloma. The semi-quantity evolution ended at 0. Ascroft scale for fibrosis was totally 0, but with the right-hand side panel is for ATT alone. Still, granuloma was there. Number of granuloma in the entire section was 6. For those sections provided with that, the fibrosis score was 3. You can see that blue colored fibrosis with the arrow mark in the middle of the second from right. You see the fibrosis there with ATT. The score was 3 versus 0 for Unani with ATT. That was for lung, and this was for liver. Architecture was completely preserved in the Unani with ATT, complete absence of granuloma and no fibrosis. But with the ATT, you can still see the granuloma present there. The lung architecture was totally destroyed there. Moderate regeneration of hepatocyte and moderate inflammation was still persisting. This was done after 1 month of treatment. But the 2 months, you'll have different changes there. So the morphometric scores are being consolidated here. The first one in the top is the untreated scoring is average is 10, the number of granuloma, the diameter of the granuloma. This was the first panel is for 1 month of treatment. The second table is for 2 months of treatment. And so the average size was 0.2 in untreated. With ATT, the number of granuloma, all the 4 sections were 8 in number with ATT alone. And the size of the granuloma was 0.5. At ATT with Unani, you see 6 average of granuloma was seen. Again, 0.2 is the diameter. Micro tectoral granulomatous lesions is described by this 0.2 diameter. At the end of 2 months of treatment, you see ATT, the diameter was 0.15, number of granuloma was 6. With the 500 specifically, I want to concentrate is 6 and 1 granuloma. The granuloma size was totally reduced. 0.07 versus 0.5 at 0.2 in the 1 month of treatment. It was markedly reduced and it was completely improving the granuloma numbers as well as the granuloma size was completely improved by this morphomedical analysis. So then we went for the PK measurements of blood levels, which was totally upsetting us here because in group 3 is ATT and group 10 is ATT with Unani. In group 3, in group 3, all the anti-tuberculars are still present. It was more also compared to the Unani formulation with the ATT. It was very less in Unani formulation with the ATT for isoniazid pyrazamide. Rifampicin we could not detect at all in the blood of the animals with Unani formulation and ATT. But ATT's rifampicin was still there. So here we were confused why in blood we could not see the another 3-4 slides. So we went for the tissue drug level also here. That was done in HRMS. Here it all were completely reversed. In lung, you could see in group 3 is ATT, group 10 is ATT with Unani, isoniazid rifampicin, everything was present there. So it was concentrated in tissue, but blood has been cleared and it is going to the lung, site of infection, lung as the liver, the drugs were present and it was more when compared to the ATT alone. So this was the ratio here in tissue drug levels. With the special instrumentation, we were able to see comparable levels. And in some cases, more of these drugs is seen in Unani versus Unani with ATT when compared to ATT alone. So this shows the pharmacophilia profile is consistent with improved target site drug delivery and suggests potential superior efficacy safety balance. So these are the biochemical status. All were quite normal. Urea, creatinine were normal in all the groups. Uric acid, bilirubin, SGOT, gamma GT. Total protein was less in ATT in the infected animals, but it was more normal in the Unani with the ATT. Globally, it was also lesser in ATT and infected, but in the AG ratio, it was more in ATT and infected, but in Unani with ATT, the AG ratio, albumin globulin ratio was lesser. So we went for another important aspect. We wanted to study what is mechanistically happening in this tissue levels. That was we went for metabolomic from the lung, spleen, and liver, mainly lung and liver. This shows us the quality of the data metabolomic was run in a high resolution MSMS at Ajipur, Naipur, and it was complete segregation. All the three groups, one is infected, another one is ATT, and another one is ATT with Unani combination. They were completely segregated. You can see in the A of the thing. The rest of the things means quality of the assay. This gives the heat map of the metabolomics in lung. This gives a comparison between ATT with infected versus ATT with Unani formulation. It gives a very wide VIP score. These are the important metabolites present in the. It was present in the group of animal lung tissue in the group which was treated with Unani with ATT. And the last slide. This is the metabolic liver profile. Shows marked reduction in the cirrhosis of the liver with the Unani formulation as well as the heat map shows, and here the PCOS score shows a complete segregation of all the three groups, reflecting the quality. So this is almost the final slide, and this gives a complete picture of the metabolic profile. In the first column, you can see for the ATT here. Suppression, ongoing tissue remodeling, ongoing only. Reduce acute inflammatory metabolism does not fully terminate the fibrotic signaling. And the right hand side, you can see that Unani with the ATT here, tight clustering was there. It was very good, appreciable quality of the graph, and greater displacement from infection control, greater displacement from more cohesive metabolic normalization happened. We analyzed with the help of the different metabolites present in the heat map, and there was completely resolution phase. Remodeling appeared. Fibrosis complete termination was seen in this metabolic profile, and complete restoration of lung hemostasis was seen with Unani with ATT. This was very promising, and it all implicated to this. And we went for the immunohistochemistry also. It was also contributing, showed a reduced granuloma size, and overall immune cell burden was also reduced in Unani with ATT. This was also another unplanned assay. Immunohistochemistry was also done. So to conclude, so it was an integrated outcome of urgent intervention on tuberculosis, Unani formulation with ATT, which showed a histopathological improvement, decreased granulomas, reduced fibrosis, and splenomegaly attenuation was happening, comparable to ATT efficacy in terms of antimicrobial activity. Similar bactericidal efficacy was with ATT was seen. Enhanced host immunity was seen with THP, TH helper 1 cells and versus TH17 immunity controlled inflammatory signal was seen, and metabolic restoration, resolution phase remodeling, and complete restoration of the tissue homeostasis was seen. Favorable safety profile in terms of the drug levels. So to conclude, adjunct therapy with this, your intervention with the Unani combination with ATT enhances anti-TB efficacy while fortifying the immunometabolic recovery also. Thank you. Any clarification? Thank you. Thank you.
सर कुछ कमेंट कर सकते हैं?
At the end of the session, sir, we will have few question answers. And at the end of the session, we will do all the felicitations of the speakers and the chairperson. Thank you very much, sir, for sharing your valuable and detailed studies. Now, in this session, we have another speaker, Dr. Yogita Goyal, who is Professor and HOD, Department of Pharmaceutics, Shri Vileparle Kedwani Mandal's Institute of Pharmacy, Dhule, Maharashtra. She has 19 years of experience in academics, research, and pharmaceutical innovations. She has guided 4 PhD scholars and 25 postgraduate students. She holds 3 patents, contributed to 2 books, and 10 book chapters. So, ladies and gentlemen, let's welcome her with a good round of applause, Dr. Yogita Goyal. And today's topic, her topic is to investigate the pharmacological effect of certain Unani formulations in a preclinical animal model of polycystic ovary syndrome. Over to you, ma'am, Dr. Yogita Goyal.
Request, we have covered the 50%. We have the 4 speakers to this session. So half is over, then the remaining half and one and other. So I would request you to kindly skip the introductory and review. Just come go to the objectives and outcomes.
I'll do it in very, yes, very quickly. Yes,
It's my request.
thank you, sir. Yeah, I'll do. Very good morning, respected dignitaries, all the members, esteemed members, and my dear colleagues. Today, I am going to present my research topic to investigate the pharmacological effect of Mazun-Davidul-Ward, a Unani formulation in a preclinical animal model of polycystic ovary syndrome. Next slide. Why I have selected PCOS. Next slide. PCOS is a common endocrine problem, mostly affecting reproductive women. And it is a well-established Rotterdam criteria by the American Society of Reproductive Sciences that any 2 symptoms out of 3, if it is seen like hyperandrogenism, oligoanovulation, and polycystic ovary morphology, then there are chances of patients suffering from PCOS. So we should further investigate it. And this is very surprising to know that highest burden of PCOS is seen in India, that is in more than 3.5 lakhs. In very short, the pathophysiology, PCOS is not only affecting the ovarian function, it is affecting at the different level hypothalamus pituitary. It is stimulating the gonadotropin hormones, which is disturbing the level of LH and FSH, elevating the level of LH hormones and decreasing the level of FSH hormones, and raising the level of androgens, which is causing ovulatory dysfunctions. Along with this, it is also associated with insulin resistance, means there is no response to the insulin, level of insulin is increased, level of glucose is increased, and hyperinsulinemia takes place. All this results in hyperandrogenism and the follicular arrest. So, reduced aromatase activity means reduced conversion of these androgens to the estrogens, LH is raised, androgen is raised, FSH is reduced, and the junction between the cell is poor, and altered steroidogenic activity means reduction in the enzymes which converts the androgen to the estrogens. So, as we saw the pathophysiology, before moving forward, we should know how we can test PCOS. So, in the patient's first, general personal data is taken like the lifestyle, obesity, weight, dietary habits, genetic predisposition, because these are the primary factors for PCOS. After this, we confirm by physical examination like anthropometry means body mass index, then acanthosis nigrans, this is black patches because of insulin resistance. If these features are there, it is further confirmed by the blood test where we check the blood glucose level, we check the hormonal level of LH, FSH and the testosterone. And lastly, we go to the ultrasound to see the appearance of the ovaries, where we can see number of small follicular cysts in the ovaries in the patients of PCOS. Treatments available are clomifene, which is an ovulation induction agent, but it does not address the metabolic conditions. Anti-androgens like phenol, and it is also tetragenic. Oral contraceptives, though it helps the hormonal balance, but it does not acts on the other symptoms, and it is also creating different problems. Then insulin sensitizers like metformin is used, which helps to reduce the insulin resistance, but it does not act on the ovulation or the infertility problems. So here we can see this is multifactorial. Hormonal imbalance is there, even blood glucose level is disturbed. At the dermatological level, there is disturbance. At the inflammatory level, disturbance. So we need a therapy which is multivariant, which can balance the hormones, as well as it can have effect on the mental health as well as on the endocrine and metabolic health of the patient. So we are going for the traditional system of medicine where Unani is the prevalent one. It acts by the 4 temperament, hot, cold, wet and dry, where 4 humors are there: blood, belgium, yellow bile and the black sweat. Significance is there. This system where we want multivariate, here Unani has mental, emotional, spiritual and physical causes. It is working at that level, means it is holistic in nature, which is the best treatment option for PCOS. It provides promotive, preventive, curative and rehabilitative healthcare. So in Unani, PCOS is also known as Mers Akyas Kustur realm, where Unani concept of PCOS is basically mainly focused on the dominance of Kilte Balgam. Means there is accumulation of the Balgam in the reproductive organ, which is the main cause of PCOS. So one of the abnormal form of pregnancy accumulates in the sac. So the clinical features are Tams, which is amenorrhea, irregular menstrual cycle, Urk means infertility, then Saman e Mufrat, obesity and hirsutism. These all factors we have seen earlier also. These are the primary symptoms of PCOS. So the Unani medicine is holistic and the natural approach for PCOS. And this in this Unani medicine, my treatment of choice is Mazum Davidul wort. I have selected Mazum Davidul wort, a classical polyherbal formulation. Why? On the basis of its property, as it is already used for the reproductive treatments, it is used as a lutein tonic and it is a warming agent. And here we have seen in PCOS, there is deposition of bulgum. And in the Unani Mazum, many of the agents which are warming agents and it also dissolving agents, means they dissolve, they disperse the bulgum and they affect the temperament, which is the cold temperament. These Mazum Davidul wort contents create warming effect, and this is the reason why Mazum Davidul wort, along with the anti-inflammatory, astringent, antiseptic, antioxidant and the antimicrobial properties, is hypothesized to have effect on PCOS. So the objective of my study was to determine the therapeutic potential of Mazum Davidul wort in the experimental model of PCOS. Next, to study the effect of Mazum Davidul wort on weight of ovary, histopathology and ultrastructural alterations, FSH, LH, testosterone level in the letrozole-induced model of PCOS. Third, to study the effect of Mazum Davidul wort on insulin resistance, hyperglycemia and dyslipidemia. Fourth one was to investigate the effect of Mazum Davidul wort on inflammatory biomarkers like TNF-alpha, IL-1 beta in a letrozole-induced model of PCOS in rats. To determine the effect of Mazum Davidul wort on lipid peroxidation, antioxidant activity in ovarian tissues of the PCOS rats. Going ahead with these objectives, the methodology was the animals selected were adult female spread-doll rats with the weight of 150 to 180 grams. The model that we have selected for induction of PCOS was letrozole model. This is well-established model giving best results. Letrozole 1 milligram per kg per day oral dose was given along with the fed diet for 30 days for the induction of PCOS. After the PCOS is induced, we confirmed the induction of PCOS by the estrel cycle assessment. After the PCOS was confirmed, randomly we divided the animals, each group having 6 animals. First one was normal control with only chow food. Next group was letrozole with high-fat diet and metformin at 500 milligram per kg dose. Next is letrozole plus high-fat diet plus finasteride at 5 milligram per kg oral dose. Fifth one was letrozole with high-fat diet, Mazum Davidul wort at 250 milligram per kg oral dose. Sixth group was letrozole high-fat diet with Mazum Davidul wort at a 500 milligram per kg dose, and last group was at 1000 milligram per kg dose. The experimental timeline with the induction of PCOS and the treatment. Day 1, as I said, we started with the induction of PCOS with letrozole 1 milligram per kg body weight up to 30 days. After 30 days, we believe that as per the protocol, PCOS is induced which we confirmed by the estrus cycle assessment test. After induction of PCOS on the 31st day, we started with the treatment. As I said, the 7 different treatments, mainly Mazum-Davidul-Ward, along with comparing it with metformin, finasteride. The treatment continued for 30 days. And after 30 days, that is the 60th day, the treatment was also completed, and we first done the physical evaluations, the blood test, the weight test. Then we proceeded with biochemical test, histopathological evaluation, and the ultrastructure evaluations. So initially, body weight and estrus cycle was assessed. What do you mean by estrus cycle is, in the normal rats, there is 4 phases, that is proestrus, estrus, diestrus, metaestrus phase, which goes on continuously. But in the rats with PCOS, the diestrus phase is delayed, and this confirms the induction of PCOS or the presence of PCOS in the rats. And body weight was assessed. Then oral glucose tolerance test was done by giving 2 grams per kg oral dose of glucose in the 12 hours fasting rats. And then we have tested the level of insulin, the level of glucose, and also calculated the HUMA-IR. Then we collected sample by lateral orbital puncture, and we have centrifuged it. Then we determined the hormone and the lipid level. Hormone triglyceride, total cholesterol, HDL, and LDL by semi-automatizer. Then we tried for pro-inflammatory cytokinins, that is TNF-alpha and 1 interleukin 1 beta by ELISA kit, and also antioxidant activity and lipid peroxidation markers, SOD, catalase, reduced glutathione, and monaldehyde by ELISA kit. Then we undergone histopathology and transmission electron microscopy, histopathology by H&E staining, ultra microscopy by transmission electron microscopy. And lastly, statistical analysis was done by in the data. Quickly coming to the results of Mazum-Davidul-Ward on the body weight of PCOS rat on administration of letrozole high-fat diet, we have seen significant raise in the body weight of the rats as compared to the normal control group. But on administration of Mazum-Davidul-Ward, we have seen a dose-dependent effect, that is at 500 and 1000 milligram per kg, we saw significant reduction in the body weight compared to rats which were given only letrozole. Results confirm that Mazum-Davidul-Ward effectively reduces the increase in the body weight which was gained because of PCOS. Next, we confirm the estrus cycle. As I said, these 4 phases are the normal phases of estrus cycle in any rats. In the PCOS animals, the last diestrus phase is delayed and the continuous cycle is distant. Estrus cycle was shown sequentially in the normal control group, but in letrozole and high-fat diet administration disrupts the healthy ovarian function, which results in the prolongation of the diestrus phase, indicated by the large number of leukocytes count. Now, after treatment with Mazum-Davidul-Ward, in the PCOS rats showed a regular pattern in the estrus stages, including proestrus, estrus, metaestrus, and diestrus. These phases are recovering by the treatment of Mazum-Davidul-Ward. The above results suggest that the Mazum-Davidul-Ward normalizes the estrus cycle disruption. Then we saw the effect of Mazum-Davidul-Ward on the weight and the diameter of ovary. When we give the combined administration of letrozole and the high-fat diet, we have seen increase in the ovarian weight, and this might be because of the deposition of number of cystic follicles, also the increase of the thickness of theca cells layer. But dose-dependent reduction in the ovary weight and the diameter was observed by the intervention with Mazum-Davidul-Ward in the group treated as compared to only letrozole treated group. It signifies the restoration in the ovarian morphology. Then we saw the effect of Mazum-Davidul-Ward on blood glucose test. Induction of PCOS causes an elevation in the blood glucose level at all time points as compared to the control or the normal group, indicating abnormal glucose metabolism in the PCOS condition. The area under the curve also shows that the Mazum-Davidson word at 500 and 1000 milligram dose exerts the same effect on the area under the curve of oral glucose tolerance test. The improved in blood glucose results in amelioration of abnormal glucose metabolism in PCOS condition. Then the effect of Mazum-Davidson word on insulin resistance was checked. In the letrozole treated group showed increase in insulin and HUMA insulin. HUMA insulin means it is calculated on the basis of fasting insulin and fasting glucose divided by 22.7, and this both signifies the importance of drug insulin resistance. However, at different doses of Mazum-Davidson word significantly improve insulin resistance by lowering the level of insulin and IR in the letrozole treated group was seen. Then we have evaluated the hormonal levels starting with the LH and the FSH level. PCOS rat exhibited higher level of LH and lower level of FSH compared to the normal group. At no dose, that is 250 grams, Mazum-Davidson, neither the LH level was reduced nor we have seen the restoration in the FSH level. However, at a higher doses of a moderate dose of 500 and higher dose of 1000 milligram per kg, it significantly reduced the LH and increased the FSH level. Then further, we have evaluated as there is hyperandrogenism, the level of testosterone and also the ratio of LH to FSH level. Letrozole hyperdiet group increased the level of plasma testosterone, and also in the previous slide we saw LH is increased, FSH is decreased, means it is disturbing the ratio of LH to FSH. At low dose, that is 250 milligram of Mazum-Davidson word, significantly, we have not seen significant effect in lowering the testosterone level, while at medium to high dose, that is 500 to 1000, we have notably lowered the testosterone levels and also balanced the LH to FSH ratio, which mitigates the hormonal imbalance. Then effect of Mazum-Davidson word on triglyceride and total cholesterol was evaluated. PCOS rat showed increased level of triglyceride and total cholesterol in the serum, but after administration with Mazum-Davidson word, it exerted a dose-dependent effect on the triglyceride and the total cholesterol level. Next, we saw the effect on the low density and the high density lipoprotein. We have seen the level of LDL is raised, level of HDL is reduced in the PCOS rat, which is restored in the dose-dependent manner. And also inflammatory cytokinins were evaluated, TNF-alpha and IL-beta. Reduce these inflammatory cytokinin levels in the PCOS rats, and we have also elevated, which after dose-dependent treatment in the 1000. Then we have evaluated GSS activity, MDL level. GSS activity is elevated, which is reduced by Mazum-Davidson word treatment, and MDL level was increased, which is reduced in the dose-dependent manner with Mazum-Davidson word. These biochemical studies were confirmed by the ovarian morphological evaluation by histopathological studies. In the first normal control group, you can see the corpus luteum, the nucleus, the absence of cyst. There are no cyst follicles, but in the different other groups, that is disease control, metformin, finasteride, and even in Mazum-Davidson at 250 milligram, we see the number of cyst follicles are there. Disruption in the corpus luteum is there. Thickening of the theca cells is there. But at higher doses of 500 milligram, reduction in the cyst follicles is seen. Best results are seen at 1000 milligram per kg, where clear corpus luteum with reduced theca cell thickness and no cystic follicles are there. These studies were confirmed by ovarian ultrastructure. In the normal control group, we can see the nucleus, the mitochondria well defined, but in the disease control, in the metformin, finasteride, and at even up to 500 milligram dose of Mazum-Davidson word, we can see the solving of the mitochondria, the dilation of the rough endoplasmic reticulum, but all these conditions were significantly improved at 1000 milligram dose, where up to subcellular level we can find the improvement in the PCOS condition because of the higher dose of mazumdabidul water. So I conclude by the findings of this study demonstrated potential effect of mazumdabidul wort in ameliorating letrozole hyphae diet induced PCOS in rats. Mazumdabidul wort exerted its therapeutic effect because it is multivariate, improving insulin resistance, hormonal imbalance, lipid metabolism, antioxidant status, and polycystic ovary morphology. All these conditions it is improved. I have published a review article on PCOS, and also this mazumdabidul wort research paper is communicated. Reviews are completed. Soon I am expecting positive outcome. Thank you so much. I'm sorry. Thank you, sir. Yes, please.
You will take any question or comments during that.
I'm sorry, I have to rush just to respect the audience and dignitaries. Yeah, thank you so much.
Thank you so much, Dr. Yogita Goyalji, for the detailed study and the insightful, valuable things. Moving ahead, I would, the next speaker is Dr. Dinesh Mani Tripathi. Dr. Dinesh ji is working as an assistant professor, Institute of Liver and Biliary Sciences, ILBS, Vasant Kunj, New Delhi. Would like to say a few lines about him. He has worked as a postdoctoral researcher at Hepatic Hemodynamic Laboratory, IBI-BAPS, Hospital Clinic de Barcelona, University of Barcelona, Spain, for 8 years. He has specialization in areas of liver physiology and pathology and has published various papers in national and international journals. I would like to invite Dr. Dinesh Mani Tripathi ji for his speech. Thank you so much.
Thank you for a nice introduction. A very good morning, Chairperson and August audience. I'll take this opportunity to talk about the briefly work we have conducted with Unani, the formulation with respect to liver disease. So my previous, as you know, the previous speaker, Dr. Asghar, brief you about that, little bit about the anti-tubercular effect, infectious effect, and the control using the Unani formulations. What I will talk briefly about the hepatoprotective efficacy induced by anti-tubercular drug treatment, that is a hepatotoxic effect, what we see due to the ATT treatment. So I'll take this opportunity on behalf of ILBS. So, consider the time paucity of time, I'm not going to introduce too much about the background, but still just give a glimpse. As we all know, the liver is a hub for detoxification, metabolism, and the immune dysfunctions. So the control in this all the function is respect to different spectrum of liver disease. So what is those spectrum? Those spectrum could be the dietary intervention, fatty liver, cirrhosis, because cirrhosis with the high jaundice, hepatitis due to some viral pathological impact, hepatitis B and C are the common viruses that we found here. And autoimmune hepatitis is also one of the conditions. What we talked about here is drug-induced liver injury, where we take drugs to cure some disease, but that drug do have some side effects. So I will talk about all the impact related to the drug-induced liver injury. So the delay has several mechanisms to induce liver injury. Basically, they are working here. Okay. So formation of toxic metabolites, oxidative stress, mitochondrial dysfunction, inflammatory activation, copper cell stimulation, and cytokine storm. So when the drug acts on the liver for the metabolism, and the metabolism is fail, they try to hit the hepatocytes. And in response to that, there is a necrotic death happened in the hepatocyte. So when the necrotic death happens in the hepatocyte, it starts secreting a lot of dense molecules which affect the other cells, go in the dying property, and they are not going to recover. So somehow this is going to progress in the acute liver injury pattern. So in talking about the delay, overall the Delhi scenario, you will see 46% of Delhi is only induced by the anti-tubercular drug treatment. If we talk about the rest of the other acetaminophen and some other statins and other cholestatic disorders, but 46% it's a very important data we have to consider. The Delhi is having 46% of that drug use impact. And there is a major cause of acute liver failure. When a liver cirrhosis develops, patients who have developed the TB infection, and on top of it, if you are starting the tubercular drug treatment, they have a prognosis of chances to develop the acute liver failure, and that there is no rescue. So, what are the drugs that we use? I think your previous speaker already covered all the things, so I will skip this. So, this all the drugs, isoniazid, rifampicin, pyrazinamide, ethanol, restopramycin, this is standard care of drug for use for the anti-tubercular treatment effect. The mechanism also is clear in the previous slide, so I will skip here. So what we have in hand, what we can do with the patient who have this like really bad. So what we do, we first withdraw the ATT drug. Considering you know that we're not going to treat the ATT, but we have to prevent the liver damage, so we have to stop the drug first. Second, supportive and symptomatic management, adequate nutritional support, avoid alcohol and other toxic agents, modified anti-tubercular regimen. This is the second choice of the management for the ATT. Third, what to do? We supplement something, adjuvant therapy to hepatitis, whatever the injury was induced by ATT, we have to subside those. So what we use silymarin, some other antioxidant, because ATT work mostly with the antioxidant mechanism. So management of severe ATT disease has plus case in acute liver failure, and there is only risk is liver transplant. So this is a very serious complication induced by the drug. So ATT withdrawal alone may result in late, incomplete, and inconsistent hepatic recovery, structural and metabolic damage can persist. Prolonged interruption can produce some treatment failure. Oxidative stress inflammation is one of the major consequences. Limitation conventional ATT management highlighted the need of adjunct representatives. So why we need, that was what I was talking about. So traditional Unani formulation with documentation of some hepatoprotein has been already documented. We wanted to explore that. So which bacterial compound and inflammatory can be supported, and that is the main line of mechanism. Offers complementary strategy along with the ATT management. Can we add something with ATT or can we go beyond on treatment? So with this concept, we have started with the formulation started with the DINAR, and here we joined the hand with the CCRM, with their support, we started this study, and we have started some milestones together. So what we have done, this is the brief introduction, and I think I'm not going to explain all this because you are well aware about it. So what they have action has been reported. They are antibiotic, analgesic, laxative, and refrigerant. So already they were using the therapy. And then 50 windows also has been shown. In some cases, they have good for hepatitis, uterine pain, removal of ascites, ulcerative, visceral pain, abdominal pain. I mean, this molecule, this formulation has certain degree of beneficial effect, which is already documented. So we just try to exploit the beneficial effect to try to recover the ATT induced liver injury. So this student was supported by the CSRM funded project, and she is working on the project, and she is completing her PhD. So what we have done previously, I'm not going to detail all the experimental details, but at least the concept is important. So we have developed the in vitro model system using the cell line, and this is a primary culture system where we have tested the ATT induced impact on the hepatocellular function. And later that what we have done, we treated this all model system, in vitro model system with 2,460 microgram per microliter of the cervidina. We found there is a 30-40% reduction of cirrhosis improved upon treatment with the cervidina. So we have some beneficial effects. Cervidina are not going to show some toxic effect, at least in the in vitro system. So with this lead, we moved directly to the animal model system. We have done some primary cell system, isolated primary hepatocyte directly from the animal. And later what we have done, we have developed animal model of ATT induced. We have randomized these models, and we have developed this. We have to give you focus here. We have taken one group, is a spontaneous regression. Is it trying to mimic the scenario where the patient comes in the clinic, they give the ATT drug, and we say, no, withdraw the drug. Whether this patient is going to improve or not. Per se that we have taken one regulation group, we have not given anything. Another group, we have given this cervidina, 100 per body weight, as a therapeutic window. One we have used the standard molecule, that is the silymarin, normally we use for ATT. And another we have to break, if we start the Shabadidinat at the day one as a substitute along with the ATDL treatment. So this is what we have done. So endpoint analysis, we performed the hemodynamic analysis, some tissue analysis, and some molecular deep analysis. So what we found, as you can see, green versus red line versus orange line. Red line, you can see they are the ATDL vehicle, that one we has a damage. And the regression, where we have seized the drug, but still the damage is persisting. We found that all green lines that is treated with the preventive care. When we started early, the Shabadidinat, we have a very beautiful beneficial effect of those drugs. Later, we found it is a very typical feature of the sarcopenia in the animal, which is induced by ATDL, that was supplemented when we give the preventivist, Shabadidinat, as well as use the therapeutic, in very much close to the standard line of care. Also, we found a very significant reduction in the liver dysfunction, which is induced by ATDL. In all the scenarios, bilirubin also significantly down when we treat with the Shabadidinat. At the tissue level, what we see, there is significant change, inflammatory changes, primarily driven in the periportal area of the liver, which was produced by the ATDL drug, and then the parenchymal necrosis, paracentral damage, and myelocytosis was seen. This all was still persisting in the regression model where we only seized the drug. However, when we treated these two conditions with a preventive and therapeutic line of treatment, we found the very beneficial effect and very close to the cell membrane. So we have some beneficial effect at tissue level as well. What was the mechanism? It's not just we have beneficial effect and all, but there is something rational molecular level, whether we having some changes or not. So we found that the drug metabolism is increased CYP2E1, which was main drug metabolism molecule, it was down regulated. So this is the way they have a protective mechanism of this Shabadidinat, and then was for the increase and the metabolism also increased. So at drug metabolism levels, the molecule that was involved to produce ATDL was suppressed by the Shabadidinat treatment. Second molecule, what we have checked is RIG-K and caspase-3. So as I told you, there's in the TB drug induces a necrotic death. So there is a necrotic marker, RIG-K3, and the caspase-3 was significantly upregulated in both the conditions when treating the drugs. However, we have a very strong beneficial effect in both arms of the Shabadidinat, treating the preventive as a therapeutic and the drug. And then also we check that PAN damage, the DAMP-associated molecular pattern was significantly down-regulated here, CC. So necrotic death as well as the beneficial effect of Shabadidinat was compensated in the DAMP inhibition as well. So, like both of these drugs, they have induced their effect through the oxidative stress. So the marker that was prevented glutathionein synthetase was down-regulated due to delay, and it was inhibited. So this was upregulated with the Shabadidinat. So they have an antioxidant property, and which was also supported with the NRF21 expression, which is serving as well. We also checked the release validated with the supraphytic dismutase activity that was enhanced, and MDS was found to be down-regulated in the Shabadidinat. So antioxidant mechanism of Shabadidinat is very beneficial in terms of the hepatic injury. Further, we checked at tissue level. The vacuum, they have intracellular oxidative was very high in the liver, where we have the treatment with the vehicle and integration models. However, there was some side with the preventive therapy on in person with cell marine. So cellular oxidative was down, the drug metabolism significantly was down regulated on treated with the Shabadidinat. So further, what other effect we can see? So here, DNA damage, mitochondrial genes, and all we have checked. Antifibrotic impact, cytokine strong, and we found there's an anti-inflammatory effect of Shabadidinat is well documented previously, which is we are not new at showing, but we also found this same response in the drug-induced liver disease. And the mechanism of cellular mechanism of the inflammatory cytokines was also significantly down-regulated. So there is an anti-inflammatory, antioxidant property was very well documented, very well obvious here. The last part, what we see, when drug is treated to the animals and they have pronounced periportal fibrosis, you can see here that there are a lot of, in control there is no collagen deposition, or they're very nominal. However, in the ATDL model, we see a lot of collagen deposition just because of the one drug. And this drug is persistently releasing those extracellular matrix deposition, which is later stage can develop to the fibrosis and can actually go to cirrhosis. Those cirrhosis is not well documented, but here we have seen some literature here. So what we found in treatment group, though this is comparatively higher than the preventive arms, with compared to the Selmarin. So Selmarin and preventive arm of the Shabazina is quite similar effect at the tissue level. However, when we develop when the injury was full blown, then we do not have that much good impact, but still that is beneficial in compared to the untreated arms. So with this, I can say that collagen deposition is not only enough. So there are molecular mechanisms we have checked where the fibrogenesis part was upregulated on significantly high. So fibrogenesis is a marker that was portion of the collagen in the extracellular matrix. And also enhancing the fibrinolysis, where the extracellular matrix is getting dissolved. So these two mechanisms balance, they're regaining the balance of that matrix deposition and resolution. So with this mechanism, they are having an anti-fibrotic effect. And that also important. Deposition was also very down-regulated upon the treatment with the Shabazina. So in conclusion, what I want to say that Shabazina has this was further confirmed, validated with a smooth muscle cells marker, and that was found to be down-regulated upon the treatment with Shabazina in other arms in compared to the untreated, which is very close to the Selmarin which we have used as standard drug. Third part, I mean last, not third, but this is the hepatic regeneration, because we all know that liver regenerates in response to injury to recover, to repair their own damages. So this regeneration part was wrongly explained by the in terms of ductular reaction. Ductular reaction is the coloniocyte, they make the hepatocyte in response to injury. So these coloniocytes you can see there was a proliferating near to the criteria where the injury was pronounced. This was a significant regeneration happened upon the Shabazina. This is cotton cyclone, the one who do not understand, but I will try to explain. So coloniocytes generally they are stem cells in the liver, they reside in response to injury, they try to repair and they regenerate new hepatocyte. So these markers are very much pronounced, and there was the pronouncedly activated upon the treatment of Shabazina. So we have some regenerative effect. We see a lot of hepatocyte was found, good healthy hepatocyte was pronounced, was found in periportal zone. And their marker was also down-regulated, which is regulating the damage of this cholestatic injury. So that normally they do a lot of cholestatic injury. So cholestatic injury was also suppressed with the subcutaneous artery patch. This was all the tissue part. I'm just extending a little bit more to the hemodynamic part. So when we talk about the liver injury, liver damage, they raise the portal pressures. What is the portal pressure? So portal pressure is the rise the pressure of the portal vein above the 5 mmHg, which is the ultimate consequences of any liver disease. We found more the portal pressure. So responsible factors of the portal pressure are what? The flow, the blood flow going to the liver, and the resistance, the amount of fibrosis against this flow. So resistance is more because of the fibrosis, and flow is more because of the inflow going to the liver due to the liver damage. So both is contributing what? More of the portal pressure. So this portal pressure is very detrimental. When the liver disease, they start to develop the vessel bleed and the vomiting of the blood and the blood coming in the stool. So this because of the high pressure in the portal area. So we wanted to check whether this drug has some impact on the further complications associated with liver disease or not. So we have checked and we found. So here you can see normal liver, we have a very linear blood flow. However, in cirrhotic liver environment, we have a catastrophic blood supply. So this catastrophic blood supply is leading to cause of the portal hypertension. So we found, and we did the hemodynamic analysis in all these animals, and we found portal pressure was significantly reduced in the treatment group, was very close to the Selmarin. So overall, the systemic mean arterial pressure, the arterial pressure was also improved, the portal pressure was reduced, the intrahepatic resistance, the amount of fibrosis I have shown in the previous slide, that was also validated at the hemodynamic levels as well. So we have very wonderful effect on the systemic and portal hemodynamics using this drug. This is a part, this portal pressure was derived from where? because we found there is significant improvement in the endothelial functionality in the liver. So these are the surrogate marker which is representing the endothelial cell inside the liver was improved. They have significant reduction in the CD31, endothelin 1, and internalized levels of generate. Endothelial cells are regaining their own phenotypic and characteristics. And this is the classical conventional marker when the endothelial cells need to regain the fenestration recovered. So they found that similarly in other molecules. So I'm just concluding here what we have found so far. HIV drug has some impact. Necrotic inflammation, fibrosis, tuberculosis, as explained by previous slides. However, in Unani formulation, Shalbidinol, they are having very good effect. However, in comparison to the untreated and treated with the relief. If we talk about the both arms, what I would like to put more emphasis on start with the preventive arms. When you start with relief, this can supplement along with the TT drug, so you have more large emphasis on the beneficial effect of the Shalbidinol. With this, I would like to thank. This is my team, and I will not for Thank you. Thank you.
Any questions and any comments, any critique? So we are welcome. Most welcome, please. Please.
Work in pipe construction. So I hope you used sugar-free formulation.
I have requested to the committee to provide me the Shalbidinol sugar-free because this has 1.2 kg, 1.2 kg sugar in 1 liter somewhere.
Okay.
So this is
it was sugar-free.
Yeah, no, it's not sugar-free. This was not sugar-free.
So it should be tested.
I have asked.
Again.
I have the committee requested this use
It should be tested with sugar-free.
Yes.
Number one, you did some chemistry of that.
Shalbidinol.
Yes.
Though that was not the scope of the project, but I did.
But without chemistry, it is
because this was very well characterized molecule what we have suggested to use. So, but we have done some chemistry. That's why we are able to find out. Yeah, we have done.
Wonderful one. Thank you very much. One anti-tubercular, sir. It was very good, very exhaustive work. But one thing that overall conclusion was that it is increasing the concentration of INH finally in the blood. That means there is involvement of cytochrome P450.
Yes.
Did you study that?
Yes. In the metabolic profile,
Yeah.
the metabolite which is responsible for CYP450 was downregulated.
Yeah.
And it was actually with the Unani formulation, there was upregulated also. So it is completely preserved.
So what you are thinking? Should we give piperine, the well-known cytochrome P450 modulator, or this?
It is not required. It has been taken care of by the Unani formulation. Indirectly, we have found out in the metabolic.
That is also Unani.
Which one?
Yeah, black pepper is black pepper.
We need to.
What do you prefer for?
In this.
Tabashir
Tabashir should be okay, sir. Because now with our results data.
It's good. Very exhaustive work. Thank you very much for working on this. And then one thing more, in Tabashir, you did metabolomics part also.
Yeah.
But you concentrated mainly on biology part.
Yeah.
If you concentrate on little chemistry of formulation part and see the chemistry of Tabashir and how it is working, that will be very helpful for you.
That is lacking. We haven't concentrated.
So please do that also, sir, if possible. You must be having those serum samples and samples of liver.
Yeah.
And if you can do that, will go in much better impact.
Definitely, sir.
Thank you very much. And that's all.
I have one question, Doctor.
One thing I would add to that Professor Saeed's theory, as he mentioned the paper from the Filpil-Daraz, we call the Piper logger in Unani Filpil-Daraz. Actually, a study was done way back in 60s. Perhaps you know that. Why Dr. Handa, he's a very leisured person. He's no more right now. He has conducted a study on trichurcumin. a compound formulation of Ayurveda having the three drugs, Piper longer, Piper niger, and gingival officinalis, Filkensia, Daraz, and Zanjibili. So in that study, he reported the papery from both tiger and the python longer. It reduced the quantity of ATT, especially the rifampicin, and moreover, the dose of rifampicin, and moreover, the side effect of the ATT. So that's why he's.
Sure. But I somewhere read that it has some cardiotoxicity effect.
Thank you.
Yeah. So I have one from this. May I ask? Yeah. Sir, you have done some metabolomic study. You have shown wonderful data on that. So, how should we conclude there is an impact in cirrhosis using the metabolomics data? Yeah, there are some metabolites, the presence of VIP score, because those metabolites are involved in liver cirrhosis. And those metabolites had a very discriminating higher VIP score in the metabolic data. So, those metabolites are involved in downregulated. Those which are involved in this cirrhosis are downregulated in the presence of this one, this Unani compound. Yeah, but sir, in the clinics scenario, we don't see the patient who have a TB infection, they don't develop cirrhosis. That was the surprising. Actually, it's not documented yet. There are some patients with coming in and ending up with jaundice and those kind of. Yeah, jaundice is fine, but cirrhosis is very late stage. Late stage. But in the TB survivors, this has been important. Those patients after the end of treatment, TB survivors, by almost 30% check the scan or the biopsy if you have something that can. Yeah, there are some data. The status of the cirrhosis there. I'll check.
One my question from, not my question, because the previous person has asked the same question. One of my things, Shavati Dinan, one of the important formulation. And I think you have, which formulation you have taken from which formulary? The composition of Shavata, have you prepared it yourself? No. Or you have taken from?
I have taken from the ministry only. That's also only provided me this formulation. So I believe with the word
about this question. This is the collaborative project with Mumbai, RNO Mumbai. And one of our scientists is involved in this as a co-PI, and they given the formulation. So our work is as a collaborators just to give the formulation to our collaborators.
Okay. One of the wonderful work.
We have the idea.
This is one of the wonderful work, but one my suggestion is there. Because NFLD and fatty liver disease is the most common and prevalent problem. And at least your study will provide a lead for the further study in cases of NFLD and fatty liver. So I suggest that clinical trial must be carried out so that the.
So this is the 3-year project from the preclinical to the clinical part. So when it will come to the clinical, we are involved as a clinical.
And also we are extending to the NFLD part, the same molecule, and we go to sugar-free as I suggested, sugar-free for the NFLD. Because it's going to have. Okay. We believe that will have a good, wonderful impact on that.
Okay, thank you, sir.
I just want to add 2 lines in the Asghar Dastagir lecture. Actually, this study is initiated in 2013 under the guidance of Professor Shakir Jameel sir and Yusuf Amin sir. And we shortlisted 25 anti-TB formulation from the classical text. And then from 25 formulation, we shortlisted 2 formulation, Arge Harabhara and Kurse Tabashir Sarkani. And that presentation was done by under the guidance of NIT Director Swami Swaminathan Madam that time. And Alhamdulillah, we are seeing the fruit of that breed by the Shakir Jameel sir and the Yusuf Amin Sahab. So I acknowledge them by this study, and we are seeking more information about this formulation. Thank you, sir.
Please go ahead.
Well, it was an amazing presentation, all of it. Amazing.
Thank you so much.
I come from the patient's group side. So what I want to tell you all is that it's awesome to listen to such work which is going on, which the citizens in the country don't know, when we tell you that. They don't know. So we have to make sure that they come to know. That's very important.
So we should conduct more meetings to
What meetings? They are having a lot of meetings. Thank God I got invited. Otherwise, I never get invited into these kind of conversations. Good that I came. Good that I came, because it should be done in a much more massive manner. What I only want to comment is, whatever you're doing and what you said, there should be some kind of a dates given. When did you start? What is the timeline? When you're talking about days, first day, 60 days, 30 days, what is that date you talked about? It creates a lot of evidences. We are talking about innovation and evidence. In this whole conversation which we are having, we are talking about evidence. How do you create evidence? You have to give tangible kind of data.
We have shown the tangible data because we have analytics.
Yeah, but what I'm trying to say is, where it happened, which date you started, just now, which madam just now explained.
After 13 years, we are saying that.
Yeah, that's what I'm saying. But don't get scared. Never get scared in your life. Jo dar gaya, wo mar gaya.
Yeah, true.
You see, what you have to understand is, we have to talk the truth. And when you talk the truth and when there is transparency in your work, you get credibility. And in order to get credibility, we have to ensure that we are transparent. So give the dates, even if it is long, it's taking time, doesn't matter.
Yes.
Nothing happens, Rome was not built in a day. So we all have to build that. So that was my only comment. I thought I must share it with you. Thank you.
Mr. Supervise.
Thank you, madam. You are choosing one of the, I think, emerging causes of the PO study. And this is one of this area of the view also. But I am just asking for, you are using this drug for your preparation or for procure from market?
It has been again sent by CCR.
So I have a same question like Saeed. Why are you using the sugar clear this?
Actually,
because you have shown the one of the your criteria regarding
glucose, rise in the glucose is one of the parameters.
One parameter.
That is actually a good suggestion from your side again. But the formulation, it is not prepared at our end. It is taken from Hyderabad.
I mean, future internal just because capsules are available in the market.
Actually,
yourself,
actually, sir, initially I purchased.
One more thing I'm just suggesting. I have seen this your parameter. Each and every parameter have a very good significant effects and a single drug. And most of the one of the teachers are here. We are suggesting there's a lot of drugs, not only margins, there is for even the PO study. There's the other for preparation also. And it's only one preparation.
No, actually, I am working on 3 preparations. But today,
but I'm not agreeing for your result because you have seen all these results. It's mostly significant like LH and obvious segregation. Everything is. I don't understand. One more thing, you have not used any toxicological study of this in this parameter.
No, it's ongoing, sir. Actually, I have received the project 1 year back, and regarding the results you are saying, in many places we saw that only 1000 milligram is giving good results, not 250 and 500 dose. In some places, it is little significant, and in 1 or 2 studies, non-significant for both the doses. So this was what we actually got in the lab, to be very transparent. And
I'm not.
No, means this was what we saw in our lab, which we are reporting.
Your input is very good.
Yes.
Give it in writing.
Sometimes
give it in writing.
You have also worked in that, and
yes.
There's a lot of some toxicological effect of magnesium because it's not only for using the 3-4 drugs.
No, it is having number of polyherbal formulations. Yes.
Main content of this.
Yes, it is.
Sugar, this is the issue.
Basically, no. Sugar, if you remove sugar from it, becomes new formulation.
Yeah.
And if you use you with the sugar, once you get it sugar free, it is new formulation and you have to do all the studies.
Again.
So that is why we don't go for sugar.
We will discuss on the chai पे sugar भी होगी और
One of
भी होगी चाय पे चर्चा करेंगे. We are running short of time.
By this one carry a message I can have. Thank you.
Thank you so much, everyone, for this wonderful discussion. I request all the chairpersons to kindly come on the dais for the felicitation.
आइए, please.
Also, all the speakers, Dr. V.N. Asghar Dastagir sir, Dr. Yogita Goel, Dr. Dinesh Mani Tripathi ji, and the chairs, Madam Amina Haidan ji, Professor Dr. Mohammad Idris ji, Dr. Zaki Ahmed Siddiqui ji, and I also invite Dr. Yunis Iftikhar Munshi sir, Deputy Director General CCRUM and in charge RRIUM, Silchar. सभी के लिए हम एक बार जोरदार तालियां बजाएंगे और I request Munshi sir to felicitate all the chairs. Madam Amina Al Haidan, Chairperson, Lotus Holistic Health Center.
मैडम जी दिलाते हैं ठीक नहीं इधर आइए पहले किसका नहीं पहले तो स्पीकर्स पहले फर्स्ट ऑफ ऑल स्पीकर्स नंबर 2
Okay, so I will request Idris sir. I request Idris sir to felicitate Dastagir sir. I request Professor Dr. Idris sir to felicitate Dr. V.N. Asghar Dastagir.
Please, come over. आइए साहब आप भी आ जाइए प्लीज
See the roast on Valentine's Day.
Valentine's Day, very auspicious day, the Mahashivaratri. So please have a blessing from the please come from the blessing. Thank you very much.
I request Dr. Siddiqui sir to felicitate Dastagir sir. Dr. Dastagir. Thank you very much. And now I request Dr. Munshi ji to felicitate our chairs.
First, she is Aditi Devo Bhava.
Madam Amina Al Haidan, Chairperson, Lotus Holistic Health Center Institute, Abu Dhabi, UAE. कल जिनके साथ हमने इंटरनेशनल MOU भी एक्सचेंज किया है. Thank you very much. I request to felicitate Professor Dr. Mohammad Idris ji, former Principal and Dean Ayurvedic and Unani Tibbiya College and Hospital, Karol Bagh, New Delhi. Thank you very much. And I request Dr. Munshi ji to felicitate Dr. Zaki Ahmed Siddiqui ji, Deputy Director and in charge Regional Research Institute of Unani Medicine, Kharghar, Navi Mumbai. Sure, sir, sure.
Very good Sunday morning to all of you and wishing all the best for very auspicious year today, the Shiv Mahashivara. So in this first session of today, we have 4 very renowned and very enthusiastic and very knowledgeable presentation. These four presentations based on the preclinical studies. And all the studies have been funded by the CCI. And they have done marvelous. Sir, he's right, sir. Amazing. Very good outcomes within the stipulated durations. All these studies cover very few English. This very important thing, one mentioning thing which I'm telling you. All four studies cover the 5 Unani pharmacopoeial formulations. They are used for the last many centuries. We have ample empirical evidence mentioned in our class. But now the need of the hour is just to have evidence-based study. So they have presented the evidence generated after the doing a lot of work. These all four externally used formulations ignited some early response from the audience. They were right by saying they contain some sugar based. So you are right, Sir Anwar and other fellows from council. So this is a very contentious issue. Either we use the sugar or not sugar, and though we have taken some steps to get some sugar free. I'm a student of Unani pharmacology. I consider the sugar is not so sensitive issue. If diabetic person needs some calories, some carbohydrates, suppose we are taking the Javarish, Majune Davidul Bird or Javarish or Sharvate Dina, we are taking 5 grams, out of which 3 grams of sugar. 3 grams created hardly 150 calories. So we are not so sensitive regarding the sugar. अरे भाई उसको कुछ कैलोरीज भी तो चाहिए डायबिटिक को, तो इतना सेंसिटिव नहीं होना है कि 1 चम्मच अगर उसने या दिन में 2 चम्मच माजून दबीदुल खा ली तो इंसुलिन स्पाइक कर गया. ऐसा नहीं है, हम लोग कुछ ज्यादा ही हो रहे हैं. एक बार 1 बजे हम एक तो ये कहते हैं कि वी ट्रीट नॉट द डिजीज ऑफ पेशेंट और एवरी पेशेंट डिफर फ्रॉम अदर पर्सन. तो ऐसा नहीं है कि किसी की मेटाबॉलिज्म जो है बिल्कुल यूनिवर्सल हो, ऐसा तो इतना ज्यादा सेंसिटिव हमें होने की जरूरत भी नहीं है. नंबर 1, दिस इज द माय कॉन्सेप्ट. The other, the legal problem, when you discard the sugar, any pharmacopoeial formulation that becomes a new formulation as per the Drugs and Cosmetic Act, that does not allow to use as pharmacopoeia. That is very difficult to study or to understand a new product. So please think over it. It's very simple to say sugar को निकाल के और क्यों नहीं देते. अरे बाबा इसमें लीगल प्रॉब्लम है इसके अंदर कि हमें एक न्यू ड्रग बन जाएगी माजून दबीदुल बर्द को. मैडम ने काम किया PCOS के ऊपर. अगर हम अगर इसके अंदर से शुगर निकाल दें फिर ये माजून दबीदुल बर्द नहीं रहेगी, फिर एक न्यू यूनानी फार्मूलेशन होगा और इसके ऊपर फिर हमें इसके ऊपर पूरी प्री क्लिनिकल टॉक्सिकोलॉजी सारा स्टडी करना पड़ेगा असरे नौ. तो इसका भी ख्याल रखना है कि ये सारा इतना आसान नहीं है, इसको भी समझना. तो ये बहुत अच्छी स्टडी हुई है और ये इन्होंने बहुत अच्छे काम किया है. सर ने बहुत अच्छा बोला. ही इज रिप्रेजेंटिंग फ्रॉम द अदर साइड बोले तो पेशेंट. हम लोग सारा काम पेशेंट के लिए कर रहे हैं. काउंसिल हमारी गवर्नमेंट फंडेड है, पब्लिक के लिए कर रहे हैं, तो इसकी पब्लिसिटी भी होना चाहिए. इट वुड हैव बीन बेटर कि हमें मीडिया के लोगों को भी यहाँ बुलाना चाहिए, उनको भी यहाँ बिठाना चाहिए और उनको बताना चाहिए, क्योंकि जो डिजीज कवर हुई है दैट्स वेरी कॉमन. फॉर एग्जांपल tuberculosis, we have set the goal which was given us by the WHO and UN. Now the UN is also involved in health problems. Yes, as you know that. So the WHO given the India the target to 2025 just to eliminate the tuberculosis from India. निकल गया, 1.5 महीना हो गया, पूरा 1.5 महीना हो गया। अब हमने नया सेट किया है 2030. We will definitely, inshallah, we will eliminate the tuberculosis from India. This is our plan. तो अब इसके लिए क्या हो रहा है, बेटाक्यूलिन का आ गया है, बेटाक्यूलिन को फैंसी क्योंकि रिफेंसी रेजिस्टेंस हो गया है, एंटी माइक्रोबियल रेजिस्टेंस बहुत एटीटी से बढ़ गया है, तो बेटाक्यूलिन जो है वो अब चूंकि उसका ऑफ हो गया है, उसका पेटेंट ऑफ हो गया है, तो उसको हम कर रहे हैं और अभी आईसीएमआर की स्टडी चल रही है। तो उनके साथ वी आर नॉट रिप्लेसिंग एटीटी, प्लीज रिमेंबर, वी आर सब्स्टिट्यूट, वी आर कॉम्प्लीमेंट एंड देन एडजुवेंट। जो एटीटी चल रहा है उसके साथ हम चलाएंगे, जो डॉक्टर साहब ने बताया, साथ में ऊपर से तबाशीर संतानी और प्लस अर्के हरा भरा, और डॉक्टर साहब अभी कर रहे हैं शरबत दीनार के ऊपर। तो एडजुवेंट थेरेपी हम क्या करेंगे कि उसके एटीटी के की ड्यूरेशन भी कम हो सकती है, उसके साइड इफेक्ट भी कम हो सकते हैं, और जैसे आपने बताया कि लिवर हेल्थ के लिए या आपने जो स्क्रीन के बारे में जो उसके अंदर होगा। बहुत बहुत आपका धन्यवाद, और ये बहुत अच्छा लगा। इसके बाद टी का दावत आ गई है अभी आप सबके लिए, तो इसके बाद वी विल ज्वाइन द टी एंड वी विल डिस्कस ओवर द टी विद मिल्क एंड शुगर। थैंक यू।
Before that, we will have a group photo for chair, co-chair, and all the speakers of this session. May I request everyone kindly to come on the stage for a group photo. और बाकी सभी को मैं रिक्वेस्ट करूंगी कि you can all proceed for the tea. It is 11:48 and we will be back at 11:58. Thank you so much for your cooperation.
फोटोग्राफ्स उनके पास फोटोग्राफ
किसके पास?
वो भी थे, उनको भी बोल देता हूँ आपसे
दे दीजिए, अभी चाहिए ना, मीडिया में जाना है।
वो भी थे ना इधर भी फोटो निकल, देखो वो सेक्शन में रहेंगे इधर, वो देखो बाहर खड़े, वो देखो टीचर में बाहर खड़े हो। हाँ सर, कहाँ है सर? डोर के इधर खड़े हो।
गुड मॉर्निंग। हाथ लगते हैं। कल से हम क्लास में नहीं आए कहीं नजर नहीं बड़ा बहन के साथ डॉक्टर नादिम एक और आप भी आ जाओ, अभी जा रहे जय आप भी हो जाते हैं, अभी आए थे निकल जाता है।
अच्छा सर, आ गए,
आइए यार
थैंक यू। अरे आपने अच्छा
Instead of tubercular sizes,
आपका नाम एक्चुअल में सिर्फ देखिए टाइमिंग का मैच नहीं होता है, 3 जगह चलता है। अगर यहाँ का चालू है तो मैं आपको मालूम पड़ेगा कि नीचे वाला भी अगर चालू हम देने वाले हैं।
ये तो सबसे बोल के आई हूँ, सबका चाहिए बेटा।
नहीं समझे आप, सबका तो चाहिए पर 3 आदमी नहीं,
एक ही बंदा है।
एक ही बंदा है, वही मैं बोल रहा हूँ। ऐसा करना
सारे में सेशन एक जगह का देखिए, आपको हर जगह जाना पड़ेगा।
हाँ
किस पे दे रहे हैं?
क्यों नहीं दे रहे? क्या करूं?
मैं आपसे फोन पे जा रही हूँ, फोन
मैं इसमें ले लीजिए, आप अपने फोन में ले लीजिए, मैं कॉपी कर देता हूँ।
कैसे करेंगे? कार्ड
है ना, कार्ड रीडर दे
उस पे दे दीजिए।
नहीं, इसमें कर देता हूँ, एक बना दीजिए।
मैं सेशन में फोटो
जी
देखता हूँ। पेन ड्राइव दूँ?
वो फोटोग्राफ चिपकाते हैं, तो वो दूसरी
सब कर दूँ या कल वाली भी कर दूँ? या आज की अभी की कर दूँ बस, जैसा आप बोलना चाहते हो।
कल वाली तो हमारे पास आ गई ना?
आ गई।
आपने तो दी थी या किसने दी थी? क्या नाम है आपका? ये बहुत ज्यादा होगी। कितना नहीं तो कल की बात कहाँ कर सारे उसके ऊपर से जो है
पहली बार कॉपी करवा, कल थे दूसरे बातें ना।
आज मैं प्रेजेंटेशन होगा, मैं अपना मोबाइल दूंगा, मेरे को अरे इसी से
Good afternoon, everyone. To invite with respect Professor S.J.B. Bokhari sir, Professor and HOD Department of Physiology, Government Nizamia Tibbiya College, Hyderabad. A warm welcome, sir. जोरदार तालियों के साथ हम सर का स्वागत करेंगे. I request you to kindly take a seat. I would like to invite Professor Irfan Ahmed ji, Professor and Head Department of Mahiyatul Amraz, State Unani Medical College. Hearty welcome, sir. And as a chair, I would like to invite Professor Bijon Misraji, Chairman Core Group of Experts for Insurance Coverage in AYUSH sector. जोरदार तालियों के साथ हम सभी चेयर्स का स्वागत करेंगे. A very warm welcome. And speakers for this session are Dr. Sheikh Nikhat Parveen ji, Professor Iram S. Rao, Dr. Jyoti Kode, Professor Asiya Sultana, and Dr. Sangeeta Trot. So first, I would like to invite Dr. Sangeeta Trot, Dean Research and Innovation, ITM Business School, Skill University. इनका टॉपिक बहुत ही इंटरेस्टिंग है. Her topic is online gaming addiction and mental health, the role of parental resilience and parental control, जो मेरे ख्याल से घर घर का सवाल है. And I would like to say a few lines about Dr. Sangeeta Trot. She is a professor in marketing and dean research and innovation at ITM Business School, Navi Mumbai. She has more than 22 years of experience in teaching and research. Dr. Sangeeta is postdoctorate in commerce and management from Indian Council of Social Science Research, New Delhi. जोरदार तालियों के साथ हम स्वागत करते हैं डॉक्टर संगीता ट्रोट.
Thank you very much for the warm introduction. And very good morning, in fact, good afternoon to respected chairpersons here, the very own audience. And before I begin, I would like to thank Dr. Nikhat, who has invited me today to deliver a session related to the project which we have just completed. And what I'm going to speak about is not Unani. Okay? The first session, I think, which was a pre-session, was a power-packed session, and I would like to take what Sir already said, that lot of awareness is needed in the field of Unani. And I come from the belief that nothing works in watertight compartments. Everything can be collaborated. There can be a lot of interdisciplinary research and to the society. So with this motive, I would like to share one of the projects which we did with Academy of Marketing Science, USA, which is the topmost marketing organization in the field of management. And it was a funded project. So I would like to share what I have done. It will have no Unani in it, but the basic objective of sharing it, we want to expand, we want to collaborate, we want to go beyond management to understand how we can link it with Unani. Right? So with this, I would like to start. So the topic of study which we did was online gaming addiction and mental health. The role of parental resilience and parenting styles. I can see a lot of students sitting here, and we all are aware that children, especially children and young adults, in fact, students are a lot into gaming. Right? So, This online gaming addiction is a part of internet addiction, and it has been declared by International Classification of Diseases as one of the disease. So it needs to be taken care of. It has been a part. Can I request to change your slide, please? Slide for us. So to move forward with, we should understand what is a gaming disorder. So we understand what is a gaming disorder. It has been classified under International Classification of Diseases as a pattern of gaming behavior, where we lose control with regards to gaming, where all our other activities just come to a stop because we are glued to the screen. Anybody here? This addiction has also spread even to senior citizens, have also spread even to working people, and is most probably found among children and young adults. So anybody here, before I go to the next slide, would like to confess that I am an addict? Yes? Which nobody will do, I think, because even if we are glued to the screen and trying to forego our daily activities, we are an addict. Right? So this applies to internet addiction, this applies to mobile addiction, this applies even to gaming addiction. Right? So to go ahead further. When I say online gaming addiction, it was very well brought under Sustainability Development Goals. Even Sustainability Development Goals, which we are aiming at 2030 also, are looking forward for treatment to online gaming addicts, because if this is not treated, our future generation is at stake. So that is why this online gaming addiction, which has been classified under International Classification of Diseases, has also been brought forward as a concern under Sustainability Development Goals. You can see the Sustainability Development Goal, that SDG 3, SDG 4, SDG 11, SDG 8, are very well related to this gaming addiction. Right? So to go ahead further now. If we take it further and understand it from a health perspective, the World Health Organization has also laid a lot of concerns when it comes to gaming addiction, because it somewhere affects the mental health. So if you talk about anxiety, if you talk about depression, if you talk about social exclusion, and if you talk about sleep disturbances, which teenagers, which young adults, and these patterns are also found among, the young people as well as in senior citizens, can be dated back to some type of addiction. So this was a study which we did in the year 2020, when we were all, surrounded by only one word, that was COVID. And addiction was very high that time among children and young adults. And online gaming addiction affected the mental health among children and young adults. So this was a study which was carried out in 2020, and which I would like to skip the internet addiction. The data is pretty old because this was a presentation already done. Now in 2025, internet addiction is picking up more than any other addiction. The reason being because when you play games, you get rewards. You get rewards, and that is where you don't like to connect to the offline community. You don't like to, you exclude yourself. And this is very happening with our own children, with the young adults. They don't want to indulge in physical games. They don't want to be a part of the society. They want to just engage virtually with friends and playing games. And that is where a lot of mental problems happen, anxiety, social exclusion. This is what these are the different problems that have connected, right? So to go ahead further, we wanted to study online gaming addiction and mental health and understanding the role of parents. And then you have got free parenting style. Where the parent takes a back seat and the entire control, the entire decisions are taken by the parents. So we wanted to understand how these two constructs have an important role to play between the gaming addiction and the mental health of the children. So these are the different parenting style, which is authoritative, which is high control and high warmth. We have authoritarian, which is high control and low warmth. We've got permissive, which is low control and high warmth. And then neglectful, not bothered. Let the child do whatever the child wants to do. These were some of the styles. Now, the study is not a clinical study, to be very frank. It is outside the scope of what Unani has been doing. But this is an initially funded study, and now what we are looking for is a collaboration to conduct a clinical study to understand whether Unani can be of help in controlling the addiction and reducing the mental health problems. This is what we are looking at. So that time the study was conducted with three important objectives, that is to understand the role of parental resilience. What are the different types of resilience? And we wish to examine the pervasiveness of online gaming addiction. How, with parenting styles, you can control the gaming addiction. So these were the objectives. Going ahead further, so this study was divided into two phases, wherein we found very limited study has been done in this particular area. And the first part was a literature review, wherein we studied 50 research articles which were highly cited in the field of online gaming addiction and the parenting styles which were there. And the second, we did some qualitative, in-depth interviews with parents to understand what do they do to control this addiction and how is it having an impact on the mental health. So what I would like to share is the outcome of the study. Each interview lasted at least for 45 minutes to 1 hour. And the first question which we asked was, is your child an addict? Any guesses on the answers which we got? We interviewed around about 25 parents. And out of 25 parents, the first question which we asked was, is your child an addict? Out of 25, there were 20 parents who said, my child is not addicted. That was the first answer which we got. So, for a parent to understand that their child is addicted, they don't want to hear the word addicted. Then we went further down, probing how many hours does your child play games? So that was the time, COVID time. One major answer which we were, करने को है क्या? दिन भर मोबाइल पकड़ के गेम्स में ही रहते हैं. तो दिन भर मोबाइल पकड़ के गेम्स में रहते हैं तो एडिक्ट कैसे नहीं है? एडिक्ट कैसे नहीं? But they denied from the parents कि मेरा बच्चा एडिक्टेड नहीं, लेकिन मालूम है दिन भर गेम्स में बैठे रहना है. So then that is how we went indirectly probing, and finally we understood. Since the child is in games, so friends se milna nahi mangta hai. He does not want to indulge in any type of, social development. The child does not want, all the time negative thoughts keep on probing in the child. We understood that there is some mental health problem with the child. So we interviewed the parents separately. We interviewed.
Dr. Sangeeta, you will have to be faster.
Yeah, just finishing, sir. This is the last one. The last part is they understood that the child was also mentally addicted and suffering from certain type of problems. Right? So coming almost to the end, this was the paper which we published. This paper got published in Addictive Behaviors, which is Scopus Index Q1 Journal. There's already a second publication in line, which is in the management. It is ABDC Journal A-RANK, which is already in progress. So this is the study, which was a funded study done in the year 2020. And now what we want is the potential collaboration. We understand that Unani lays a lot of emphasis on mental health. So we are wanting to collaborate, and we intend to collaborate on these lines. How Unani can assist the parents in taking control of the situation, how Unani can promote mental development among young adults, and how Unani therapy can help us in achieving the sustainable development goals. And we know, because we come from the theory, nothing in this world is in watertight compartments, and all can be brought together to protect the people, the planet, and the society. So let us join together to contribute to the wellness of the society. So these are the implications. By doing research, by collaborating, this is what we are going to get. And we look for publications in reputed journals. Thank you very much for patiently listening to something which was not Unani. But we hope that we can work together for the well-being of the society. Thank you very much.
Stay on. So anybody's got any questions to ask quickly, you can ask now. Anybody? No?
Questions are what Unani doctors can do.
It's an open question, sir.
Please go ahead. Give her the mic, please.
So thank you, ma'am, first of all, to come here and to join us and giving a very new opportunity to work as a Unani physician. And now I request to CCRUM hierarchy is the responsible for the projects daily. So we need this type of project in collaboration. And Sangeeta ma'am soon will sign the MOU also. Just because of this, she's working on the mental health and the AI. So we need the help from the CCRUM. We're seeking help from the CCRUM to initiate the funding to do such kind of project and to such kind of publication which will be beneficial to the society.
So,
thank you.
My only message to you is that whenever you make any proposal,
right,
you have to make sure that it is made very tangible and it is measurable in terms of your outcome.
Yeah.
So please focus on the methodology, which is very important.
Yes.
Because what you presented, I would just don't take it as a criticism.
No, that's fine.
It's a suggestion.
Yeah.
You have to understand how do you do statistical significance in terms of who you reach out to, how you reach out to, and also understanding that those questions which you will frame, how those questions needs to be framed. So I'm sure there are competent people in Unani, council who look into your proposal, and they'll definitely help you if your proposal is in the right direction.
Thank you so much, sir. Thank you.
Yes, please, please, please. Please use the mic. Doctor.
This is the greater and very large portion of the addiction. This is already been mentioned by the
Your mic.
WHO. It has become a disease. I'm a teacher. I have been the teacher. My voice reaches to the last rank. So there is no problem. I have no need any microphone. Perhaps you know the last month Australia banned the use of smartphone under 16. Perhaps you know that? Yes. The new young people.
We are all under 16.
And that's followed by the France, Britain, and so many countries. Perhaps India is also considering just to ban this menace. What the background behind this? 2 साल पहले in the year precisely 2024, a book written by the Jonathan Heads. He was written this. He wrote this book very on this topic. The title of this popular book is The Anxious Generation. The Anxious Generation. When the book read by the Anthony Albanese, you know He's the Prime Minister of Australia.
Doctor Sahab, you've got many more speakers now.
नहीं मैं एक बात बता दूं इंडियन कॉन्टेस्ट आ रहा है एक मिनट के लिए जब ये किताब उन्होंने पढ़ी तो उन्होंने उसको बैन लगाया जब फ्रेंच में इसका एडिशन हुआ तो उन्होंने इसको अंडर 15 कर दिया एक साल का और उसके बाद फिर ब्रिटेन ने किया अब हम दुआ कर रहे हैं ये कि कब इसका हिंदी और मराठी एडिशन आए सो दैट इंडिया में बैन हो जाए इस तरह का जो मैडम ने प्रपोज किया थैंक यू वेरी मच
So let's give a big round of applause to Dr. Sangeeta for the lovely presentation. Next speaker, please.
Thank you so much. As Dr. Sangeeta is leaving, मैं आपसे विनती करती हूँ कृपया आप मंच पर आ जाए और मैं I would like to request Professor Irfan Ahmed ji to please come here and felicitate Dr. Sangeeta. We are having the second session of the day, Advancement in Nutrition, Dietetics and Lifestyle Management in Unani Medicine. Thank you so much. And our next speaker is Dr. Nikhat Sheikh. She is a scientist level 3 at Regional Research Institute of Unani Medicine, RRIUM, Mumbai, under the Central Council for Research in Unani Medicine, CCRUM, Ministry of AYUSH, Government of India. She is actively involved in clinical and translational research with a special focus on mental health, neurodevelopmental disorders, and lifestyle diseases. And her topic is Unani Ahar in tuberculosis management. So, ladies and gentlemen, please welcome Dr. Nikhat Sheikh with a good round of applause.
Thank you. Respected dignitaries on the dais, respected chairpersons and beloved teachers and students, Assalamu alaikum and very good morning to all. Thank you for giving me an opportunity. I'll just briefly go through the Unani Ahar and how it's important. Slide show, please. So my topic for today's presentation is Unani Ahar and it's important as an adjuvant, as a fundamental therapy, how we can do in tuberculosis management. Basically, this work is going on in council to publish the Ahar and we are working on that. With that help of the officers from council, I made this presentation. So this is the just a first slide showing the Ahar and I'll show you how Unani classical texts elaborated the Ahar or Ilaj Wala Ghaza. As you know the definition of tuberculosis, I won't go in detail, we have the shortage of time. But I just want to say now that tuberculosis is not just an infection, it's a beyond the infection. And especially, you may say that TB is strongly associated with the malnourishment. Or it's a vicious cycle which is associated with each other. Malnourishment causes the tuberculosis causes the malnourishment. So this is the nutrition is just not an adjunct. Now there's a fundamental therapy even in the modern era. And this is the publication showing the vicious cycle of malnourishment and tuberculosis association. Even the ICMR published the diet recommendation, how the tuberculosis patient can take in daily basis. Unani scholars knows the tuberculosis fundamental concept, what the synonyms of SIL, which is emaciation in classical text, did as a low-grade fever. I won't go into detail. This is the Unani fundamentals. So now the foundation of Unani Ghaza or the Ahar, the primary and the fundamental goal is to restore the strength, preserve the tissues, and support the innate healing mechanism through Ghaza. And even scientific evidences also shows about that TB patients have increased caloric need by the 20 to 30% during their treatment. And nutritional support improves the treatment outcome and reduces the mortality. Unani diet principles is clearly mentioned in classical text as a Gizilative, Rosacasive, कमियत के एतबार से, based on the quantity, based on the quality. So these are the classical texts full with the evidence-based fundamentals of eligible ghiza. Unani fundamentals also clear in classical texts about the supporting the role of milk in the management of tuberculosis, especially donkey's milk, goat milk, and they show now the modern scientific research shows that it has the immunoglobulin activity to enhance the immunity, to protect the liver. So these are the published data which is available on the internet just to show the evidence. I'm showing how the Unani said before thousands of years to take the goat milk and the donkey's milk. This is the some published data of immunological properties of donkey's milk, and I given the references. This is also the property of, this is published data in the Scopus, which showing the goat milk supplementation. Unani classical text or Unani Hukma also suggested the milk-based preparation in the to enhance the immunity, especially Kheer, Firni, and Hariras. Lots of preparations are mentioned in the classical text, and you see the references which show the milk-based proportions are increasing the immunity, to enhance the immunity, to enhance the strength, to protect the liver. This is the Ibn Sina's reference, which in his canon of medicine, recommendation of rose-based preparation, which called the Golkand in Unani, and for the treatment of pulmonary tuberculosis. This is the published in PubMed, and he advises consumption until a total intake of approximately 45 kilogram was reached. And I think Unani physician heard this story that a TB के patient को Ibn Sina ने Golkand से treat किया था. So this is the references for the rose-based preparation. And if you see the publications also, it might be the hikmat behind the Golkand is the tabreed or tartib, the basic usul ilaj of the Unani system to manage the tuberculosis. And this is the dates, honey, and barley water references are available to enhance the immunity, to protect the liver. So this is the ahar mentioned in classical text also. This is the role of animal source food in nutrition to support the immunity, you may say, in tuberculosis management, especially fish, chicken, bird's flesh, and barley water with fish. These all terms mentioned in the classical text, which are nowadays we can say non-vegetarian diet or the animal source food in the classical text, and we have the references to why we have to use the animal source food in the tuberculosis management. Now this is the important slide which is showing my exhausted literature on the crab mentioned in the classical text to manage the tuberculosis, and just want to say one line about it, that I did the literature survey, that ICMR project of tuberculosis, and I searched the 25 formulations for management of tuberculosis from the reputed classical text, and each formulation contained the crab. Even Kurze Tabashir Sardani having is a one ingredient of crab. And it was very difficult for us to counsel the NIRD to include the animal source medicine in our things, and we have the references from the marine line. We got the publication to show the immunity property, to enhance the liver protective, and even classical text shows crab soup, crab in their diet as an immunomodulator, and we have the publication for that for references. So these are some table which showing the high energy diet, micronutrient, along with the Unani, how we diet, how we can manage a tuberculosis patient with their breakfast, with mid-morning diet, lunch, evening, and dinner. So you may refer to the WHO document also, and along with the Unani, we can integrate a patient diet in daily routine. So conclusion for my presentation: strengthening nutrition is not optional, now it's essential. Unani dietary intervention play a crucial role in supporting tuberculosis management by enhancing the immunity, promoting the recovery, and preventing the relapse. There is immense scope to integrate Unani dietary principles with existing TB program as a nutritional adjuvant, especially in undernourished population or malnourished population, or you may say the severe cases of tuberculosis. And integration will provide a comprehensive, holistic approach of TB to care, addressing both nutritional and therapeutic needs of patient. So my way forward for this presentation or this conference, we need a rigorous clinical validation to support this claim. we have to be formed. I'm looking to Council to form some standardized dietary protocol along with the WHO guidelines and the Unani principles. And we need the integration under AYUSH TB program. We have initiated our Council's officers, Dr. Tamanna Nazli, Dr. Shaista Aruj, Dr. Ghazala Javed, and Dr. Farad is all working on the TB AHAR at headquarters, and they are coordinating this program. So these are the basic references to support the nutrition for this vicious cycle of tuberculosis with malnourishment and tuberculosis. And I thank you, the DGCCRM, thank you, the nodal, my in charge, Dr. Zaki MSL, to support me, Dr. Ghazala Javed ma'am, to make this presentation fruitful. Thank you very much.
Thank you very much. Thank
you.
Within time, just stay on, we'll take the questions right away. Yeah, please. No.
So actually,
Can somebody give him the mic, please?
Yeah, I have.
so it has been shown that cattle do have the TB infection as well. So how wise to take the cattle milk use as a dietary intervention for
So that's a pasteurized milk. And now there is many ways to...
percent of the patient who have the extra pulmonary manifestation have a tuberculosis, that's well. So can we replace with a plant-based milk product like soy milk and all? Can we include
Now,
it?
this is a good scope to do the study. But there is only this presentation shows how classical text shows about the Unani Ahar. But there is definitely a scope to replace. We cannot replace the natural thing. We can, you may say, the innovate, or we can do the researches, or we can be modified according to the latest criteria.
May I add something? I want to add something.
Yeah, question.
Yeah. Actually, I'm not asking any question. I just want to add upon whatever she said and what he was asking. It's very relevant question because that is very true that bovine tuberculosis do exist, and there are always chances of contamination. But then there are ways to get that milk free from contamination and then raising awareness about that. So not only for tuberculosis, otherwise also it is very much needed to raise awareness regarding how the milk is consumed. This is one thing. But now in present era, present situation, where is the milk? Where is dairy? Dairy exists anywhere? No. Our lifestyle has dramatically changed, and finding dairy product is beyond almost impossible. So what he was saying that plant-based protein, plant-based milk, like sort of thing. So it is also an option, but plants are not plants again. These are just sitting here, we must be telling that pharmacognostic criteria doesn't qualify the drugs for having those kind of phytochemicals that we're supposed to have earlier. So that is a question remained for debate, and we can find possible ways for that.
Thank you. Thank you.
Problem regarding the donkeys, where?
Okay, thank you.
What classical text says actually.
Okay, Dr. Nikhat, one thing just wanted to tell us, as Saga has just asked the question, that it's not the only tuberculosis now we have. It is other than the pulmonary tuberculosis, we have that like urogenital tuberculosis is the most commonest cause now presently. So in this case, our that is what you are finding. And one more thing is, as per Unani concept, we have to take the fresh milk. But as of now, that's the present modern day, they say that it should be pasteurized. So what is your saying?
Sorry, I didn't get for the neonatal tuberculosis.
No. Any other tuberculosis and the role of this milk and the nutrition in tuberculosis.
So basically, it's a research question, and of course, it's that's why I told it's a way forward to have some validation claims, and we need such type of studies to claim this, to prove this claim how it's working. This is just a presentation which showing what classical text saying about the management AHAR in tuberculosis. Personally, I don't have any research work on that, of course. But what the references that even I given the reference to back my statement about the Q1, Q2 level publication, which shows the immunomodulation, properties of this milk and the gulkan and the dates and berry. We need from the Unani approaches such type of studies, and this is the way forward for us as a council person also.
Basically speaking, it is the Unani concept only which says that we should concentrate on the eligible Ghaza.
Exactly.
The first one is the concept, our concept is eligible Ghaza is the first. Later it is, finally it is the eligible Ghaza.
Yes.
We have to go, because Gulkhan, she has mentioned, it is having a very important activity in this one.
Yes.
Okay. So milk is also mentioned here, and the number of, not only this one, Unani concept, even the Ayurvedic concept says the same thing.
Yes.
So,
just one.
You can also add the Maulaham.
Yes.
Yeah, madam.
10 have been passed.
Yes.
Dr. Nikal, you have done extensive research. One question: have you found any reference of camel milk? Is the immunomodulity effect? Because literature says that the camel milk is very good immunomodulator.
Yes. So when I'm searching the literature of classical texts, there is as such not found the camel milk references for the tuberculosis chapter. Might be in the other chapter they recommended, but for the tuberculosis, especially when I search the literature, I didn't find, might be it's my lacking. I'll definitely go to the extensive research and the literature search. So thank you for coming.
Yeah, good. Thank you very much. Thanks a lot. Let's give her a big round of applause. Yeah.
Oh, 1 minute.
Yeah. Assalamualaikum. Thank you for the presentation. And he spoke about camel milk. We have Dr. Fatin Khorshid. I will give you her number and also email because she did very, very good research in not camel milk, in the urine milk. And she have already she did the urine milk in the capsules, And this is, you can go for very good research with her together. And it's really very good results you have. Yeah, I will share with you all.
Thank you for your reference. I just want to add one thing. We have the next speaker of Dr. Jyoti Kode, ma'am. Even she did some camel milk research on that. And she will more talk about the camel milk from the Tata Cancer Center. So we initially talk about the camel milk, but not under the topic of the tuberculosis, but for the cancer actually. So might be she will deliver a talk on that. Thank you very much. Thank you.
Thanks a lot. Thanks a lot.
Thank you so much, Dr. Nekarchik, for a wonderful presentation. Our next speaker is Dr. Iram S. Rao. He's a professor in Department of Food Technology at Bhaskaracharya College of Applied Sciences, University of Delhi, and has more than 31 years of teaching and research experience. She has been instrumental in establishing National Institute of Food Technology, Entrepreneur Management, and Apex Institute of Excellence under the Ministry of Food Processing Industries, India. So please welcome her with a good round of applause. And her topic is Unani Ahar, Bridging Traditional Wisdom and Modern Nutrition Science with Talbina Products. Over to Professor Iram S. Rao.
Good afternoon, everybody, and good afternoon, the chair and the jury members. I wish to start by thanking Ministry of AYUSH, CCRU, for giving me this opportunity to present this small work. Let me tell you that this is not a research endeavor. As mentioned, that I come from Department of Food Technology. We have taken up this project sponsored by CCRUM to bring about Unani products for common man's use. So that's the background, what I'm talking about over here. So if you see that we're looking at bridging the gap between traditional wisdom, of course, all of you are the masters of the craft and you know very well that what Unani can do. And I think time has come to have a Unani Ahar as well. I'm trying to connect this with the food science. What does the modern nutritional science talk about it and how can science validate this? So if you look at the modern day crisis, and of course, this adage is common to all of you, that Hippocrates said this long ago, that let food be thy medicine and medicine thy be food. And I think even today, in these particular times, it has been tested time and again. Nutrition science is also first coming to diet therapy, as mentioned by our jury members over here, that it is first food which can prevent the occurrence of any disease. And with that kind of a background, if you look at it, all the public health concerns today, as we talk about, are actually non-communicable, and that's simply because of two factors. Yes, the food, you got it right, but the second one is your lifestyle. All of us have become very sedentary. Our previous speaker, the first one, spoke about how mental health can be related to that also. So lack of physical activity, you may be the person eating just the right food, but if you've not worked around, if you've not mobilized, then what's going to happen? It will never be bioavailable to your system. And today there is science which is talking about your gut-brain axis. So eventually what's going to happen, it's not going to work for your system and it's going to backfire, and that's what today India is sitting on an epidemic of overweight and obesity. More than 30% school children are already overweight and obese, and we know that we're already not just the diabetic capital, but we are also heading in cancer, unfortunately. So there is an urgent need to look at this kind of an integrative approach, and as you can see over here, that can we have this holistic system which is based on the Unani system of wisdom for such a long time. And today, as a food scientist, what can we do to bridge this particular gap? And you can see that this is a time-tested formula. We know time and again, and we've seen so much of research which, if not cures completely, it has a very, very preventive kind of a thing. Scientifically, it's been validated with the information, and today we know that how Unani focuses on food, minimally processed food, unprocessed foods, and similarly today we are talking about that what's been over classification of ultra-processed food is creating havoc not just in our country but world over. And then the thrust is that how can we have foods which are just very minimally processed. Let me underline, you cannot have a food which is unprocessed. You can't eat paddy directly, you can't have wheat directly. You need that some little primary processing, and the thrust has to be always on value addition. So that's where the science and the technology can actually tie up together and solve these major problems which both India as well as the world today is facing. So what is this Unani medicine? I don't have to explain this much. You understand that this is based on the four humors, and that's what my nutrition science also says that, you've got to understand the mechanism. You have to understand the physiology, and then only as a guiding principle can you allocate diets. And that's why today we are talking about what is called as personalized nutrition. It is never one size fits all, and that's why perhaps we have gone wrong. So once you've understood the four humors, which is dam, soda, balgam, and safra, you would have at least some leeway how to get started with. The second one, which is very, very important, and I found this, that the essential pre-requirements or prerequisites, which is primarily based on Asabe Sitta Zaruria and psychology. So when you eat food, it is not just for sustenance and nourishment. Let me remind you that it is also for satisfaction and for psychological satisfaction, and that's why you find that comes on the top of the pyramid over there. Your food is related to your gut health. And there is a vagus nerve which is connecting your brain, and that is why when you have a food which you have grown up eating, a typical recipe which your mom probably served you, that kicks off that kind of a feeling of exhilaration, and you feel ecstatic, you feel very happy. So that's what we have to choose food very wisely, and time and again if you're taking these convenient foods, you find they all taste alike. They all have the same kind of textures, and that is why your gut is also not happy at the end of the day. Movement and energy, that's what we have emphasized, that without physical activity, you're no good. And that's where we are talking about that waste management, gut health. Today we are talking about probiotics, prebiotics, postbiotics. Why? Because your gut-friendly bacteria has completely diminished, and that is why it is so important. But with that, is it all play and no work makes Jack a dull boy? Absolutely. Rest and relaxation is even more pertinent, and you need to. Today, the psychologists say that idling around, lazing around is also very important for your mental health, and that's what we are talking about, rest and the circadian rhythm. We find youngsters not sleeping in the night, but in the daytime. Does it change anything? Absolutely. Your biological clock changes, and that is why going to sleep with a mobile phone, even if I'm not addicted, is not a good thing to do. You're supposed to keep it outside the room so that it doesn't sleep, disturb your sleep cycles. Nutrition and hydration, more is said about it, and of course, air quality. So I think it was the prophetic wisdom, and I reiterate that both do not waste water and the air quality has been even more pertinent today as we are talking about the UN SDG goals. Everything which you eat could be very healthy, but you understand that how many of us who stay in Delhi are dependent on air purifiers as well. So if your environment is polluted, that is also being absorbed by osmosis in your body and has an effect. This is something which everybody sitting in this room, I'm sure, is very well versed with, that food primary function is giving you nourishment. It helps you with your physical energy levels and, of course, sustenance. But can we think of those foods which will also work as Ghazai? And I think the youngsters of today have to go back to their kitchens to understand that kalonji, saunf, ajwain, zira have had these, very, very pertinent therapeutic values, and they have been incorporated not just in the Unani medicine, but even today we are talking about that how small quantities can help you combat simple problems which are related to acidity. And like in the Islamic literature, it is reported that Nigella seeds, which is kalonji, if you have that, it is a cure for everything but death and aging. So can we replace your zira tarka with kalonji as a one kind of a step to make sure that how foods can possess medicinal properties? Dawai Ghazai, these are notable medicinals which can be also taken, and we know that a lot of herbs and a lot of condiments. In the previous talk, I was hearing that how pepperine, which is the active component of pepper, is used to cure some of the biggest maladies like cancers, etc. in the world. And drug, of course, as dawa, which is going to be having a therapeutic effect. So coming to the four pillars, let's say, of personalized nutrition, which is based on visage, are sanguine, phlegmatic, choleric, and melancholic. I think you all know this very well, that it depends on what kind of a temperament do you have, and based on that, you're going to design the particular foods which we are looking for. I just need to emphasize this, that if I look at Unani literature, what it focuses on is recommendation of cooling and moistening food for those people who've got a lot of heat in their body, and that is typically a hypertensive patient. You find that food science emphasizes on the DASH diet, which is dietary approaches to stop hypertension, and that's nothing but just having a balanced diet, including a lot of fruits, vegetables, whole grains, nuts, oilseeds, and cereals, and that is going to be rich in fiber, certainly helping those people with hypertension with a lot of potassium, and that's how it can help in actually reducing your blood pressure. I've given those quoted studies over there that where all these trials have been conducted, and there's where I find synergy between Unani and the modern nutrition science. Similarly, with diabetes, you know that you require fiber-rich foods. Typical examples which I've suggested are barley and fenugreek. You also have jamun, which is also rich in the same thing. And we find that they simply do two things: scavenge off all the toxic constituents and hypoglycemias from the body, and that's how they have a lower glycemic index, and you can manage your diabetes pretty well out there. The third one, if you look at the respiratory health disorders, and there you find that this is being talked about in terms of sarcopenia. So such people have to be given a diet which is going to be anti-inflammatory, high in protein foods, and this is going to relieve them with omega-3 supplementation, as well as enough amount of proteins which are nutrient dense so that they can be taken care of in their the COPD patients. Holistic prevention is the key. So, of course, while you have the right balance of diet, hydration, physical activity, the big question which arises today, and I find that the fast-moving articles out there are large portions. You have big burger and you have a king-size burger. What are we doing? We're eating with our eyes, going and snatching that, And that's where the dilemma is, that you need to exercise what is called as moderation and mindful eating. And you've got to go according to your body type and your temperament. Whole food should be the focus, and of course, digestion is the key. Whatever you're eating is something which your body should be able to break it down, assimilate it, and then supply the classic nutrients for your survival, sustenance, and better performance. So what is the call for action in this case? I would suggest the research community to invest in robust mechanistic and clinical studies, elucidate biochemical pathways of Unani dietary principles. Further research on humoral balance and food qualities is required. I find that there has to be more robust science, publications and very good high index papers and high citations is what is the need of the hour. You also have, of course, there are a lot of them, but there's still need to kind of connect the two sciences together. For healthcare systems, we must have integrative models, and our prior speakers have mentioned that. You should complement conventional treatment with Unani holistic strategies. Create a comprehensive and sustainable healthcare paradigm under AYUSH. And what about us as individuals? We will say, look at the policymaker, look at the regulatory body. No, this is where you need to understand and begin empowering yourself with this knowledge. And this has to be implemented in each one of our lives. Assess your life through the 6 essential factors. Choose foods that are both Ghaza and Ghazai divide. And I just gave some examples. Another example like honey, it is anti-inflammatory. Curcumin, badam, etc. And people have talked about laban, milk of various varieties. Also, goat milk has got excellent buffering capacity. So I know all of you understand what is Talbina. I know all of you understand what is Talbina. I don't have to explain this to this particular fraternity, but it highlights what is supposed to be a nutrient-dense food. What is anti-inflammatory? How is it beneficial to your gut microbiota? And that has been reported by the Professor as a nutritional powerhouse. And why did we select barley? Because of all these exclusive reasons. Can you see that? It is rich in fiber. Now the question is which fiber? Fiber can be crude fiber, fish and thrown out of the body, not making any physiological difference. But soluble fiber enters your bloodstream, scavenges the blood of all the toxic constituents, whether it's cholesterol, whether it's circulating levels of sugar, etc. And that's why we find that beta-glucan is a game changer over here. It has all the essential micronutrients. So when I look at foods, particularly cereals and coarse cereals, once you process them, all the B complex is not there. In this case, you have a rich source of B complex vitamins. In addition to that, you have magnesium, manganese, phosphorus, zinc, and selenium and iron. Remember, today selenium has been underlined as one of those trace elements. That's were administered 100 milligrams per day, and we found that the TSH level declined. And also the oxidative stress was also looked into it. Why we looked into these products were because there is no specific commercially available Talbina products, particularly when the convenience comes into play. Of course, there are sporadic incidences of where the powder is available. These are the products which we worked with, so I'm going to come straight to the pictorial part of it. We made instant dalia, and a mixed vegetable dalia, which had the goodness of the high fiber, beta-glucan, low NGI, and there was no added fat to that. This was actually designed for the elderly and people who would. This is not moving forward. Please, next slide. Just 2 slides. I'm concluding. Just the product names.
Go back and come.
Great. These are the flakes with 2 flavors. One is lychee.
This is known as jugar.
Absolutely, sir. Absolutely. So when nothing moves forward, take a step back. That's what. Right. So Talbina flakes were designed with lychee and chocolate flavors. And why? Because children do not want a typical porridge, which is greaky. And of course, the youngsters sitting over here also would kind of reckon with me. So low GI, high fiber, gluten-free. Of course, you would say that, barley has some amount of traces of gluten, but that is all. And no added fat. Okay, jugar has to be done again. Okay, and this is where I've done a comparison with the conventional cornflakes. You can see that the high fiber is there, hardly any fat is there, but high sugar is very high over there with the other products. For our products, it was hardly 1 gram to be added. It was replicated like chocolate flakes, very, very popular with children. So that is why this was designed. Similarly, this was also compared with the others. I've highlighted over here that it had higher amount of dietary fiber, 3 times higher than cornflakes and wheat flakes. Just one. Okay. So this is where, and the last is the Talbina cookies, and this is what I wanted to thank CCRN for the funding. What we gained was nutritional superiority, gut-friendly formulation, validity of stability. What we at now is commercial scale-up, and thereafter clinical trials before it can be commercialized and launched in the market. With that, it's a bit thank you so much for.
You can now breathe. And you listen, you be there, be there. There are some questions from anybody?
Questions, yes.
No? My only thing is you must define medicine and food. What is food and what is medicine? It's very important. Okay? Because I come from the food side. I was a member of the Food Safety Authority when it got founded in 2018. So I was there. My only message to all your scientists is you have to understand the daily dietary habits of the citizens and then go with that as a recommendation.
Right.
You know, like when you talk about milk, for example, now my wife has been recommended not to have milk other than soya, but it's so expensive. I have to sell my assets to get that. So what you have to understand is how much affordable you can make. And that is very important.
Absolutely.
Because when the Food Safety Authority was built on only one sentence, making wholesome meal accessible to all.
Correct.
Okay. And we have to adhere by standard because that's the first thing consumers look for is standard. Iska koi मानक है कि नहीं? Is there a standard? Standard is very important.
Yes, sir.
But if you make certain standard, like I have attended more than 20 Codex Alimentarius Commission meetings all over the world. What did we do there? We were trying to harmonize the standard of the world. Okay, but they didn't want to accept vegetarian, non-vegetarian labeling when we talked about GMO labeling and things like that. Now, but India has taken the leadership. So we have to take certain leadership in terms of dietary habits around the world where Unani can play a role. So this is what I want you to say.
Right.
Yeah, next speakers. Thank you. Big round of applause, please. Big round of applause.
Thank you so much for your lectures that for Talbina, this is prophetic medicine. And thank you because for prophetic medicine Talbina ولا ينطق عن الهوى إنما هو يوحى وحي يوحى. What you are doing, thank you that you are giving evidence base of to take Talbina and the benefit of Talbina. Yeah. This is good.
Very good.
Thank you.
One question.
Okay, thank you. Please.
Thank you so much, Professor Iramas Rao. Moving ahead, we have our next speaker, Dr. Jyoti Anand Kode. She holds expertise in the field of tumor immunology, stem cells, and cancer. She recently superannuated from Advanced Center of Treatment, Research and Education in Cancer, that is ACTREC, Tata Memorial Center, India, as a principal investigator and senior scientist at the Kode Lab, Tumor Immunology and Immunotherapy Group. She has contributed significantly towards understanding role of immune cells, soluble plasma immune markers in cancer diagnostics, prognostics, and stem cell immunobiology, transplant immunology, and regenerative medicine. So please welcome her with a good round of applause, Dr. Jyoti Kode. Her topic is edible fruit juice curbs tumor growth in preclinical cancer. Dr. Jyoti Kode.
Good afternoon, but my voice is bad. But the data is excellent, so you can bear with me. So I want to thank Dr. Nikran for want to thank Dr. Nikita because she has got me into this field, I can say. For a long time, we've been working on camel milk and camel urine. So if I just take 1 minute, generally like cow urine also, it is supportive, so it will not kill cancer because it is actually regenerative medicine. Directly it will not kill, but once you take in the physiological system, it will show anti-cancer activity and immunomodulatory. So earlier time there was not much funding, so that's why that work got delayed. But I think Dr. Amina, you can take this ahead and that can be tested, camel milk and camel urine. Okay, sorry. So here we have been working on a lot of formulations, AYUSH herbal formulation, chemical compounds, and one of the yeah, 15. No, okay, so we go directly to the work. So go to the conclusions. Huh? Okay, so this is a metastasis. What generally we are going to talk about cancer. So in the body, I don't know this one. Oh, sorry. Oh God. I'm sorry. So, cancer cells spread to the different parts of the body. This is just this thing, beginning that when they start, they have to invade. Okay, so this is one step where compounds have to act. Then they go into circulation, where circulatory cells have got special profiles. So whether it can be acted, these circulatory cells can be checked, and then they go and lodge somewhere. So at different points, then any compounds has to act. Okay. So I think we will not talk about much. This is a kokum fruit juice. So there has been some earlier and plant-based compounds. So this is a fruit juice which we have studied, and it has got some lot of phytochemicals. So mainly antimicrobial activity, anti-cancer activities, immunomodulatory activities. We have checked. We have checked it doesn't harm immune cells in immunotoxicity assays. This is just an entire protocol. You need not go. We'll go over every test actually. So antimicrobial, in vitro testing, in vivo testing, and immunomodulatory testing. This is, I think, standard chemical HPLC formula for the fresh fruit juice. It shows anti-biofilm formation. See, because every inflammation starts with a bacterial growth. So it has got an antibacterial activity. Here you can see that, this is a oral cancer cell line which was developed in our own lab. So this cell line, you can see the GI juice is actually killing at such a low level as 7% or 5%. And this is a standard adriamycin. You can see the cell migration is halted again at 5%. Means fresh fruit juice, which is say 100%, it's a 5% is also showing anti-cancer cell migration stopping. Similarly, so we have one inflammasome assay standardized. So whatever inflammation they have tried to code, so there is one LPS NRI juice is showing equivalent activity. These are toxic compounds, cytarabine and adriamycin is showing equivalent activity. These are toxic compounds, cytarabine and adriamycin. Here, this is the one that's, so you can see compared to control, they activated those markers. You can see are activated. You can see are activated. Cytarabine, in fact, actually causes trouble. You can see nicely curbing of inflammation. Just the cell inflammation. Just the cell cycle, it shows that apoptosis is induced, cell cycle is arrested. This is apoptosis arrested. This is apoptosis, another method. What we have to see in that right side column, the cells undergo apoptosis. This is another cell line, oral cancer cell line. We had liver cancer also, liver cancer and cervical cancer cell line. So here we show that it doesn't affect immune cells. It affecting cancer cells, but it is not changing the metabolic activity of healthy immune cells. This is another one good assay where we want to show that immune cells go kill the tumor target cells. So we say that the compound, it may not act directly on the, say like cow urine directly because it is supportive, but it will activate immune cells and kill cancer cells. This is what the methodology is. Now here we show that NK cells, if you must have these are natural killer and innate immunity cells. So these cells go down when you do the activation, inflammation activation, NK cell activity goes down. But you can see that cytarabine has not changed. This is a standard chemotherapy drug, but GI juice we can say the NK cell activity is nicely regenerated again. So this is how even same test can be done for these things. Here we show that mucosal immunity is activated. Now we want to show, okay, whatever I am taking, drug, juice, inside goes, it will kill cancer, but not harm immune cells, or it will support mucosal immunity. So these are the cells, CD3, CD4 cells that are supported. You see perforin granzyme means effector immune function is supported. Here you can see the mate cells. Mate cells are mucosal immune cells. Mucosal immune cells are supported, with these GI juice. So this is same another percentage. Now we've just taken, these are the last few slides where we shown in vivo activity of the same GI juice, colon cancer in few models. So here you can just in short I'll explain similar images you will see. This is a tumor bearing control, and this is the middle one is actually GI juice. It is not showing change in adriamycin, you can see change in body weight, and also it is showing toxicity in survival, but GI juice is not. And here you can see that in the 6 mice how the GI juice is. So statistically significant, you can see this colon cancer study. There is a activity appreciated by NIH FDA standard protocols. Now this is again oral cancer model. Similarly, you can see, 2 mice didn't show, many mice 4 show, but if you go by statistical significance, again it is showing statistical. Plus this will not have side effects like, adriamycin. So this is another breast cancer xenograft. Again, 4 mice had a good activity, 2 didn't. Similar, another method. So here we have looked at cytokines in mice sera of these efficacy treated. You can see that it acts through interleukin 6, chemokine, or interferon gamma. Another method we can see transcriptome of those residual tumor environment. So only this GI juice had shown activity, not adriamycin. Same way immune response genes. And we also have methodology where we show that inflammasome associated markers. They show the formulation. This is, you can call it herbal formulation because it's just a direct fresh juice, which can be, so you can, I don't know, you can call it sherbate kokam or something.
Due respect to you and your study, very nice presentation. It was a scientific presentation. One thing I just want to add that as per ICMR guidelines, the objectives of any study should not be more than 2. Because 2, 3 studies I have seen, they have mentioned the objectives more than 3, it is not acceptable. As per ICMR guidelines, I'm looking to. And to your study, what it shows that is it a probiotic activity, anti-cancerous, or it is increasing the immunity? That is what I mean, a paradox to understand.
Okay, first main objective is anti-cancer activity. Okay, now if it is anti-cancer, adriamycin and all those standard drugs show cardiotoxicity, immunotoxicity, immunosuppression. So we also, because I am from immunology division, we also show that it is immunomodulator. It is not harming immune cells. It is supporting immune cells also, immune cell function also, immune cell anti-cancer activity function also. Regarding gut microbiome, we can be doing
Modulator or anti-cancerous?
It is both. It is having both activity. In fact, all AYUSH compounds, they will, you will say, I'm eating palak, spinach, or say ginger, zingiber. It's a dietary compound. It doesn't harm otherwise. But when when we say it is anti-cancer, I did include, I have got another similar slides for gingiber extract. Beautiful data for pancreatic cancer. So it is the same, controlling inflammation and LRP pathway, but at the same time, it is not harming immune cells.
No, what Dr. Sam had to tell you is that you have to be very focused in terms of that study. So the objective should be only 1 or 2, not more than that. That's number 1. Okay. Now, that normally the objectives are very people like you who come and concentrate on one. Try to be very focused. Try to be very focused in terms of what is their objective in terms of the outcome you want to bring out of that paper, scientific paper. You can't make it very elaborate.
So we just got 4 papers published recently. Same anti-cancer and through inflammasome. So it is acting through inflammasome pathway. You will learn mechanism. So that is the mechanism part. Main objective, as you say, is anti-cancer. Now I want to going to connect with Dr. Mani, Dr. Goel for anti-fibrotic activity, which right now it is not ready. Maybe it is ready in next conference. Yeah.
Yeah, you keep your space alive, keep running because we want you to run.
So I can tell you in Savantwadi, Sindhudurga, this is a regular diet. After spicy food, we always take this kokum juice, made it in a coconut milk and take it. So the concentration you will see just 1%. So we take 1 spoon, make it in a vessel and then drink it.
लेकिन आपका voice कितने improve कर दिया? There is a modulation. that goes to show,
There's a lot of female going on in our institute and building also.
Wonderful. Any questions? Any questions from anybody? Because the lunch is getting cold.
She is a collaborator from Tata Institute.
Yeah.
And yesterday we signed the MOU with ma'am, and just because of her hard working, we got the initiatives of this MOU with Tata.
Very good.
And she is the main source to integrate Tata Active Center.
Very good.
And we are working with her the oral cancer with Munzich muscle therapy.
Wonderful.
So inshallah, soon in the next Unani fair we'll present the data.
Wonderful.
Thank you.
Wonderful. Big round of applause. Big round of applause. Please.
I would like to add something.
Please.
From the FSSI, since you belong, you have referred, but yourself.
But not more than one sentence. One sentence.
One sentence में नहीं बोल सकते.
Because lunch is getting cold.
Actually, FSSI का representative, he would have been here as a participant. Unfortunately, he couldn't have due to some reason. I don't know.
Anyway, you got a former member sitting here from sports.
They take very important information. FSSI ने notification किया, perhaps you know the Ayurveda आहार.
Yes.
आयुर्वेद आहार आपको पता है?
Yes.
नहीं, आप तो सर एक्सपर्ट हैं. मैं ऑडियंस से मुखातिब हूँ, आपसे नहीं. मैं बच्चे खास तौर से ये आयुर्वेद आहार का नोटिफिकेशन 2022 में हुआ. उसमें मैं इंपॉर्टेंट बताऊं, उसके अंदर ये प्रॉब्लम आई कि व्हाई आयुर्वेद आहार, व्हाई नॉट यूनानी आहार, व्हाई नॉट सोबारिफा, व्हाई नॉट होम्योपैथी में तो नहीं है कोई, सिद्धा वीकर, हाँ आयुर्वेद सिद्धा. तो यूनानी पीपल ने ऑब्जेक्शन रेज किया फ्रॉम डिफरेंट प्लेटफॉर्म, डिफरेंट एनजीओ कि आपने आयुर्वेद आहार को नोटिफाई किया है, आपने यूनानी को क्यों नहीं किया? इसके पीछे एक वैलिड रीजन था. 21 फॉर्म ऑफ आयुर्वेदा प्रोडक्ट को दिया है. यहाँ पे हमारे मोहसिन दहलवी साहब हैं, ही इज रिनाउंड ड्रग मैन्युफैक्चरर यूनानी मेडिसिन. तो उसके अंदर 2 ऐसे यूनानी के फॉर्म थी जो सब ऐड किया है. गुलकंद जो अभी प्रेजेंटेशन में था, Q1 एंटी ट्यूबरकुलोसिस के अंदर मैडम निगत ने किया, और दूसरा मुरब्बा. ये दोनों नाम एक पर्शियन में एक अरबिक में है, और इवन उन्होंने जो अथॉरिटेटिव बुक्स दिए सर, उसके अंदर यूनानी का रेफरेंस नहीं गया. तो जो ऑब्जेक्शन इज वैलिड. जब ये मिनिस्ट्री में ये गया तो मिनिस्ट्री हैज कॉन्स्टिट्यूटेड कमेटी फॉर कॉन्स्टिट्यूशन composition of Ayurveda, not Ayurveda Ahar, but the AYUSH Ahar.
Yes.
In that committee, I am the member of that committee recently. NIA and India Institute of Ayurveda, both great institution of Ayurveda, have been selected as the nodal agency. उसमें अब ये है जो आप देखेंगे, अप्रिशिएट करेंगे जो हमारे मिनिस्टर साहब ने कल बोला. अब आयुष आहार को हम थाली बनाएंगे, आयुष थाली, और यू विल गेट इट फ्रॉम IRCTC. ट्रेन में बैठेंगे तो वहां मेनू में आपको आयुष थाली मिलेगी. किसी कैफेटेरिया में बैठेंगे, यू विल गेट द आयुष थाली. इवन यू विल गेट इट व्हेन यू आर ट्रैवलिंग ऑन आकाश. जमीन से लेकर आकाश तक जाएंगे हम, जो हमारा प्लेन में भी जाएंगे तो वहां पे जो मेनू आता है ना प्लेन के अंदर, यू विल गेट द थाली. ये नॉर्मल आदमी के लिए होगा और डिजीज वाइज भी होगा, टेम्परामेंट वाइज भी होगा. ये टर्म्स ऑफ रेफरेंस है कमेटी का. थैंक यू
very much, sir.
Excellent.
Thank you so much. We are talking so much about food before lunchtime. Yeah, but there is one important presentation. Dr. Asiya Sultana, may I invite you on the stage? She's Professor, Department Ilaj with Tajweed, Ajmal Khan Tipiya College, Aligarh, Muslim University, Aligarh, with over 26 years of experience in teaching, clinical practice, and research. Her research focuses on the holistic management of lifestyle disorders, and she has published over 90 research papers and has delivered over 100 lectures. So over to you, Professor Asiya Sultana.
5 minutes.
Yes, sir. Yes, sir. And I, first of all, a very good afternoon to all of you. And with the permission of the chair, I want to start my presentation. And to begin with, nothing as can be as difficult as being the last speaker of the session, because everyone is looking forward to move out of the hall for the food and yes, yes. And it has been my humble submission to the organizers after congratulating them for accommodating this very important session on diet in a very relevant time. My submission is if you make any change in the schedule, that please let the speaker know about the change in the sequence of the deliberation.
Yes. Very important. Very
yes.
important.
So my topic is on the millet-based dietary interventions, a meta-analysis of metabolic signaling and glucose modulation. So as I say that talking on diet can never be as relevant as this present time. As a very famous wisdom, Indian wisdom says that Hitabuk, Mitabuk, Ritabuk, Chaya Sada Swas. Those who eat wholesome food in proper quantity and as per the season, they stay healthy. So this is also the Unani wisdom, as Hippocrates once asked, what should be the quality of food? My request to the audience that since this is the last session, my last lecture, but I hope that you are very much scientifically oriented, that you will definitely try to listen. So in this session, so the what are the qualities of good food? Then Hippocrates replied that good food must have 3 qualities. Number 1 is it should be traditional. Number 2, it should be seasonal, and number 3, it should be local.
Right.
So if you go and see every science, all kind of science related to food encompasses and gets enveloped in these 3 things: local, seasonal, and traditional. India is facing a nutrition transition where the traditional food is being very rapidly changing with high calorie, ultra processed, calorie dense, and empty calories. Everybody knows that lifestyle is changing very fastly in the name of modernization and urbanization. So I chose this topic on dietary intervention and why dietary interventions are very much relevant because of 3 things. Number 1 is India is sharing the maximum burden of lifestyle disorders, be it diabetes, pre-diabetes, hypertension, obesity, non-alcoholic fatty liver disease, cardiovascular disorders, and so on. And all the disease goes hand in hand. So India is bearing the maximum burden of these lifestyle disorders. So dietary interventions very carefully designed and then working on and then finding solution for a culinary diverse country like India is very much important, because the data derived from the Western world cannot be directly applied to the Indian population. That is why clinical trials on dietary intervention are very much relevant. Number 2 is very unfortunate that when Indians are thin fat phenotype, that is Indian get metabolic diseases, even slightly deranged metabolic BMI, basal metabolic rate is slightly deranged, that Indians can have all kind of metabolic diseases because of their phenotype, and very younger age, and at very they are prone and susceptible for truncal obesity. Agar koi insan upar se niche mota hai, then it is not very much threatening if the obesity is only on the truncal area. pear-shaped obesity is very threatening and it's a red flag. So Indians are prone to it. And that drug also signifies and underscores the importance of dietary intervention. And third is undernutrition. हम हमेशा से गरीब मुल्क रहे हैं. We are yes sir. Next slide please.
I thought you were going without the slides. Go ahead. Go ahead.
So the global metabolic crisis, impaired glucose tolerance and type 2 diseases are major contributors to global morbidity and mortality. Chronic hyperglycemia increases the risk of cardiovascular diseases, nephropathy, neuropathy, retinopathy, and many other indirect complications. Dietary modifications remains a major strategy in prevention and management of these metabolic disorders, and that is why Indian government in 2023 declares as the millet awareness, International Year for Millet Awareness on the recommendation of the Honorable Prime Minister to WHO. 2023 was declared as the International Year for Millet Mission and Millet Awareness. So, consumed for centuries, why this study on millet? Because it is consumed for centuries in India and Africa with recognized health benefits. Rich in fiber, starch, amino acids, and phenolic compounds. Phenolic compounds are very much important food components helping in slowing the glucose absorption and leading to sudden very few glucose excursions and improving insulin sensitivity. Clinical evidence scattered across small trials requiring systemic analysis. When I thought of doing a meta-analysis on this, I could find very little clinical trials and dietary interventions along with millet, and that too were having very less effect size. So the studies were not very much comprehensive. So I found very difficult to draw inclusion criteria. So I chose studies between 2020. So last 15 years, all the data were scattered. Individual studies show promise, but vary in results and have a small sample size. Clinical uncertainty, healthcare providers need quantitative synthesis to guide dietary recommendations, and then ultimately policy impact for the public domain. Systemic evidence supports inclusion in dietary strategies for metabolic disorders. And also very important because, as Ma'am was saying, if someone is denied of the food which he or she has been brought up on and then traditionally used to it, is very difficult. And that is why millets were very much part of our cultural practice. And Indians are very much accustomed with eating roti. So millet can be an answer to all those requirements and the present necessity. The objective of the study is to systematically evaluate the quantitatively synthesized evidence from randomized and controlled clinical trials, assessing the effects of millet-based dietary interventions on glycemic parameters and lipid profile in adults with impaired glucose regulation. And this is our privilege that traditional medicine, other than having side effects, they have side benefits. So apart from getting the dietary regulation, glucose control, they are very much rich in calcium and protein and iron. So it could be included in the midday meal program or Garbhavati Mahila Yojana to address the deficiency of iron, protein, and without giving medicine which may have adverse effect in first trimester and second trimester of pregnancy or school-going children at tender age. So the study selection was Prisma framework, screening, remove duplicates and perform targeted screening, then eligibility, access full text articles for inclusion criteria, identification of database search across 4 databases, inclusion finalized studies for qualitative and quantitative synthesis, So systemic search conducted following PRISMA guidelines across PubMed, Scopus, Web of Science, and Cochrane Central Database. Search items included millet types. So there are several millets, pearl millet, finger millet, barnyard millet, and many others. So millet item was also very important to find and to take into consideration glycemic control markers and metabolic outcomes. So eligibility criteria included the study design, randomized controlled trials for controlled clinical trials only, population adults with impaired glucose, regulation of type 2 diabetes, intervention, millet-based dietary intervention with companion group and outcomes mean standard deviation values of glycemic or lipid parameters reported. These were the criteria that we included a study for our systemic analysis. Here I would like to mention one thing that Dr. Said is sitting here. He was supporting that RCT randomized in controlled trials are the gold standard of clinical trials, but for pharmacotherapy. But when it comes to dietary intervention in clinical trials or dietary supplements, then RWR, research on the real world clinical research is very important because adherence, compliance and long-term sustainability is a very important thing to consider. Therefore, RWR, real world clinical setting research is very important, and that is why I have chosen all those studies who were evaluating the effectiveness, not the efficacy of the intervention product. So from 312 trials recorded, 8 controlled clinical trials met all eligibility criteria and were included in the quantitative synthesis. The studies evaluated foxtail, finger millet, barnyard and millet interventions across diverse populations. So this is the fasting glucose reduction, standardized mean difference, random effect model, and then studies included controlled clinical trial analyzing fasting glucose outcomes and heterogeneity moderate, I-square indicating some variability across studies. This is the postprandial glucose response, and I would like to just share with you that millets have this phenolic compounds which are very rigid and very, not easily digestible. So they help in reducing the sudden glucose excursion and then moderating the insulin sensitivity and then helping in long-term postprandial glucose excursions. Long-term glycemic control at HbA1c. 2 studies shows controlled trial providing HbA1c data for meta-analysis. Then random effect was 95% with a confidence interval 1.5 to 0.45, and low heterogeneity is indicating consistent effect across studies. So moderate but statistically significant reduction in long-term glycemic control markers demonstrate sustained metabolic benefit. And then, as Manu was saying, this earlier lecture, she was saying that millets are rich in iron, zinc, and manganese. So manganese helps in insulin action, and this zinc and iron helps in improving the pancreatic function, and that way also indirectly they contribute to the glycemic control very effectively. So impact on blood lipids, total cholesterol. You can see that it also improves. This slide, this is the forest plot. This diamond is showing the pooled effect, and the width is showing is the confidence interval. For the total cholesterol, you can see that it reduces the high density cholesterol, total cholesterol. This is for the total cholesterol. You can see that it reduces the high density cholesterol, total cholesterol, but negative effect was seen for high density cholesterol, whereas low density cholesterol was found to be lower. Millet-based diet significantly reduced total cholesterol, triglycerides, and LDL cholesterol. LDL levels showed positive trend but did not reach statistical significance. These improvements aligned with the cardiovascular risk reduction observation in whole gland intervention. There were studies that shows millet supplementation Also curb cardiovascular disorders. This is the mechanism showing this prebiotic and postbiotic and was talked about. So this also addresses to that because it is not getting easily digested. हमारे यहाँ कहते हैं ना बत्यूल इंहिदार सरियों इंहिदार यानी चीजें मेरे से देर से गुजरती हैं. So that leads to the fermentation in the colon and producing short chain fatty acid that helps in the improving the insulin sensitivity. Lipid lowering mechanism.
Faster.
So, study consideration, heterogeneity sources, variability in the study duration, different millet type use, diverse preparation methods. It is very important to address those issues and small sample size and some trials. So, future research needs larger multi-centric trials, standard interventions are warranted to confirm findings for longer follow-up periods needed to assess sustained metabolic benefits and clinical outcomes for leading long-term well-being. So, discussion. Millet-based diet significantly reduced fasting and postprandial blood glucose. LPA1C showed moderate but clinically significant improvement. Total cholesterol, triglyceride, and LDL levels decreased in intervention group. Effects are attributed to high fiber-resistant starch and an antioxidant content of millets. Results were consistent across most controlled trials. Moderate heterogeneity may be due to the variation in millet type and study duration, and larger multicentric randomized trials are needed for stronger evidence. So the conclusion was millet-based dietary intervention demonstrate clinical meaningful improvement in glycemic control and lipid parameters in adults with impaired glucose regulation. These findings support incorporating millets into evidence-based dietary strategies for diabetes and metabolic syndrome management, offering traditional, accessible, and effective
One question on my side. Why did you start random study design was randomized and controlled study? Why did you select this design?
Because as I told you that whatever the studies that we go through, they have less effect size. So by and there were only few studies available that were meeting the inclusion criteria. So I go for the randomized so as to increase the confidence in, interval level. So as to we can generalize the outcome and then we can bring all the real life setting clinical trials.
This type of studies should.
I can't help. I will
Sir, millet diet is served downstairs. Millet diet is served.
In which form you have given the patient?
All the studies, I mentioned it. Different form, like some give porridge, some give syrup form, some give, as I am giving, just to apprise the audience that I am also running a budget funded by the higher funding agency, Ministry of Education, on millet supplementation. So they sanctioned me in 43 lakhs for this intervention. So we are giving millet tortilla, roti, because Indians are very much accustomed with roti. Unless they eat roti, they are not satisfied. So we try to find some solution for that. So we are giving roti, and we are doing a real world clinical trials to get the effectiveness. So we are giving them roti and providing them with the whatever the guidelines are there of WHO for this glycemic patients, and then letting them free whatever they are free. Because earlier I was in Hyderabad, Indian Institute of Millet Research. They were telling me that they are also doing the same kind of work, but when they ask the patient to follow the dietary guidelines, they ask them to send a photograph of the thali. So and then what they do, they take the picture and then add rice after that and send the picture to the investigators. So this is how the compliance is very difficult. That is why I thought of doing whatever can be done in a long, sustainable. Study for for refined grey like wheat, rice, and all. Thank you very much for patient listening.
Because it has anti-nutrients.
Many the WHO guidelines are there for adults. 60% of the grains can be replaced with millet, and for elderly it is 70%, and for children it is 30%. 30% of the cereals can be replaced with millet as per the WHO guidelines.
They are reported as anti-nutrients. You may have
Anti-nutrients, they are rich in calorie only, but they are dense in iron, manganese, calcium. One thing, if dairy is available, this question of dairy is very much relevant, especially when the patient is a toddler or an infant. So, if dairy, if milk is
खावे अन्न वैसा बनेगा मन। और अगर आपका मन अन्न की ओर अभी भाग रहा है तो उसे बस 1 मिनट के लिए थमा के रखिए। We'll have a quick session of felicitation, and I request all the chairs and the speakers of this session to kindly come on the stage. पहले हम group photo लेंगे और उसके बाद felicitation होगा। All the speakers: Dr. Nikhat Sheikh, Professor Iram S. Rao, Dr. Jyoti Kode, Professor Asiya Sultana, and Chairperson, Professor Bijon Mishra, Professor S. J. B. Bokhari, Professor Irfan Ahmad Ji. पहले group photo होगा।
Sir. Sir, please.
आपको 100 लोग मांगे।
Serious students for much get
थैंक यू वेरी मच। और आप सभी को मैं विनंती करती हूँ आप कृपया यहीं पर बने रहें। आई रिक्वेस्ट प्रोफेसर फॉर फेलिसिटेशन, प्रोफेसर बिजॉन मिश्रा से मैं रिक्वेस्ट करती हूँ डॉक्टर निखत शेख जी को आप फेलिसिटेट करें।
ये तो सब कुछ कर रही है। Taking it, I'm giving it. Okay, sir. Thank you.
Thank you. I request Professor S.J.B. Bokhari to felicitate Professor Iram S. Rao. Thank you, and I request Professor Irfan Ahmad Ji to felicitate Dr. Jyoti Kode. And request Professor Bijon Mishra to felicitate Professor Asiya Sultana ji. फोटो सबका
आप इधर है
Right. Dr. Zaki and Dr. Professor Mohammad Idris sir on the days. Thank you. And now felicitation of the chairperson. I request Professor Idris sir to felicitate Professor Bijon Mishra sir. I also request him. I request Dr. Zaki Siddiqui sir to felicitate Professor SJB Bukhari sir. And request Dr. Idris to felicitate Professor Irfan Ahmadji. Thank you very much. Thank you very much, everyone. Thank you so much. I request all the dignitaries, all the panelists, Good afternoon, and let's move to the next session. Generally, post-lunch sessions are really, जिसे हम कहते हैं कि बहुत ही डिफिकल्ट होते हैं, कठिन होते हैं, पर कोई बात नहीं, हम आगे बढ़ रहे हैं और अभी और भी कोई आ रहा है तो उनको बोलिए कि kindly have their seats, and with permission from all of you, I'm proceeding towards third session of the day. Theme is Advancement in Regimental Therapy and Health and Wellness. So would like to invite सबसे पहले chairpersons को मैं यहाँ पर बुलाना चाहूँगी. Chairpersons for this session are Professor Dr. Qazi Rashid Anwar जी. जोरदार तालियों के साथ हम स्वागत करेंगे. आप डीन हैं प्रोफेसर एंड HOD INENT अंजुमन इस्लाम डॉक्टर MIT तिबिया यूनानी मेडिकल कॉलेज and HAR Kalsinkar Tibiya Hospital, Mumbai, Maharashtra. Thank you so much, sir, for being here. Would like to invite Dr. Najmoos Seharji, Deputy Director, Central Research Institute of Unani Medicine, Lucknow, UP. A very warm welcome. And thank you for gracing the occasion. I would also like to invite as a chair Dr. K. Kabiruddin Ahmed, Deputy Director, Regional Research Institute of Unani Medicine, Chennai, Tamil Nadu. A very warm welcome, sir. Thank you so much. And the speakers of this session are Professor Mohammad Anwar ji, Dr. Noman Anwar ji, Dr. Tamanna Nazli ji, Dr. Faruqi Shazia Parveen ji, Dr. शाइस्ता उरूस जी. मैं सभी का यहाँ पर हार्दिक स्वागत करती हूँ और हम शुरुआत करते हैं आज के दिवस के तीसरे सेशन को. Would like to invite Professor Mohammad Anwar ji. हम जोरदार तालियों से सर का स्वागत करेंगे. Professor in the department at Aligarh Muslim University. He has been involved in teaching undergraduates and postgraduates clinical subjects since 1994 at reputed institutions including Aligarh Muslim University, Hamdard University, New Delhi, and the National Institute of Unani Medicine, Bengaluru. He has served in several academic and administrative leadership roles. और सर का आज का टॉपिक है एविडेंस बेस्ड इवैल्यूएशन ऑफ रेजिमिनल थेरेपी इन क्रॉनिक रियूमेटॉइड डिसऑर्डर्स. ओवर टू यू सर. स्लाइड्स स्टार्ट करो.
Assalamu alaikum and a very good afternoon to all of you. With the permission of the chairman of this session, may I start by, at the outset, I am very much thankful to Director General CCRU for giving me this opportunity to be here for the academic presentation in the conference. The theme of conference is innovation and evidence in Unani practices. And as you know, this session is organized specifically for Ilaj with Talbina. I have chosen the topic evidence-based evaluation of regimenal therapies in chronic rheumatological disorders. Why I have chosen this topic? It is most prevalent disease and most common disease, musculoskeletal disorder. I think every family encountered with this disease. And Unani system of medicine is a, just give me a pointer, please. Pointer, please. Is a well recognized system of the medicine, and now the world is realizing its potential. Because of its potential, the WHO has considered a system, a scientific system, as a Unani system of medicine, and also ICD classification. ICD comes under the different diseases comes under the ICD classification of the WHO. Because of this potential, Government of India, particularly DGHS, Director General of Health Services, has published a common document. DGHS has published one common document that is a common management of musculoskeletal disorder. Standard operative procedures are published by the CCRM for the operating different regimenal procedures. Recently, so many, yesterday it was during the inauguration, Honorable Minister has inaugurated the SOPs, which was documented by the Ministry, CCRM Ministry of AYUSH for the different regimenal. One of the regimenal therapy, cupping therapy was already published by the CCRM. So, because of potential of regimenal therapy, even the government and Ministry, CCRM, taking a pain to develop the SOPs, because earlier the SOPs was not developed. So many people are doing some different regimenal therapy in different ways. Now we can say the regimenal therapies are established and we can do the regimenal procedure with proper protocol. Basically, Ilaj with Tadbir that describes the way to prevent the various regimental disorders, including rheumatoid arthritis, osteoarthritis, gout, neck pain, lumbar pain, low back and sciatica, different things. But this presentation emphasizes the integration of the rigorous research and clinical expertise to develop and tailored intervention and set new standards for the musculoskeletal disorders with the aim to enhance the patient outcome, to reduce the recovery time, to provide more efficient target care for the musculoskeletal disorders, and the main focus to improve the musculoskeletal health through research-based strategies and regimenal interventions. As we know that basically Rajya Tadbir is the moderation and modification in Asbab-e-Sitta Zaruriya, data discussed in the previous lecture about the Asbab-e-Sitta Zaruriya. And mainly, the Ilaj Tadbir is the moderation and modification of Asbab-e-Sitta Zaruriya with the intervention of different regimens. The modern is affected number of musculoskeletal disorders, neurodegenerative disorders, including low back, cervical and lumbar spondylosis, osteoarthritis, fibromyalgia, rheumatoid arthritis, sciatica, which causes pain and disability. And this is the global prevalence of the disease. You see that 18 million people suffering from the rheumatoid arthritis, neck pain 222 million people are suffering, osteoarthritis 528 million, low back pain 1,570 million, and other musculoskeletal disorders 386 million. This is the global prevalence that is posing challenge to the physician as well as economical burden to the society as well as the country. So, pain is the most frequent and troublesome symptoms of acute and chronic disorders, leading to functional impairment, emotional distress, and disability that poses a significant challenge in terms of ongoing clinical assessment and selection of the appropriate management strategy to the physician. Restoring the daily functioning and maintaining the well-being are increasingly advocated goal in the treatment of pain and disabilities. Currently, for the treatment of the mainstream system of medicine, number of opioids, steroids, non-steroidal, anti-inflammatory drugs, DMRDs are being used, frequently being used. These are effective, but long-term use of these, because most of the diseases are chronic and the long-term diseases. So that is why the long-term use of these non-steroidal anti-inflammatory drugs, other drugs, causing several side effects, which is a major threat to the human health, as they adversely affect the national workforce, inflicting economical and enormous burden to the nation. As we all know, right now the most important cause of the drug-induced kidney failure because of the most use of most of the non-steroidal anti-inflammatory drugs and the drugs which are being used for the rheumatoid arthritis for the long term. That is why if any mode of intervention which minimize the use of these modern drugs and which can helpful in the relieving the symptoms and pain may be as a novel in Unani system of medicine, so many regimenal interventions are there. Most commonly the Java therapy, beach therapy, massage therapy, Riyazat, Hammam, Kabal, Nudul, which are being used to manage the pain and musculoskeletal problems. Cupping and beach therapy is proven to be effective. Recently, numerous scientific and clinical studies have been carried out to assess the efficacy of the regimenal procedure. It has been found to be effective in the treatment of musculoskeletal disorder. Keeping the strength of Unani system of medicine, the Director General of Health Services, Government of India, has published standard treatment guidelines for musculoskeletal disorders in 2024. Hence, the inclusive utilization of regimenal therapies has great potential in the management of musculoskeletal disorder and thereby reduces the clinical symptoms, complications, and improve the quality of life. This is I am not skipping some slides that are also we have time, but we are treating these diseases with the basic principle, adopting basic principles of Unani medicine. That is regimenal intervention. Basically, all the therapies are being used for the tantiye mukta. That is why before starting any regimens, the nusjotantia is very important. Give the nusjotantia, the effect will be more. So these and the main purpose of these regimens to maintain the humoral equilibrium and tawazun of life. If any disease will develop, we do end up in most of the diseases. What is the purpose to maintain the humoral equilibrium and maintain the tawazun of life, and by providing the tanti umumi and tanti unkavi, we can provide the pain relief and the management of the different musculoskeletal disorders. These are the regimenal interventions which are commonly being used, and most of the regimens are applied for the purpose of tanti and istafra. And as these regimens are being used thousands years ago, and it is documented, well documented in Unani classical literature, like recommended by the Razi, Messina, and their books, and most nearly 36 regimenal modalities are there. Among them, some are very widely practiced and some are the less practiced. Now, because this conference is being organized to develop the evidence base, now in the modern system of medicine, the evidences are generated, and what is the mechanism of action of relieving pain of different regimens are also being established. See, if you dry cupping, pajama blush is the most common procedure. If you see what is the mechanism of action of the pajama therapy, that is negative pressure is created under the skin, which creates the skin upliftment with the local pressure decrease inside the skin and increased capillary filtration, local filtration, and that will filter the interstitial fluid, retention of fluid inside, and the dilution of the chemical substances, inflammatory mediators, and nociceptive substances. That will cause analgesia, that will ultimately decrease the pain and breakage of the reason of addiction. Similarly, in the fat cupping mechanism, there is a specific mechanism where the negative pressure, skin upliftment, and there is a mechanical and nociceptive stimulation of skin receptors, which stimulate the nociceptors, C fibers, and delta fibers, which activate the peripheral sensory system, that goes to the spinal cord. Then, gate control mechanism developed, which release the different endorphin, endorphin, and then the neurotransmitter serotonin is released, and noradrenaline is released, substantive is released, and this is the neurohumoral response via the HPA axis, which reduces the pain and causes the clinical analgesia and relief of the pain. Similarly, there is a specific mechanism of massage therapy, where there is change, physiological changes, psychological changes, neurological changes, biochemical changes, and immunological changes. All these changes result decrease the neuro excitability, parasympathetic activity, decrease the muscle tension, and thereby the pain is relieved. So, with this basic background of the mechanism of the different regimens, I have discussed only 2 or 3. As I am associated with the Ilaj Tarbi last 30 years, and from since 10 years, I am attached with the postgraduate department, and students are working under my supervision. I have given the topic just for the purpose of to generate the data for the I have selected some important topics, particularly rheumatoid arthritis, knee osteoarthritis, adhesive capsulitis, and fibromyalgia, and given the topic for the short-term study to my PG students. One of the important study was carried out under my supervision for rheumatoid arthritis. As all you know, rheumatoid arthritis is one of the important autoimmune disease, and people are suffering from this. And we have given the topic that is the clinical history of PBR preceded by multi-nuclear therapy in the management of rheumatoid arthritis. The enrollment, the study was designed by the department, it was approved by the research protocol committee, then it was approved by the institutional ethical committee, then it was registered by the CTRI, then the properly research was started by the PG student. But there are some certain constraints while we are adopting the topic of PG research, certain constraints that sample size of 1, because most of the students, those who work under PG, did their PG, have a specific time. Only 2 years they found for the research purpose, and that is why the sample size, as per calculation, was not given with the permission of the ethical committee members. The sample size was 40, and 5 was excluded, and allocation, the patient was given test one group A and group B, that was the randomized. After randomization, the test group patient was initially treated with the multi-muscle therapy for the 21 days. After multi-muscle therapy, HBR was given for 28 days. And for the standard treatment of the rheumatoid arthritis, that is hydroxyquinoline SC2, 200 milligram for twice a day, given for 49 days. The intervention, 23 for the multi therapy, and for the intervention group B, that was 12. And the study was, patient was recruited after proper investigation, proper inclusion and exclusion criteria, and then it was assessed by the subjective and objective parameters. In this study, the subjective parameters of pain, morning stiffness, restriction of movement, tenderness, and objective parameter was the WAS, OMAG, and ESR, and ZIA. This is the ingredient of the multi-muscle which was given to the patient earlier for the 21 days. After that, this is the ingredient of the WBR, and I think on slide you see the after the assessment. After the assessment, the p-value was effective, that is less than 0.001, and the group in which the multi-muscle therapy after the WBR was given the more significant than the significance level of the group B. Though this is one of the work which was conducted by under my supervision. The paper was sent to the publication. It is under publication. I think it will be published very soon in the very good impact factor journal. Second study which was carried out under me, that is on the osteoarthritis. And here I have chosen very best practice. Where some regimens are widely practiced and some regimens are very best practiced. Here your clinical evaluation of effect of product with Rogane, Amargadi, and Riyasat in knee osteoarthritis was our. The study was conducted on the 60 patients, and the group was divided into 3. Group A, Group B, Group C. The Group E, Dalake Motadil 5 ml Rogane Amargadi and knee strengthening exercise was given to the patient. In Group B, Abdul with Dalake Motadil with Rogane Amargadi and knee strengthening exercise. And Group C, application of 4 gram of diclofenac gel the knee, and after that knee strengthening exercise. In all 3 groups, knee strengthening exercise was common. In Group A, only Rogane Amargadi massage was there. In Group B, it was added with the Habibullah, and in Group 3, only exercise was given. After the completing 21 days, it was assessed on the subjective parameter as well as the objective parameter. The subjective parameter was pain, morning stiffness, and objective parameter was AMA. The p-value in comparison between A and B group came to out less than 0.05, which shows insignificant difference in improvement between the group. Both group p-value of comparison to group A and C came to be less than 0.001, which shows the moderately significant difference in improvement in the pain, while the p-value of the comparison to group B and C compares less than 0.01, which shows significant difference improvement in the pain between the both groups. So this is the study carried out on the osteoarthritis, and this is the consort chart. Eligible candidate was patient was 78, enrolled 64, the 14 patients were included, 64 were randomized, and allocation group A 21, which will be 20, and which is 23. And this is the follow-up of number of patients. Then the patient was analyzed statistically, and statistically significant results were observed. The patient where the with Danak with the Rovane Ahmadadi, and this is the ingredient of Rovane Ahmadadi. This study was conducted on osteoarthritis. This is submitted and paper is published in the journal. I have given reference paper is published in the. And third study which was carried out under me, under my guidance, that is on fibromyalgia. Again, fibromyalgia is a chronic problem and it is psychosomatic disorder, and it is mentioned that cupping therapy is quite effective in some nafsiyati amras and nafsaniya. Because concept of fibromyalgia is not there in the classical literature, but polyarthralia pain and multi-point pain was there. The patient was diagnosed on the clinical parameters of fibromyalgia. Then clinical evaluation of the hypothesis, right, as a part of multimodal approach in the management of fibromyalgia. 60 patients were selected for the study, and patients were divided into three groups. One group where the hijama pressure once a week were given for the 28 days at the tender points of the fibromyalgia. You know the 28 tender points. If there are 28 tender points present in the fibromyalgia case, if the 10 tender point is positive, then the case is diagnosed as a fibromyalgia. So at the tender point, cups was applied for hijama pressure problem, and in group B, hijama pressure with abdasnan was given for 28 days, while in group C was treated with the standard modern treatment, that is amitriptyline, for 21 days. The patient was assessed on the 0 day, then the 7 days, 14 days, 21 and 28 days. Subjective parameter which was assessed for the NRS, and subject to objective parameters, fibromyalgia, revised fibromyalgia questionnaire. So these hijama bilasut along with the abdasnan exhibited significant reduction in the pain and other symptoms of fibromyalgia on the basis of the reduction in the scores of NRS and FIQR. These are the ingredients of abdasnan which are given, and this is the last study which was carried out under my supervision. That is clinical evaluation of the effect of Roman modeling. In the management of adhesive capsulitis. Adhesive capsulitis, again, you know, it's a very common problem, particularly in a patient who has diabetes. Some sort of time develop the adhesion and causes adhesive capsulitis. Commonly, it is known as the frozen shoulder. The patient was diagnosed on the basis of clinical symptoms as well as an investigation. And diagnosed patient, the study size was 60. The diagnosed patient divided into two groups. One group was given application of zimadin and alternative in the first week, followed by dalacladian with the Roman for 10 minutes, followed by stretching exercises twice for the period of 3 weeks. While the group B, ultrasound therapy with diclofenac was given, and the group B patient an alternative for the period of 4 weeks. After the completion of the therapy, the patient was again assessed on the subjective and objective parameter. The subjective parameter was the pain, stiffness, reduction in the joint area, tenderness on the joint area, swelling over the affected line, and then objective parameter, the numeric scales, and SPID, that is shoulder pain and index, disability index. Effect on the NRS and SPID, both groups showed a significant reduction in NRS and SPID scores. That p-value was less than 0.001. So this is the consort chart. Apart from these four, so many in the recent past, so many studies was carried out on the different regimens of regimenal therapy and published in the national and international in the journal. I have given some references. Knee osteoarthritis is a very common problem. The gut cupping therapy in the knee osteoarthritis. These are the work carried out by the other researchers which are published. Just I would like to mention because this is the evidence-based conference. So what are the regimens which are having some evidence? That is cupping therapy in the knee osteoarthritis, leech therapy in the knee osteoarthritis. Knee osteoarthritis, what patient treated with the cupping, the paper is the published in the journal is the references. Similarly, the low back, there are applications of the heart fermentation for pain elevation, non-specific low back pain. Weight cupping therapy in the management of the low back pain. The paper is the published in the concern journal. Effectiveness of weight cupping therapy and effect of gliding cupping with the Roganesco in the low back pain. The paper is again the fibromyalgia. Some work has already been carried out on the procedure of the cupping therapy, and then chronic neck pain and shoulder pain, and then the rheumatoid arthritis. These are the studies which are already carried out for the in different sectors, different scholars, particularly from the CCRPM and other institute, Jamia Ahmad and National Institute of Unani Medicine. Just I am giving reference of these therapies so that we can provide the at least some lead that these regimens are quite effective and these are its use are the scientific very proven. So summary of this, the goal of regimenal therapy is not only to elevate the immediate symptoms of musculoskeletal condition, but also to improve the overall structural and functional health. By integrating advanced therapeutic techniques such as targeted massage, cupping therapy, medicinal bath, exercise, rehabilitation with personalized dietary and lifestyle modification, balancing the body's humor, enhancing circulation, promoting tissue repair, this therapy also offers long-term relief in the management of musculoskeletal disorders. And in conclusion, advancing musculoskeletal care through evidence-based regimens is crucial for improving patient outcome and enhancing the efficiency of the intervention. By integrating research-driven insight and clinical expertise, healthcare providers can develop targeted strategies that optimize recovery, reduce pain, and set a new benchmark for excellence in musculoskeletal health through Rehabilitation. In its advanced form, Rehabilitation combined time-tested wisdom with modern principles offering the effective non-invasive remedy for the pain relief, rehabilitation, and management of the musculoskeletal disorder. With these words, these are some small-scale evidence-based studies which I have presented. But there is a need. What is the shortcoming? There is a need that meta-analysis of these studies and one target-based plan research work should be designed and carried out by the different centers, and the meta-analysis should be conducted so that we can provide the remedy for the chronic musculoskeletal disorder. And as I earlier told, that regimens are very effective in the managing musculoskeletal disorder. But as you know, that most of the diseases are such as osteoarthritis, there is no specific treatment. Rheumatoid arthritis, there is no specific treatment. And person traveling here and there for the treatment, and most of the drugs which are being misused for its management and for the pain relief. बस टाइम क्या होता है कि पेशेंट आकर के ओवर काउंटर एक बार कंसल्टेंट के पास गया, उसने मेडिसिन लिख दी और ओवर काउंटर आने के बाद वो मरीज दवा लेता रहता है. तो जो बहुत सारी दवाओं का मिस यूज हो रहा है, उसके अपने जो इफेक्ट्स हो रहे हैं. और एज आई अर्लियर टोल्ड दैट ड्रग इंड्यूस्ड नेफ्रोपैथी का जो थर्ड कॉमन काज है, first is the diabetes, second is hypertension, and third is the because of drug induced. The most is attributed with the misuse of the non-steroidal anti-inflammatory drugs. So with these techniques and with regimens, at least we can decrease the number of the patients for taking allopathic medicine, and they can relieve some sort of the relief, and they can manage the chronic disorders. With these words, I am just concluding my lecture. Thank you very much. Any question, I am here to answer. Yes, please.
therapy is very popular. Considering the principle of the visa that individual treatment. So that the evidence to generated is acceptable both the Unani community and the mainstream rheumatology in India. That is my question.
A very well question. That is why we are generating data. The different research organizations are working in this direction, and now small scale studies was carried out at the different centers. Just I have given example of the 4 research work. One is the rheumatoid arthritis, second is osteoarthritis, third is the adhesive capsulitis, and fourth on the fibromyalgia. These researches are on the basis of the modern scientific parameters. We have taken the protocol, we have approved from the research committee, as well as it is registered under the CTRI of Government of India. So this is the evidence, but here are some shortcomings also here. Because these are the small scale studies. We cannot implement or generalized. We can, unless otherwise, we cannot do the larger scale study. These studies are carried out like clinical trial phase 2. Now the requirement and the need for clinical trial phase 3, clinical trial phase 4, and after that there will come post-marketing surveillance, and then we submit our data to the government for the acceptability, so that we can give a sound validation proof that these regimens are effective. And I think with these scientific proven data, even modern system of medicine people will also accept our validity.
We should go for randomized control trial.
No, madam,
Just
one point is there.
I earlier told.
The government, what is existing to the discount between the modern and the AYUSH. So, what is the government is the main aim and objective? 20, you are selecting 60 patients.
Okay.
So, what is asking to the, you call for your like-minded modern doctor to your group and ask to his medicine is 5%, 5 people. Your medicine is 55 people. If that data is collecting from the Unani system, that may be, we can globalize our things to the global level. That is only because I am sitting with other ministry. So that's why I am asking this question.
देखिए ऐसा है just give answer because ये जो researches हो रही हैं ये evidence को generate करने के लिए researches हो रही हैं. हमारी जो सेंट्रल काउंसिल फॉर रिसर्च यूनानी मेडिसिन है अब लार्जर स्केल पे इस पे प्रोजेक्ट दे रही है, और जब भी कोई हाइपोथेसिस बनती है, हाइपोथेसिस वी हैव टेकन फ्रॉम द क्लासिकल टेक्स्ट, देन हमने जो प्रोटोकॉल फ्रेम किया दैट इज प्रोटोकॉल ऑन द यूनानी एज वेल एज द मॉडर्न पैरामीटर वी हैव अडॉप्टेड. द आरसीटी द थिंग इज लॉन्ग टर्म स्टडीज रिक्वायर्ड, randomized clinical trial is required, then the meta analysis is required, then it will be scientifically proven, evidence based, we can prove it. Thank you.
In a very prestigious hospital, CHAVAN hospital in Delhi, and it's a RCT. We are doing this thing.
Here is the prestigious institute is not. Prestigious physician is most important. That I want to do because these are the Hakims. They are very popular in the rheumatoids. So the hospital is not important for the doctor is important. Doctor.
Under the supervision of a rheumatologist.
Yeah. Thank you, sir. Thank you very much.
Thank you very much. I request Dr. Rashid Kazi to go ahead with remarks, and then we'll have the next speaker.
Bismillahirrahmanirrahim. Professor Anwar is a very esteemed academician. Sir is a senior faculty, head department, chairperson of the IBT department at AMU Aligarh. Sir very well concluded the topic. Sir, I congratulate you first of all. The topic was the evidence-based evaluation of regimenal therapy in chronic rheumatological disorders.
Okay.
Sir, this is a great challenge for modern system of medicine. So you rightly chosen the topic, very proper, very appropriate topic you have chosen, and you have concluded each and every aspect of the disease in your speech, in your lecture. तो जिसको हम कह दें कि आपने मौजू का हक अदा कर दिया. Big round of applause for the esteemed speaker, please. अब अगर हम बात करें कि इस वक्त सिचुएशन जो सिनेरियो हेल्थ केयर सिस्टम का, तो आयुष सिस्टम ऑफ, ये बात हमको माननी पड़ेगी, वी मस्ट हैव टू एक्सेप्ट कि आयुष सिस्टम ऑफ मेडिसिन इज नॉट अ फर्स्ट चॉइस ऑफ पीपल, फर्स्ट चॉइस ऑफ पब्लिक, इट इज अ सेकंड चॉइस ऑफ पब्लिक. तो आयुष सिस्टम के पास, यूनानी डॉक्टर्स के पास पेशेंट जब आता है तब वो मॉडर्न सिस्टम से मायूस हो चुका रहता है और एक लंबे अरसे तक मॉडर्न मेडिसिन इस्तेमाल कर चुका रहता है. इसकी बहुत सारी वजूहत है अगर हम देखें तो, कि मॉडर्न मेडिसिन जो है वो वाइडली अवेलेबल है, इजीली अवेलेबल है, उसका डोजेज फॉर्म जो वाइडली एक्सेप्टेबल है, इसका साइंटिफिक अप्रोच है, वगैरह वगैरह. तो अगर हमको आयुष सिस्टम को मॉडर्न सिस्टम के इक्वल और उससे आगे लेके जाना है तो हमको भी यही अप्रोचेस अपनाने पड़ेंगे, तब हम मॉडर्न सिस्टम ऑफ मेडिसिन को कॉम्पीट कर सकते हैं, उससे आगे बढ़ सकते हैं. इस सिचुएशन में जब हमारे पास मरीज आता है, मैं इस डिसीज के कंसेंट में खास तौर से कह रहा हूँ कि जब हमारे पास पेशेंट आता है तो उसको एक उसका प्रॉब्लम होता है, जैसे क्रोनिक रोमाटोलॉजिकल डिसऑर्डर. उसके साथ साथ पेशेंट को वो डिसीज के भी कॉम्प्लिकेशन हो चुके रहते हैं क्योंकि बहुत एडवांस, बहुत लेट स्टेज में आयुष डॉक्टर के पास आता है. तीसरी चीज, पेशेंट को जो लंबे अरसे तक मॉडर्न सिस्टम ऑफ मेडिसिन इस्तेमाल कर चुका है उसके भी बहुत सारे अनवांटेड साइड इफेक्ट्स होते हैं. तो पेशेंट जब हमारे पास आता है तो हमारे पास 3 चैलेंजेस होते हैं. हम उस डिसीज को एड्रेस करें, हम उस डिसीज के कॉम्प्लिकेशंस को एड्रेस करें और हम मॉडर्न मेडिसिन के अनवांटेड इफेक्ट्स को एड्रेस करें. तो इस सिचुएशन में जैसा सर ने कवर किया कॉम्प्लिकेशंस भी, अगर हम रूमेटोलॉजिकल डिसऑर्डर्स की बात करें तो सर पेशेंट HCQS लेकर आता है, आई कॉम्प्लिकेशन बहुत कॉमन है. पेशेंट स्टेरॉइड लेके आता है, वेट गेन है और डायबिटीज मेलाइटस है, वगैरह वगैरह चीजें हैं. और पेशेंट गोल्ड कंपाउंड्स कुछ पेशेंट लेके आते हैं तो रेनल इंपायरमेंट वगैरह भी हमने देखा है. तो हमको पेशेंट इनिशियल स्टेज में नहीं मिलता. जो हम पे एक इल्जाम होता है कि यूनानी सिस्टम ऑफ मेडिसिन बहुत स्लोली इफेक्टिंग है या बहुत जल्दी काम नहीं करती है, उसका एक रीजन ये भी है कि पेशेंट हमारे पास अर्ली स्टेज में बहुत रेयरली आता है क्योंकि हम पेशेंट की फर्स्ट चॉइस नहीं है. पेशेंट जब मायूस होता है तब हमारे पास आता है, जब उसको मॉडर्न मेडिसिन भी काम नहीं कर रही होती है तब हमारे पास आता है. तो इस सिचुएशन में, इस डिसीज में भी हमारी जिम्मेदारी ये हो जाती है कि हम उसके क्रोनिक रोमाटोलॉजिकल कंडीशन को एड्रेस करें, हम उसके जो क्रोनिक रोमाटोलॉजिकल कंडीशन के कॉम्प्लिकेशन है उसको एड्रेस करें और हम उसके अनवांटेड इफेक्ट्स जो पेशेंट ले चुका है जैसे HCQS और स्टेरॉइड वगैरह उनको एड्रेस करें. तो सर आपको मैं एक बार फिर मुबारकबाद देता हूं और मैं आपसे रिक्वेस्ट करता हूं, नॉट रिमार्क, यू आर वेरी सीनियर. तो आपने जैसी स्टडीज की, आप जैसे AMU अलीगढ़ में इलाज की तदबीर डिपार्टमेंट में आपके अंदर में बच्चे MD कर रहे हैं, तो आप अब स्टूडेंट्स को ऐसे टॉपिक अलॉट करें जो स्पेसिफिकली कॉम्प्लिकेशन को एड्रेस करें, कॉम्प्लिकेशन ऑफ द डिसीज एंड कॉम्प्लिकेशन ऑफ अनवांटेड इफेक्ट्स ऑफ द मॉडर्न मेडिसिन. तो मैं समझता हूँ इंशाल्लाह स्टडी पूरी होगी, यूनानी सिस्टम ऑफ मेडिसिन का भी फायदा होगा, इंसानियत की भी खिदमत होगी. मैं एक बार फिर आपको मुबारकबाद देता हूँ. थैंक यू वेरी मच.
Thank you very much, sir, for your important remarks. And thank you very much, Professor Mohammad Anwar Sahab. Moving ahead, हमारे next speaker है Dr. Noman Anwar जी. मैं आपको मंच पर बुलाना चाहूंगी. Dr. Noman Anwar has been principal investigator and co-investigator in about 19 research projects. He has participated in over 50 conferences and has organized 55 academic and outreach programs. Okay, thank you so much, sir. Over to you.
Thank you very much. Esteemed chairs, dignitaries on the dais, off the dais, my dear friends, dear delegates. Very good afternoon. May Almighty's peace, mercy, and blessings be upon all of you. First, I would express my warm wishes for Unani Day to all of you. A very happy Unani Day. I would like to take, before I begin my presentation, I would like to take this opportunity to express my deep sense of gratitude to the Honorable Director General, CCRM, and the organizers for having me here and providing this wonderful opportunity to interact with this August gathering on revival of some important regimens in Ilaj with Tadbir. So dear friends, it's not a lecture actually, or not a outcome of any study. As Dr. Anwar Saab have very elaborately has discussed about, regimenal therapy and outcomes of few studies. So it is not a study, rather it is a call to revive regimens, Unani regimens, which are mostly neglected actually. We can see that 2-3 regiments are very popular across the globe, not in India only, but across the globe. But these are only few, 2 to 3. Maximum, we are having around 50 regiments, but most of the regiments are neglected actually. Next slide. So, well, ladies and gentlemen, as we know that Ilaj with Tadbir is one of the core treatment modality, or you can say that it is the important pillar, one of the important pillar of core Unani therapeutic modalities, right? Which involve certain special techniques through which the altered temperament is normalized, mobile matter is eliminated, its excessive production is checked, or its aspirate is arrested. And normal, and by that, normal temperament or overall equilibrium is restored. So these are very simple and cost-effective and time-tested method to treat various disorders. A complete detox, in short, you can say it is a complete detoxification process. So in Unani classical texts, we are having all details about regimenal therapy, like principles, objectives, indications, contraindication, and all. So these are the strengths of Ilaj with Tadbir, like maintaining overall health and well-being, detoxifying the body and rejuvenating the mind, restoring the body's natural constitution, thereby enhancing its inherent healing capacity, improving sleep quality and regulating sleep pattern, reducing stress and promoting holistic health by facilitating the natural flow of energy within the body, supporting the body's ability to maintain an ideal weight, thereby helping prevent metabolic disorders and other non-communicable diseases. So here I have given some regimenal therapies, different types of regimenal therapies, but you can see that only a few, like first also, maybe 3 to 4 centers will be practicing this, venesection or first. Hijama is common, then Daluk and leash therapy. These 3 regimens are mostly common. Other regimens we are having, as I stated earlier, that more than 50 regimens we are having, but most of them are neglected. So what is the prime objective of these regimens, like Tadil-e-Mizaj, Tarqiq-e Mawad, Tafti-e-Tahlil-e Mawad, Istifraq-e Mawad, Himalaya Mawad, and all? I think most of you are from Unani backgrounds, so you all know.
Sorry for interruption, sir. This is a request from organizers. We have to arrange a closing ceremony in the same hall.
Yeah.
So it is request to the speaker to please make it short. In 10 minutes presentation, we have 2 more speakers. Thank you.
Yes, sure. And in fact, we are having other lectures, like Dr. Talbina Nazari, she will be highlighting on SOPs, right? Standard operating. The standard operating procedure on Hijama. So I think that will be important lecture. So I will conclude within 3 to 4 minutes. So don't worry. So these are prime objective, and you see that popularity of regimens, especially that cutting therapy and leash therapy for beautifying the face and all. So many celebrities are using these regimens, particularly hijama therapy and leash therapy. So rationale for revival. Why it is important to revive all this regimen? Definitely the main reason is under-utilization of these regimens. Despite having rich classical evidence and historic use, cost effectiveness, minimally invasive, these regimens are minimally invasive, alliance with preventive and lifestyle medicine, growing global interest in non-pharmacological therapies nowadays. And definitely, as Anwar stated, a lot of work is going on these regimens, different regimens, and a lot of publications we are having public domain. So, what do we mean actually? Revival. Revival doesn't mean that only use of these regimens. What do we mean by revival? Scientific validation, documentation, standardization of process, safety protocol, and capacity building and skill development, institutional support, establishing different regional centers, and integration with modern clinical practices. So these are important aspects to revive any regimen, actually. So, as stated earlier, some commonly regimens like first hijama, talib, dalg, inkebab, and natul. And in this, I think hijama, dalg, and natul are common. And these are neglected regimens. I will just highlight in Zatu Ishal. Council has worked on nutritional therapy. Council has worked a lot actually. A lot of data is there. But why I kept it neglected? Because despite having those data, we don't have proper setup, especially in clinics. In other hospitals other than CCRU, then we were not having any SOP, any documentation, except those studies what we have carried out in CCRU. But yesterday we have seen that Council has launched SOP on regenerative therapy also. And then analysis like Idrar, then fees, these are important regimens like Riyadat, then Tamriq, and then Nutul, Sakub, and Abd and Pashoya, Bahur, Takmeed, Tadqeen, Kay, Hammam, very important regimen, but mostly neglected. Why these regimens are neglected actually? Because of inadequate infrastructure, poor documentation and research, lack of training and skill transfer, and fear of complications. So strategies will be accordingly to integrate in curriculum and skill-based training, and SOP development and standardization, clinical research, and outcome documentation, public awareness and acceptance. So, initiative of CCRM for reviving regimens in Iraq with Tadbir. So, like the development of SOPs for Iraq with Tadbir, like one SOP we were having on hijama. Last year it was released, and yesterday we have released 6 regiments, SOPs on 6 regiments. Then Council has established, clinics, Iraq with Tadbir, OPDs at every peripheral centers. And infrastructure, we are having RRM Srinagar, Center of Excellence for Regimenal Therapy for musculoskeletal disorders, and RRM Chennai, we are having the state-of-art Regimenal Therapy Center. Then we have been allotted 2 centers, funds, grant in fund aid we have received from Ministry of Minority Affairs for establishment of Rajit Tadbir at CRM Lucknow and one at RRM Silchar. So these are some future prospects. Actually, this is last slide, I think. So definitely we have to establish evidence-based research and development of clinical guidelines, education and awareness, capacity building and skill courses for technicians, traditional knowledge preservation, state of wellness, preventive and health promotion centers, integrative health models, sustainable research like lead bank, equipment, infrastructure and all, regulation and licensing. So now I'm coming to conclusion. Along with Tadbir represents holistic, preventive, curative, and sustainable therapeutic approach, encompasses nearly 50 regimens with wide-ranging health benefits, The decline in their utilization is primarily attributed to gaps in infrastructure, education, awareness, and absence of uniform standards. Reviving these neglected regimens is therefore an urgent necessity. So such revival should not be viewed as regression, but rather as a process of scientific discovery. Their evidence-based, safe, and standardized application has the potential to redefine contemporary Unani practices. These regimens can significantly strengthen the distinct identity and contribution of Unani medicine within integrated healthcare ecosystem. With this, I conclude. Thank you very much.
Thank you, sir. Very nice presentation. I request my colleague chairperson to conclude the topic in few minutes, and then I will request to the organizer to please call the next speaker.
अस्सलामुअलैकुम। नाइस प्रेजेंटेशन है। जैसा कि मालूम भी है, डॉक्टर रुमान अनवर हमारे यहाँ CIM लखनऊ से आई हैं, तो मुझे बहुत खुशी है इनके प्रेजेंटेशन को कमेंट्स करने के लिए। जैसा कि इनका टॉपिक था कि रिवाइवल ऑफ सम इम्पॉर्टेंट रेजिमेंट इन लार्जविल तकबी। तो सम रेजिमेंट है बहुत कॉमन है और सम रेजिमेंट को रिवाइवल की जरूरत है। तो बहुत अच्छा प्रेजेंटेशन था। आपने स्टेप भी बताई, उसके प्राइमरी ऑब्जेक्टिव भी बताए, और जहाँ पे वो डिक्लाइन हो रहा है जो सारे रेजिमेंट, उसको रिवाइव करना है। और ये अगर ये रेजिमेंट थेरेपी हम लोग रिवाइव करें तो यूनानी सिस्टम ऑफ मेडिसिन का बहुत स्ट्रेंथ बढ़ेगा इससे, और हम बहुत ज़्यादा लोगों को तक और पहुँच सकते हैं अपने पोटेंशियल के साथ। तो थैंक यू वेरी मच।
थैंक यू वेरी मच सर। सर मेरी एक रिक्वेस्ट आपसे ये है कि आप जब इसको रिवाइवल की बात कर रहे हैं तो आप प्रोसीजर्स के रिवाइवल पर भी थोड़ा सा फोकस करें, क्योंकि अपने कुछ तरीके इतने खौफनाक है कि पेशेंट तैयार होकर फिर मना कर देता है। तो हम जब प्रोसीजर करें उनको तो उनको सिंप्लीफाई करें, एक्सेप्टेबल टू द पेशेंट, इस तरह का रिवाइवल आप करें।
बिल्कुल,
थैंक यू।
मैंने वही कहा, रिवाइवल का मतलब ये नहीं कि सिर्फ उसको यूज करना, बल्कि प्रॉपर डॉक्यूमेंटेशन होना चाहिए उसका। अब देखिए SOPs बन रही है, काउंसिल ने 6 SOPs किया, रिलीज किया है, दूसरे उस पर भी लिखे।
थैंक यू।
इंशाल्लाह नेक्स्ट ईयर हम टेक अप करेंगे 6 मोर।
थैंक यू वेरी मच। थैंक यू।
Thank you very much, sir, for your wonderful presentation. Moving ahead, we have our next speaker, Dr. Tamanna Nazli, Research Officer, Unani, RRIUM, Delhi. Her topic is SOPs on hijama, cupping, and overview. जोरदार तालियों के साथ हम मैम का स्वागत करेंगे. And as we are moving ahead of time, I am also limiting my talk.
Good afternoon. Without any delay, with the permission of chair, I would like to start my presentation. So, standard operating, today I'll be giving presentation on standard operating procedures, SOPs for hijama, and overview. So, this SOPs, they were developed last year after brainstorming sessions and several discussions and mutual understanding with academia, clinicians, experts from surgery, from the conventional medicine, and with the mutual consensus. So, in this slide, this is an outline of the overview. We will discuss the objectives of hijama, the classifications, then the SOPs for pre-cupping, then cupping during the cupping, and post-cupping stage. Can you see from there? So the objective of the SOPs are ensure patient safety by preventing infections, scarring, and post-procedural complications through strict aseptic measures, minimize the pain and discomfort by adopting standardized, gentle, and patient-friendly techniques, promote optimal recovery by reducing the adverse events and enhancing the post-procedural healing, encourage evidence-based practices to ensure safety, quality, and clinical effectiveness, and maintain the uniformity, hygiene, and quality standards by following established sterilization and infection control protocols. So, this slide is a systematic classification of cupping on these parameters like indication. We have hijama tahaffuzi for preventive and hijama zaruria for therapeutic use. Then the second parameter is incision. We have dry cupping, hijama bila shirt. Then we have wet cupping, hijama bil shirt. We have vacuum pressure based on the pressure vacuum. It is khafifa, qawiya, and tadila. Mutadila. This is light, strong, and moderate cupping. Then we have pre-procedures like massage cupping, hijama dalakia, hijama sariya, flash cupping. And we use fire, which is hijama naria. I think this is. There is some mistake. This is fire cupping, and sometimes we use water, warm water, or some decoction of some herb, which is hijama maya, which is not very frequently used. So the principles of hijama therapy for bilashart and fire cupping is diversion of the morbid matter, and in initial phase of inflammation to divert these morbid matters from the vital organs to the opposite side, to give pain relief for the dissolution of gases, for warming the organs, restoration of the displaced organs, and increase or decrease the size of the organs as required. And for wet cupping, this is done. The wet cupping is done to evacuate the morbid matter, analgesia, detoxification, and humoral balance. So, for establishing a hijama unit, the essential infrastructural facility which is required is a well-ventilated room, adequate with adequate lighting, warm, cozy, comfortable room. All surfaces are deeply cleaned and disinfected pre and post procedure, and we have the facility of biomedical waste management, diagnostic facility, and also the emergency facility in case of head cupping. So the cupping related instruments are autoclaved and sterilized after use. One more thing, the room. In a hijama unit, we should have at least one consultation room and of 10 by 10 feet area, and one cupping area each, one for male and one for female. So these are the equipments and materials which are required for establishing a hijama unit. The patient furniture and setup, which includes the hijama table, chair, surgical trolley, surgical lamp. We need disposable sterile sheets for patient draping. For sterilization and infection control, we need autoclave, sterilized gloves, surgical mask and head caps, apron and patient gown. In case of fire cupping material, we need camphor or spirit, coin or metal disc, sometimes matchbox lighter, and fire extinguisher, which is very important. Now the instruments, we need sterilized cups, whether glass or plastic, for manual, and we need manual or electronic suction machine, forceps, long tweezers, surgical blades, 11 and 15 number. I will later tell you about the blades. These then surgical tape, bandages, dressing tray, kidney tray, and for dressing material, we need antiseptic solutions, sterilized gauze, sterilized cotton, and surgical dressing bandages, micropore surgical tape. So these are the essential requirement if you want to set up a cupping therapy unit in your department. So this slide shows you that in which season, which is suppose this is spring, which kind of oil you have to use. You need Rogane Banafsha, Rogane Badam Shiri, Rogane Tukhmik Kahu. In winters, this Rogane Babuna and Rogane Khus is very beneficial. And if you want to remove the viscid and cold tumors, you need Rogane Bakayan and Rogane Shit. And the minimum qualification for doing this cupping therapy is BMS, registered Unani medical practitioner, or a trained cupping therapist of assistance, not lesser than that. So these are this table shows you the specification of cup. So the more the diameter of the base of the cup, the lesser the number. So if you can see, and we have this 3C and 4C curve type of cups, which is advisable and recommended for the for curved surfaces like scalp or if you want to do it on acetabulum of femur. So you cannot place the straight cups with straight base. You have to choose these 3C and 4C cups. So these are the ideal timings for doing cupping. If you want to get more benefit, you should choose the best season for removing the morbid matter is spring as a preventive cupping, and in summer is best for wet cupping. The best time is the middle of the lunar month, which lies on 17th, 19th, and 21st. These are the best dates, and the best time is 2-3 hours post sunrise. So, if cupping is indicated for therapeutic purposes, as per the customary practices, it may be performed at any time, irrespective of whether it is at the beginning, middle, or end of the month. So now coming to the SOPs for pre-cupping stage, which is pre-procedural assessment and preparation. So in this case, first of all, we have to start by taking the history of the patient, its clinical examination, taking the vitals, which includes the BP, temperature, pulse rate, and assessment of misaj and nerves. Then we have to do some laboratory examination, especially for wet cupping, like hemoglobin, CT, BT, blood sugar, HIV testing, and HB testing for hepatitis B and C. So the patient, this is very important, patient should be counseled about the procedure, and an informed consent should be read and understood and get it signed by the patients prior to doing the cupping therapy. So we have to take some precautions. The Unani clinicians have to take precautions like aseptic measures should be taken. The hairy part, if it is a hairy part, it should be shaved prior to the procedure. It should not be done during the extreme weather. We should ask the patient not to take hammam or vigorous exercises or diaphoresis, strenuous activities just prior to the wet cupping. Cupping should not be advisable on the sensitive and vital areas, especially above the liver, spleen, abdomen, kidney, breast, and acetabulum of femur. Now, this is for dry cupping. Evacuation of morbid matter may be done prior to dry cupping. In early stages of inflammation, it is not recommended. And on ulcers, open wounds, cervical adenopathy, it is not at all recommended. Now, in the last 3 months post-operative recovery phase, in this phase, it is also not advisable to do the cupping. So there are also some contraindications for hijama, like age-wise, it should not be done on children less than 12 years and in elderly as well. And immediately after, as I told you earlier, in these 3 conditions, in severe anemia, in patients with severe anemia, severe hypertension, mental instability, pregnant women, and obese patients, and patients who give history of any cardiac surgeries or any fractures in the recent time, it should be avoided. Patients, wet cupping in case of wet cupping, we have to ask the patient that we have to check the status of HIV, hepatitis B and C, and we have to ask the patient whether you are any anticoagulant, aspirin, or Coumarin, some drugs, bleeding disorders. So these are the general instructions of pre-cupping. The patient instructions involve light semi-solid diet 1 day prior, fasting for 3 hours prior to wet cupping, and the ideal time of reporting of the patient is 9 to 3 p.m. Jewelry or any clothing should be removed. The tirayah 1 hour before the cupping for Sodavi disease especially. And hammam and pashoya, however, it is not recommended or contraindicated, but in thick and rough skin people, this is recommended. So preparation of room and equipment, the room are, I have already, I think.
Madam, it is request from organizers, please. It is request from organizers, please keep it short.
I can skip this slide. So this is for cupping stage. Okay. So without going into detail, suppose for light cupping, we have to give pressure only half and 1 pull, for medium 2 pulls, and for strong 3 pulls. So this slide shows you what is dry cupping. I can skip this slide. I can also skip this slide. So these are the diagrams. They are all taken from the SOPs, which is developed from. So these are the two blades, 15 and 11 number. We should ideally use these blades because for precise incision, 11 and 15 number of blades are ideal. And you can see the scarification is done, and the size and scarification number is mentioned in this table. This is the in this book which is published, SOPs. If you need fire cupping, these yellow circles are depicts the fire hijame naria. This is the rakia. We can skip this slide. This is flash cupping. Flash, I can tell you. So in this flash cupping, there is rapid and repeated application removal of suction cups, less than 30 seconds, and several cups are applied in quick succession and immediate remove, creating a flushing effect. So total duration should not exceed 10 minutes. It improves the blood circulation and alleviates the muscle tension. So what is hijama maya? So unlike traditional wet and dry cupping, the cupping that uses only air suction, this method involves placing a small amount of warm water and liquid inside the cup before the suction is applied to the skin. The purpose is to combine the physical, mechanical, and thermal benefits of hydrotherapy. And now coming to the last part of my presentation, post-cupping stage. So in the post-cupping stage, these are the general measures. Like practitioner should protect himself by keeping the face away from the patient. The sterilized cup should be used. UV lamp will be used for sterilized cupping room. Room should be clean and disinfect first. 70% alcohol is used for sterilizing the bed, chair, and rubber sheet. Instruction for a patient in wet cupping. Patient should be asked to rest for 2 hours. Avoid heavy food in the first hour. Vigorous exercises are not recommended, and bathing in the 2 hours post cupping. So in the after the hijama, the vitals are recorded. The pain is assessed based on the numeric rating scale or a visual analog scale, and the patient is observed for post procedural complications and unusual events. The local measure, the area should be washed post-cupping with Arfe Gulab and avoid any scratching to reduce infection and coronary chances. So this is the management of complication. If the patient complains of severe pain, Musakkin alam can be given. If there is headache, then we can give Archaji. For nausea, vomiting, we can give Arfinanai and Tamarhindi. If there is excessive bleeding or accidental injury to a major vessel or vein, patient should immediately report to an refer to the higher center.
Esteemed speaker is again requested to please
Sir, I'm
cut it short.
okay. So this is the biomedical waste management.
Please conclude.
Okay, okay. I want to इसको select करना भैया. Click एक बार click कर देंगे बस ये show करना है. This is the last slide. इसको SRF को CRF को करिए. Click कीजिए click control को. Last. आप कर दो. So ये जो हमारा SOP है, the CRF, the CRF, everything is mentioned in this. So coming to the end, this is my last slide. I want to show the format and an extra for reporting the things.
Thank you very much. Very nice presentation. Any question from audience in 2 minutes, please? If you have. Madam, I have one suggestion. As the hijama is most misused regime from the regimenal therapy of Unani system of medicine practiced by coax without any precaution, without any knowledge. So you have mentioned that the qualification is BUMS and registered medical practitioner or trained therapist. So the trained therapist should not be there. Trained therapist should not allow hijama without under supervision of medical practitioner or registered doctor. Because they don't have any sense of aseptic precaution, they don't have any control on the knife, they don't have any skill of the suction of the blood. So in my opinion, the audience it should be only the under medical supervision. The trained therapist should also only to assist the doctor. He or she not be allowed to practice hijama directly without doctor. This is my opinion. So we have one Professor Irfan Sahab, big name in Rajbit Tadbir. I request you your remark in 2 minutes. So we will conclude the session and we will request the next speaker. Please, madam. Dr. Irfan Sahab is an ex-faculty of my institute. आपको माइक की जरूरत नहीं.
Trainees, they have certification, any kind of certification.
Wonderful presentation, and the suggestion what Rajvi sir given, I agree with that. मिसयूज नहीं होना चाहिए हमारी जो भी साइंटिफिक कर रहे हैं चीजों को, क्योंकि आजकल वो इसको कोई मिल जाता है, हिजामा मिल गया तो हिजामा पीछे पड़ गए, कलौजी मिल गई कलौजी कर गया. तो वो बिल्कुल सही कहा डॉक्टर साहब ने कि वो हमें ऐसी एलिमेंट्स को थोड़ा सा ऊपर रखना है. And very nice presentation going on. Anwar sir has presented very well. It's a legend in life Tadbir, I must say. So time come है.
Thank you very much. Studies में हम लोगों को ये भी देखने की जरूरत है कि पब्लिक क्वालिफाइड रजिस्टर्ड मेडिकल प्रैक्टिशनर के होते हुए कोएक्स क्यों जमा कराती है. अगर इस फैक्टर पे हम सोचेंगे तो हमको सब क्वालिटीज वो सब हम फैसिलिटीज हम देखेंगे तो हमारा वैसा प्रेजेंटेशन नहीं होता, या हमारा रजिस्ट्रेशन और डिग्री होने के बावजूद क्यों हमारे होते हुए लोग इस तरह करते हैं. तो वी शुड थिंक ऑन इट आउट. थैंक यू मैडम, थैंक यू वेरी मच. यस या Exactly. Agreed. Complications. Thank you, madam. Thank you. I'm 100% agree with you. Madam, please call next speaker. Thank you so much, madam. Congratulations for nice presentation. Congratulations.
Thank you so much, Dr. Ramana, for scholarly presentation. Next speaker, I invite Dr. Farooqi Shazia Parveenji, Research Officer, Unani, RRIUM, Chennai. And her topic is Integration of Traditional Regimens into Modern Rehabilitation Medicine. Over to you, ma'am.
As the speaker is Anjumanite, so I can instruct to please keep it short. Thank you.
Thank you, sir. Please. Honorable Chairperson, senior officers from CCRM, faculty members from various institutes, and dear participants, Assalamu alaikum, namaste, and a very warm good evening to one and all present here. Myself, Dr. Farooqi Shazia, and today I'll be deliberating on integration of traditional regimes into modern rehab medicine. So as we know, nowadays, there is a more risk globally. There is an increased risk of stroke or MSD, musculoskeletal disorders, and various type of disorders. So that time integration with the traditional regime is very important, which complement the evidence-based rehab care. So rehab. So organizer have instructed me to complete within 5 to 10 minutes. So I'll keep it short. So actually my presentation covers all these 5 points. But I will just directly go on Unani regimenal therapies. So this I want to explain the regimenal medicine. Today they play a very crucial role in restoring the function, independency in the patients with chronic illness and disability and post-surgical recovery. So despite advancement, many patients have continued to suffer with pain, stiffness, and reduced quality of life. So on the basis of that, Unani regimenal therapy can be used as a valuable holistic approach in rehabilitation care. I'll just skip and I'll go to second section. These are the 4 areas. So rehabilitation in Unani medicine basically aims to restoration of the Kuvat for normalizing the movement and function of the individual. So balancing the akhlaq, the core principle of Unani medicine, along with the massage. If it is balanced, then the individual or the individual will be in the healthy condition. So ilaj with tatbik, Unani medicine basically in regimenal therapy we use non-pharmacological therapies which support modern rehabilitation by improving the mobility, relieving pain, enhancing the circulation and restoring functions. So these are the core modalities like the जैसे Numan sir ने बताया that we have some regime which we are using nowadays more. So these are the therapies like the Tariq Riyazat, Hamam, Hijama, Takbir, Burst, Nutul, Zimad and Ilaj bil Giza. So these are the areas from where we can integrate with the modern rehab. So there are different type of massage therapy in modern parallel. And in Unani also we have a different type, like the Lion we have, the Sul we have, the Maudat, like that. Along with this we are using medicated oil. So this condition, especially in musculoskeletal condition, musculoskeletal pain, joint stiffness. So by improving the circulation, reduce the muscle tension and relieve stiffness, pain. So basically it enhances the muscle and nerve and enhance the neuroplasticity. Along with this, if we see about the clinical evidence, there are multiple systematic reviews which shows that the massage therapy significantly reduce the pain intensity and improve the functional mobility in patients with chronic low back pain, osteoarthritis, and other conditions. Riyazat, here I wanted to highlight, we in RRMG, we have a state-of-art regimenal unit. Along with this, we have the modern physiotherapy unit. So you can see here, this patient is a case of Falish, post-stroke disability. So, along with Dalak ke Khashen, we are advising the patient to do some riyazat, some modern therapies, like you can see step ladder exercise. Here you can see. This patient also post-stroke disability. So here we are giving passive movement exercise. This patient is muscular frozen shoulder case. We are doing other therapies along with Unani regimes. We are integrating with shoulder wheel exercise. Here you can see this is a Phallic patient, and this backside we place one mirror for in Unani one therapy Aina Chini. It is there. So along with this Aina Chini, we have placed the parallel walk exercise. So patient itself, while he walk, he will see himself like how I am walking. So it will strengthen the patient's muscles simultaneously. It's confident also. So along with this quadricep exercise, so here somehow we are also integrating the Unani therapies with the help of physiotherapy, our physiotherapy unit. Next is hijama. So in cupping therapy, there are different types like dry cupping, wet cupping, hijama, bishar, pilashar. So here you can see patients are coming with either they'll take painkiller, and after that they'll come to us and asking about the spasm or some cervical disc prolapse, something like that. So that time we are advising either dry cupping or wet cupping. So basically these therapies along with some systemic evidences have proven the efficacy of chronic neck pain or chronic neck pain or back pain or MSD condition. So the benefit of this cupping therapies, tantiya mawat, evacuation of morbid matter, improve microcirculation, reduce pain and inflammation, and modulate the pain pathway and provide the analgesic effect, which will provide the analgesic effect. And there are the modern evidence which supports the cupping therapy. Then leaching. So here
You continue, please. All are requested to please remain present for concluding ceremony.
So in each therapy, whenever there is vein section, first hijama is not suitable, so that time we are advising leech therapy. So leech therapy, so the main action is to improve the microcirculation and tissue perfusion, reduce the venous congestion. Here the integration, I think many of modern side. So nowadays, modern side, most of the plastic surgeons or reconstructive surgeons are using leech therapy. They are placing leech. Here I would like to share this photo. So in this you can see this is the non-healing ulcer patient after treatment, and this is the psoriasis patient. So even though with non-healing ulcer and skin diseases, so we can apply it in we can integrate in reconstructive surgeries and in plastic surgeries also. Along with this, it required the standardized sterile practice and clinical supervision. Next, Nutul. So in Nutul, the pouring of medicated decoction or oil over the affected part or indicated part. So in this condition also patient, this is also indicated in neuralgia, neuropathy, joint pain, cervical stiffness. So it will reduce the pain, inflammation and nerve irritation. Zimark, medicated qualities. So here, if the patient used to come with any type of injury, so that time along with the medicines, we can apply some medicated powder, herbal powder over the affected area. So hammam in this condition, mostly nowadays non-communicable disease or lifestyle diseases are increasing. So that time also we can advise that patient, obesity patient, to come here and put steam photo. But I really wanted to add because it is a hot water immersion with steam. So that is why I have added these two pictures from our hospital. So in this condition, obesity or other type of musculoskeletal disorder, we can use hammam. In Takmeet, so in Takmeet, these are the ingredients in our hospital. Also, we are using with the ingredient of gule, tisu, babuna, nakuna, and tukme soya. So we are preparing one type of potli and we used to apply over the affected part. And in modern Bangalore, if we see, they are also using the heating pad gel and physiotherapy, thermotherapy. And in Takmeet, in our hospital, we use wax therapy, liquid paraffin therapy also as an integrated part. So nowadays, Ilaj with the
You please show the slide. The audience will go through the slide one by one, so you can conclude the topic. Please.
Who can take photos?
share, I'll just complete, sir. So Ilajbil Giza, in Ilajbil Giza now, I think a few years back, like 10 years back, nobody was not more keen about the Ilajbil Giza. But nowadays scenario has been changed and जैसे हमारी किताबों में भी लिखा गया है कि जो है आप गिजा को जो हमारी गिजा को एज गिजा को आप जो है मेडिसिन की तरह लो तो और ये हमारे जो है यूनानी फिजिशियंस ने भी ये बाकायदा लाइन लिखी हुई है तो इसमें भी मैं ये बताना चाहती हूँ कि जैसे हमारे इलाजबिल गिजा में देयर आर डिफरेंट टाइप ऑफ गिजा इट हैज बीन डिस्क्राइब्ड इन आवर क्लासिकल टेक्स्ट like protein rich diet which is used for recovery and anti inflammatory जैसे हम माउथ शेक का जिक्र करेंगे it is used for the arthritis इवन जैसे हम अगर बलगमी अमराज का जिक्र करते हैं अगर आप विटिलिगो का जिक्र करेंगे जहाँ पर जब हमारी बॉडी में बलगमी अमराज बढ़ेगा ऑस्टियोआर्थराइटिस ड्यू टू बलगमी galbay balgami so that time we are used to advise patient not to take balgami diet or cold food so like that it has been described in our classical text. So this slide is very important. So currently, the current rehabilitation medicine approach, like physical therapy, which is particularly used for musculoskeletal disorder, exercise physiology, it is used for neuro rehabilitation, occupational therapies, and pain management. अगर हम इसको इंटीग्रेट करना चाहें तो वी कैन ऐड फिजिकल थेरेपी विद दलक मसाज विद मेडिकेटेड ऑयल एंड सिनर्जिस्टिक प्रोटोकॉल लाइक एक्सरसाइज प्रिस्क्राइब्ड prescription of exercise by assessing the massage of the patient. Next patient जैसे हम बता रहे हैं कि individual मिजाज के हिसाब से हमें patient को जो है medicine along with the therapies advise करना चाहिए तो offering the JAMA as an alternative to pharmaceutical pain management. Next, specific condition for integration like musculoskeletal disorder along with this physical therapies. You can add Dalat Riyazat and Nijama, which if we see in public domain, there is a strong evidence for chronic pain and arthritis. In neurological rehabilitation, we can give Ilajbil Dalat Riyazat like Dala ke Khashan, we can give Riyazat as an advice, parallel therapy along with Aina Chini and Ilajbil Giza. We can add Maush Shahid. This gives promising for both stroke and neuropathy, chronic pain syndrome. In this condition, Hijama, Natul, and Simar Hamam we can advise, and it gives strong, moderate to strong evidence for non-pharmacological management. So, along with this, we should also focus on the safety protocol and quality assurance. इसका मतलब ये नहीं हमें इंटीग्रेशन कर दिया है तो हम कहीं भी उसको स्टार्ट कर देंगे. We should focus on quality assurance and study safety protocol. As Dr. Tamanna Nazli ma'am has said कि जब भी हिजामा कराना है तो then you have to go for investigation. तो जब भी आप हिजामा बिला शर्त विश शर्त करा रहे हैं या फर्स्ट करा रहे हैं तो you have to screen for the bleeding disorder. You have to evaluate the cardiovascular disorders for hamam because आप जब hamam करा रहे हो या तकमील करा रहे हो तो उस टाइम पे अगर patient जो है patient में fall down. So these are the research evidence, key findings. Research gap. जब भी हम इंटीग्रेशन कर रहे हैं तो दैट टाइम वी हैव टू थिंक वेयर वी आर लैकिंग सो इफ इंटीग्रेशन वी शुड बिल्ड सम RCTs with the integration okay these are future direction. Conclusion, I would like to say, by bridging the ancient wisdom with modern science, we can expand our therapeutic toolkit and better serving diverse patient population in rehabilitation setting. Thank you.
Thank you very much. Congratulations for nice presentation. Any question from audience for 2 minutes, please? Yes, please. No questions. Okay. Last presentation you have. मैडम बहुत अच्छा प्रेजेंटेशन था. मेरी एक रिक्वेस्ट है रिमार्क्स की बदले को ये कि जब आप इस तरह का प्रेजेंटेशन दे तो वेनिसेक्शन और फर्स्ट जब आप बताएं या जब आप रेजिमिनल जब आप कपिंग और हिजामा बताएं तो दोनों में एक हेयर लाइन डिफरेंस है. तो ऑडियंस के लिए उसको एक्सप्लेन करें ताकि ये ऑडियंस ना समझे कि कपिंग ही हिजामा है. कपिंग is a close term for hijama but not it is hijama, and first is the closest term for first is venesection, but first is far away and very much important and effective than the venesection, general venesection. Thank you so much. Thank you.
Thank you so much, ma'am. And today we have Dr. Shaista Uruz, Research Officer Unani, RRIUM Delhi, and her topic is use of AI-related interventions in the advancement of regimenal therapy.
So, this time constraints, so I'll get off everything. My PPT, look, I've made a lot of efforts in making it, so I'm not going to get down a good mess. But you made a PPT. This is not me, actually. Okay, so till now we have been talking about regimens, how do we do it, but safety procedures, data generation, evidence-based, ये सब की बात होगी. So how do we do it? I think the most convenient and easy way of doing it when we incorporate AI, because whatever we do, humanly we lack somewhere कि हम vitals छूट जाते हैं या हम pressure नहीं ले पाते या हम temperature कर जाते हैं या कभी जैसे हमारी फायर कपिंग है उसके अंदर फायर कपिंग है तो कभी बर्न्स हो जाते हैं कभी ब्लिस्टर्स हो जाते हैं. So how do we overcome all this and how do we generate data at every stage कि हमारा प्रेशर कितना है, हमारा बीपी कितना है, पोस्ट बीपी कितना है, हमारा साइट का टेम्परेचर. So here we are, role of AI in RD. Next slide, please. I've asked him to do it. Okay, so why do we need it? We need it so that we can isolate the variables, scientifically trace the differences, because किसी में we get some effect, किसी में नहीं आता है. So why? Then so that we can have a clinical comparison with the two patients that we're doing. अगर हम cupping कर रहे हैं या हम valve कर रहे हैं, whatever, as we'll see. So what is the difference? What happens in the body and हमारे जो therapy उसमें क्या difference होता है? That we can measure if we are taking AI into it. So the goal is to define therapy by measurable parameters. Okay. So when we take valve, बच्चे का हाथ जो होगा वो बहुत soft है. तो अगर हम उसे बोले सुल्ड valve भी करो, then also वो सुल्ड नहीं हो सकता. It is like so. हाथ का जो प्रेशर है, स्किन का जो टेक्सचर है, उससे भी हमारे गल्फ में चेंजेस आ सकते हैं. सो दैट इज अगेन व्हाई वी नीड AI. So AI के लिए I'm not giving because I haven't developed anything. This is my hypothesis, and I'm presenting hypothesis, and I'm encouraging all of you to take these up and to develop studies so that we can benefit RD. So अगर हमारे पास इस तरह की मशीन होगी, then we have to calibrate. We can calibrate how much oil we are using, the temperature, the strokes, किस तरह के strokes हैं, कितने बड़े हैं, कितना pressure है, all this, and therapeutic drift.
पर पेशेंट जो हमारा थोड़ा बहुत चेंज हो जाता है, ऐसे पेशेंट वही मसल्स ने अगर 3 पेशेंट्स को मसाज किया, देन बाय द टाइम द थर्ड और द फोर्थ वो थक जाता है. So जो प्रेशर वो लगा रहा है, the weight that muscles is doing will obviously change. So that is the therapeutic drift. So with AI we can overcome that as well. So now let's get
Madam, organizers are requesting.
that I am also doing. Yes, but I'm rushing.
All right.
So देखिए इसके अंदर this is the AI generated chart. I think rather than a CRF we can have this. इसमें we can have all the types of curve that we are having. उसमें कितना pressure है, कितना oil use कर रहे हैं, and कितने minutes का दे रहे हैं. That we can have, and at the end of the day we have an auto generated report जिसमें कितना area use किया, कितना कौन सा type of gun थे, कितने ml of oil था, कितना pressure था, duration, and again the inputs from the patients also कि discomfort था, कोई skin reactions तो नहीं, तो adverse events भी इसके अंदर हो जा रहे हैं. So this will be a one sheet CRF जो कि हमें auto generated मिल जाएगी, and तो ये हमारा clinical. As now we are talking of Nutul. Nutul में if we have this kind of machine, तो we can have oil dripping in it, we can have a shower, hand shower type of thing जिससे हम steam दे सकते हैं, patient को localized steam कर सकते हैं, and इससे अगेन मेस और जो वेस्टेज है वो सब कम हो जाएगा. तो इसका भी we have this kind of a module. So we start with initialization कि अपने पेशेंट का डेमोग्राफी ले ली, then we have a configuration कि हमने बता दी हमें इतना ऑयल चाहिए. So हिजामा अगेन, हिजामा में भी we have many things, जैसे कि हमारे पास बेड है, फायर है, ये ऐसी चीजें जिसके अंदर बहुत सेफ्टी पैरामीटर्स आते हैं. With this we can have the safety and the waste दोनों को भी हम इसमें incorporate कर सकते हैं. Then we have an auto generated report that we have here. So to have all this, so maybe हमारे पास है, we have an artificial reach also with us. So उसके भी हमारे बहुत benefits हैं कि infections वगैरह नहीं होते. Then we have venesection again, उसमें भी we can use it to find out the ये veins and to measure कितना हमारा outcome आया है उसका. Then again waste disposal, उसके अंदर monitoring जो कि because these things उसमें monitoring बहुत important है. MMT में हम हर stage पे urine का liquid chromatography करके we can have कि कब हमें नुस जाया. हर day पर हम बता सकते हैं कि okay आज urine कैसा था, कल urine कैसा है. Urine के analysis and report हमें मिल सकती है. So हमें पता चल जाएगा, मुझसे हम दे रहे हैं तो बीपी कितना कम हो रहा है, पर आवर के हिसाब से भी हमें रिपोर्ट आ सकती है. So के लिए like we have a urine spectrometry के लिए we have special container जिसमें urine करते हैं. वैसे हमारे पास अगर के लिए होगा, so again we can see कि contents क्या है के, कितने quantity में आ रहा है. तो that way again we can have all these things कि patient की safety again will not be compromised. Before again we can have that. ये हमने बनाया था कि हम initiation, dosing, exposure and then report उसकी बनेगी. So all this is good, but this cannot happen unless we have SOP for it. And Alhamdulillah, CCRM has taken the first initiative in making the SOPs. I encourage other institutions as well to make SOPs on various ilaj with these so that we can go in and have automation of our therapies, which is the need of the hour. Thank you so much.
Thank you very much. Any question, please? Nice presentation. Yes, please. This is a big discussion, sir.
और AI को अगर हम incorporate करते हैं तो it is just like हम अपने paper में कौन सा quality of paper use करते हैं वैसे.
Thank you very much, madam, for this nice presentation. And on behalf of the all chairperson, I am thankful to the CCRUM for giving us this opportunity. Thank you very much.
And I request all the chairs and the speakers to kindly come up on the stage for the felicitation. Dr. Rashid Kazi ji, Dr. Seher, Dr. K. Kabiruddin Ahmed ji, आप कृपया मंच पर पधारें. And I also request Professor Mohammad Anwarji, Dr. Noman Anwarji, Dr. Tamanna Nazli Dr. Faruqi, Shazia Parveen ji, and Dr. Shaista ji to kindly come up on the stage. Standing chairperson and the speakers. Thank you very much. Now I request Dr. Rashid Kazi to felicitate Professor Mohammad Anwarji. Thank you so much. थोड़ी तालियां हो जाए सबके लिए, थोड़ा सा अपने प्रेजेंटेशन यहाँ पे दिया है. I request Dr. K. Kabiruddin Ahmed sir to felicitate Dr. Noman Anwarji. Thank you so much. I request Dr. Najmus Seher ma'am to felicitate Dr. Tamanna Nazli. Thank you very much. Request Dr. Rashid Kazi sir to felicitate Dr. Faruqi Shazia Parveen ji. And request Dr. K. Kabiruddin Ahmed sir to felicitate Dr. Shaista Purus. May I request Dr. Zaki Siddiqui sir to kindly come on the dais and felicitate the chairpersons of this session. सबसे पहले प्रोफेसर डॉक्टर राशिद काजी जी. Very much. Dr. Najmus Seher ji. Thank you very much. And Dr. K. Kabiruddin Ahmed ji. Thank you so much. And our photographer is here, so chairperson or speakers, please come forward for a group photo. Sir, आप भी आइए. ये group photo के बाद immediately we'll take just few minutes of break to just rearrange the stage for the valedictory function. I request everyone to kindly be seated in the auditorium itself. We will be starting valedictory function in just few minutes. Thank you so much once again to all the speakers and the chairperson. And just after a brief rearrangement of the stage, we will be starting the valedictory function in just few minutes. Thank you. आप सभी कृपया यहीं बैठे रहें. बस कुछ ही समय में, कुछ ही मिनटों में हम क्लोजिंग सेरेमनी की शुरुआत करेंगे.
आगे भी खाली है भाई
स्वागत करेंगे चीफ गेस्ट ऑफ वालिडेटरी फंक्शन प्रोफेसर असीम अली खान साहिब, गेस्ट ऑफ ऑनर डॉक्टर M.A. कासमी जी, हम मंच का स्वागत करेंगे। कहते हैं मंच वो नहीं जहां पर चेहरों की तादाद हो, मैं डॉक्टर मुंशी साहब से निवेदन करूंगी, आग्रह करूंगी कि आप with a shawl, bouquet and a memento. डॉक्टर M.A. कासमी जी, आपका भी सम्मान करने की मैं विनती करती हूँ डॉक्टर मुंशी साहब से। डॉक्टर M. Thank you very much. We are felicitating all the guests with a shawl, a beautiful memento. अजीज साहब का भी सम्मान करने की मैं विनती करती हूँ डॉक्टर मुंशी साहब से। थैंक यू वेरी मच। And National Conference on Unani. 2 days National Conference on Unani. We are request Dr. Munshi ji to felicitate Hakim Khurshid Murad Sahab, Chairman Vedant Group, Bareilly. पूरे भारत Masroor Qureshi ji to present a floral bouquet Dr. Yunis Iftikhar Munshi ji, Deputy Director General, CCRUM. Sir, we have 2 special felicitations. I would like to invite on Dr. Rashid Kazi ji, एनर्जी। तालियों के साथ हम सभी मान्यगणों का और स्पेशल फेलिसिटेशन जिनका है उनका भी स्वागत करेंगे। And I request Asim Ali Khan Sahab to felicitate him. Thank you very much, sir. As the sun is setting on the beautiful evening of 15th February 2026, the closing ceremony of Unani Day 2026 and National Conference, I would like to invite Dr. Yunus Iftikhar Munshi Sahab, Deputy Director General CCRUM, to proceed.
Words of encouragement reflect the strong and unwavering policy support of the Government of India towards AYUSH system, including Unani system of medicine. The inaugural ceremony was further graced by the distinguished presence of Shri Babasaheb Patil, Honorable Minister of Cooperation, Government of Maharashtra, Dr. Manisha Upendra Kotekar, Chairperson, National Council for Industry of Medicine, and other distinguished guests. Their insightful addresses and encouragement greatly enriched the proceedings and strengthened our collective resolve. During the inaugural session, several important and landmark publications were released in the august presence of the dignitaries. These included the conference souvenir, National Formula for Unani Medicine Part 2, revised edition, preclinical studies, a compendium of abstracts, Taziniat, cosmetology, a compendium of classical evidence-based Unani drugs for cosmetic care, Al-Mughanif Tadbir Al-Amraz, Wal-Ma'rifat Wal-Ard. It's a Urdu translation, and standard operative procedures for various Unani regimenal therapies, including Tariq al-Alq, leech therapy, Tabkhiro Intibab, steam and liver bath, fumigation, Bahur, Doshi, Natur, Dalk and massage, and Muzijal muscle therapy, which is known as concomitive and purgative therapy. These publications represent significant milestone in the documentation, standardization, and evidence generation in the United system of medicine. Collaboration is the crucial step towards the strengthening of the United system of medicine, as it brings together the traditional knowledge with modern scientific methods. In this spirit, we exchanged one international MOU with Lotus Holistic Healthcare Institute of Abu Dhabi, marking the significant step towards global cooperation. Additionally, 8 national MOUs were exchanged with reputed institutions like IIT Mumbai, NIPIED Secunderabad, MIT University Mumbai, SPKM Pharmacy College Mumbai, MIJT Tibia Unani Medical College Mumbai, Tata ACJRAC Navi Mumbai, Monazar National Urdu University Hyderabad, and Hamdard Laboratories New Delhi. We also achieved several important digital and institutional milestones during this occasion. These include the launch of web portal for CCRM collaborative expression of interest projects aimed at promoting structural and transparent research collaboration. Mobile applications including Unani Ahar, featuring food recipes based on Unani principles, the Hindi version of Common Remedies, in Unani medicine, Marathi version of the same book, and the questionnaire for the assessment of mizaj, facilitating standardized clinical evaluation. The program also witnesses the presentation of an annual accreditation certificate to the biochemistry and pathology laboratories of RRI Mumbai, recognizing excellence in the laboratory diagnostics and quality standards. Additionally, a video teaser highlighting the recent initiatives of the CCRM was also released, showcasing the Council's ongoing efforts in research, innovation, and outreach. Certificates of appreciation were presented for the best published research papers, outstanding contribution of Unani medicine to eminent Hakims, and for best performing institutes and units of CCRM, acknowledging excellence and dedication in the field. The 2 days of scientific deliberations have been found profoundly enriching, bringing together some of the brightest minds to deliberate on the theme innovation and evidence in Unani medicine. The scientific sessions witnessed enthusiastic participation from experts, academicians, researchers, and scholars, making the discussion lively, meaningful, and forward-looking. We are privileged to receive keynote addresses from eminent personalities, including Professor Syed Shah Alam, Director, National Institute of Unani Medicine, Bangalore, Dr. Raman Mohan Singh, Director, Pharmacopoeia Commission of India, Indian Medicine and Homeopathy, Dr. Raghu Arakan, Advisor, Minister of AYUSH, and Deputy Director General, DGHS, Minister of Health and Family Welfare, Government of India, and Professor Dr. A.W. Santosh Kumar, Honorable Vice Chancellor, MIT University, Mumbai. A panel discussion on the theme innovation and evidence in Unani practice further enriched the deliberations. The overwhelming response from the delegates is a testament to the growing interest in medicine. The conference witnessed participation of almost 800 registered delegates physically, and along with online participation of 25 delegates. This reflects the expanding reach of this system. Across 9 scientific sessions, esteemed speakers deliberated on diverse themes, including innovations in Unani system of medicine, drug development, evidence-based research, translational research, advancement in Ilaj with Visa, innovations in clinical practice and disease management, recent advancement in Unani research, Ilaj with Talbina and wellness, the role of genomics and artificial intelligence, evidence-based perspectives from Unani classics and drug standardization. The technical sessions were enriched by experts from leading institutions such as IIT Mumbai, IICT Hyderabad, CCMB Hyderabad, NRIT Chennai, University of Delhi, Aligarh Muslim University, Jamia Hamdard, Symbiosis International University, DIT Vellore, NB, PGR New Delhi, Osmania University, and many other reputed national institutions. The discussions clearly highlighted that Unani medicine, with its holistic approach encompassing lifestyle modifications, nutraceuticals, and preventive health care, has immense potential to integrate seamlessly into the modern healthcare strategies, offering comprehensive and balanced solutions. The presence of media during the conference has brought much desired attention from stakeholders across the country and abroad, further strengthening the visibility and credibility of the Unani system of medicine. I take this opportunity to sincerely appreciate the tireless efforts of the officers and staff of CCRM headquarters and RRIM Mumbai, whose dedication and commitment made this event a grand success. I also extend my heartfelt thanks to all delegates, speakers, and resource persons for their valuable contributions. In conclusion, I express my deepest gratitude to all participants, supporters, and especially the organizing committee for their untiring efforts. Let us leave this gathering inspired and determined to uphold the legacy of Unani system of medicine while steering it towards a future marked by innovation and evidence. Together, we can chart a path where Unani medicine becomes an integral component of global health. Thank you very much. Jai Hind.
Thank you very much, Dr. Munshi Saab, for a quick review of 2 days conference. इसके बाद मैं गुजारिश करूंगी हकीम खुर्शीद मुराद साहब से, जो बरेली के वेदांत ग्रुप के चेयरपर्सन हैं। मैं आपसे निवेदन करती हूं, कृपया आप इस समापन समारोह में अपने विचार साझा करें।
मैं आपकी सब हजरात का दिल से और आपकी मोहब्बत का शुक्रिया अदा करता हूँ, और एक शेर से बस इख्तिताम पे हूँ कि ज़फ़र आदमी उसको न जानिएगा, हो कितना ही साहिबो फहमो ज़का, जिसे ऐश में यादें खुदा न रही, जिसे तैश में ख्वाबे खुदा रहा।
Thank you, sir. Moving ahead in this valedictory function, I would like to request Dr. Zahir I. Qazi Sahab, President, Anjuman Islam College, Mumbai, to say a few words on this occasion.
Assalamu alaikum warahmatullahi wabarakatuh. नमस्कार। मुझे ये पता नहीं था कि स्टेज पे आके मुझे भी कुछ बोलना पड़ेगा। Rashid Qazi, you are very mischievous. You told me come and attend and look at how people what they talk about. 2-day convention of Unani experts, practitioners, and also manufacturers and dignitaries from CIM. किसी भी वर्कशॉप का या 2 दिन के डेलिब्रेशन का एक मकसद होना चाहिए, एक रेजोल्यूशन होना चाहिए एट द एंड ऑफ द इवनिंग कि हम क्या एक स्पेसिफिक इशू लेके चले फॉर रिसर्च एंड इनोवेशन। तो आपका जो वैलिडिक्टरी एड्रेस था, मैं गौर से सुन रहा था, आपने एक बात कही food related recipe. This is one good thing that all of you can pick up. खाए बगैर कोई जिंदा नहीं रह सकता, दवा के बगैर रह सकता है. And you have access to digital platform to reach out different corners of the country and beyond India, हिंदुस्तान के बाहर भी. और आपने एक अच्छी बात कही कि प्रिवेंटिव मेडिसिन, यूनानी एक ऐसी पैथी है that will progress and achieve milestones with respect to preventive medicine. हमारे एलोपैथी में बहुत सारे ऐसे ग्रे एरियाज हैं. There are gray areas where we don't have a cure. We do cure. We do control the disease. But there are areas we have no answers. Especially chronic diseases जो है, इसमें यूनानी आयुर्वेदा का एक बेहतरीन रोल है, लेकिन it has not come in an optic form that it should be done. अभी मैं एक वाकया आपको बताऊंगा. One fine morning I got a call कि मेरे जो डायग्नोस्टिक सेंटर में एक DM cardiologist, he was hardly 40, and he had gone for workout, got cardiac arrest and passed away. अभी जो शख्स DM कार्डियोलॉजी में गोल्ड मेडल लेके KEM में असिस्टेंट प्रोफेसर का रोल कर रहा है, रूटीन सुबह में जाके अपने एक्सरसाइज कर रहा है, गेट्स अ कार्डियक अरेस्ट. He must have missed out something on preventive measures at the end of the day. अभी नौजवानों को आप देखिए, they sit with their laptop for hours together, and some of the eminent doctors who work round the clock in the age group of 40 and 50, they pass out of massive heart attack. तो लाइफस्टाइल, जो बात ये होगी कि लाइफस्टाइल, आपने बहुत अच्छी बात कही. लाइफस्टाइल के बारे में प्रिवेंटिव मेडिसिन जो है, यूनानी कैन प्ले अ ग्रेट रोल. लेकिन एक हम मराठी में बोलते अडचण आहेत आणि कुछ स्पीड ब्रेकर है समवेयर. मुझे याद है कि हमारा जो यूनानी मेडिकल कॉलेज है, इट इज प्रॉब्ली द ओल्डेस्ट इन महाराष्ट्र. और मैं जब अंजुमन का भी सदर हूँ गुज़िश्ता 16 साल से, एंड इट इज नॉट अंजुमन कॉलेज, इट इज अंजुमन ग्रुप ऑफ इंस्टीट्यूशन, जिसमें 1,10,000 बच्चे पढ़ते हैं और 20 कॉलेजेस हैं, बहुत सारे हैं जो यतीम खाने हो गए. तो जब मैंने पहला उदा संभाला, वो चेयरमैन ऑफ यूनानी मेडिकल कॉलेज, मेरा एक ख्वाब था कि मेरी वाबस्तगी बॉम्बे हॉस्पिटल से थी, हिंदुजा से थी. तो मैंने सोचा वो एक जर्नल आता है बॉम्बे हॉस्पिटल का, बहुत मशहूर जर्नल, ओपी कपूर साहब उसके एडिटर थे. तो मैं जब तिबिया में आया तो आई ट्राई टू एनकरेज कि तुम्हारी पैथी भी जोरदार है, बहुत कुछ आप कर सकते हैं. जो कभी कभी ऐसा ऐसे कमतरी का जो सिचुएशन आ जाता है, वो नहीं होना चाहिए. फिर हमारे साहब उन्होंने कहा, सर मैंने अल्सरेटिव कोलाइटिस का एक अच्छा ट्रीटमेंट किया है एंड डॉक्यूमेंट्री एविडेंस है विद बेरियम एनिमा. तो आई सजेस्टेड तुम पेपर लिखिए, मैं उसको पब्लिश करवाता हूँ. वो पेपर लिखते ही रहे हो, पब्लिश हुआ ही नहीं. मैं क्या बताना चाहता हूं कि देयर इज सम लिथार्जी. जिस स्पीड से आपको जाना है वो आप नहीं जा रहे, और आप अपनी पैथी के साथ नाइंसाफी कर रहे हो. एक वक्त ऐसा आया था कि हमारे उस वक्त के प्रिंसिपल, वो CCM के प्रेसिडेंट भी थे, तो मुंबई के बहुत मशहूर न्यूरोलॉजिस्ट, ग्रैंड मेडिकल कॉलेज के प्रोफेसर थे वो, डॉक्टर चिको वास. तो उन्होंने मुझे कहा कि वर्ल्ड हेल्थ ऑर्गेनाइजेशन की तरफ से एक सिग्नल आया है कि अल्जाइमर्स के लिए यूनानी में कुछ नुस्खा है। तो 2 मिनट है, टेकिंग टू मच टाइम। हाँ सर, अल्जाइमर्स का कुछ नुस्खा है क्या? तो यूनानी में कुछ है, उन्होंने कहा। और होली फैमिली हॉस्पिटल में एक सेटअप बनाए कि रिसर्च करेंगे। आपकी तिबिया कॉलेज को इन्वॉल्व कीजिए। वो इतने स्लो रहे, मेरा कॉलेज है, मैं उसका चेयरमैन हूं, लेकिन ये चीज सब जगह देखी जा रही है कि आपको जो अपॉर्चुनिटीज आती है आपके सामने, आप उसको ग्रैब नहीं कर पाते। मुझे डॉक्टर राशिद काजी ने आज बताया, मैंने एक सवाल पूछा, आज की 2 दिन का जो कॉन्फ्रेंस थी उसमें कंस्ट्रक्टिव और इनोवेशन कुछ था, तो उन्होंने कहा बहुत इनोवेटिव था फॉर के। तो मैं सब छोड़ पाड़ के बोला मुझे यहाँ जाना है, क्योंकि मैं यूनानी के साथ जुड़ा रहना चाहता हूँ। और जब हमारा छोटा सा मेडिकल कॉलेज था उसको बड़ा करने में बहुत कोशिश की वगैरह वगैरह। तो पहली बार 1998 की बात कर रहा हूँ, वो एक वाहिद यूनानी मेडिकल कॉलेज था जिसमें स्टेट ऑफ आर्ट सिटी स्कैन, अल्ट्रासाउंड था, ऑल इक्विपमेंट में प्रेजेंट। वो इसलिए कि रिसर्च वर्क करके उसका डॉक्यूमेंटेशन किया जाएगा। आप कुछ मेडिकेशन ऐसा है, गॉल ब्लैडर स्टोन जो है वो डिजॉल्व होता है, किडनी स्टोन डिजॉल्व होता है, होता होगा शायद, इट्स पॉसिबल। लेकिन जब तक तुम उसको डॉक्यूमेंटेशन नहीं करोगे तुम्हारे रिसर्च, एंड देयर इज लॉट ऑफ स्कोप। आज के दौर में नोबडी वांट्स टू गेट ऑपरेटेड, दे वांट नॉन इन्वेजिव मेथड्स। और आपकी, और एक मैं विचार आपको बताता हूँ, मेरा टोटल हिप रिप्लेसमेंट हुआ था, उससे पहले आई वांट टू डू स्ट्रेंथनिंग एक्सरसाइजेस। नॉर्मली लोग करते हैं, दिस इज प्लान। तो मेरे फिजियो के पास गया तो वो कपिंग थेरेपी कर रहा है, हाईली क्वालिफाइड फिजियोथेरेपिस्ट। बोले तुमको मैं कपिंग भी करूंगा। ये तो अपना तिब्बी वाला मामला है। फिर आई हैड टेनिस एल्बो मीडियल साइड होता है, साइड बाय साइड। फिर गोल्फर्स एल्बो हो गया वो सोनोग्राफी का। तो एक्सरसाइज गया तो उसने भी मुझे कपिंग किया, हाईली क्वालिफाइड फिजियोथेरेपिस्ट। तो दूसरे लोग इसको अपना रहे हैं, आप कहाँ हैं? अभी हमारा एक अलुमनाई गेट टुगेदर था दुबई में 2 हफ्ते पहले, 200 का रजिस्ट्रेशन था, ओवर रजिस्टर 300 पीपल। एक तिबिया का ग्रुप आ गया, 2 लड़कियां थी, एक साहब थे। वी हैव फॉर्म अ काइंड ऑफ अ एडवाइजरी सेटअप इन दुबई एंड तिब्बे नबी को लेके, एंड वी आर गेटिंग गुड रिस्पॉन्स एंड आई वाज वेरी हैप्पी। लोग ये सब कर रहे हैं। आज यूरोप में तिब्बे नबी के बारे में बहुत सारी इंक्वायरी होती है, लोग वी हैव अडॉप्टेड। आयुर्वेदा को देखिए आप, a very success story now, and the credit goes to manufacturers. वो अगर इन ए साइंटिफिक मैनर में मैन्युफैक्चर करके उसकी अच्छी पैकिंग करके जिस मॉडर्न मेडिसिन है उसको प्रेजेंट कर रहे हैं, तो आयुर्वेदा हैज अचीव्ड एक्सेप्टेबिलिटी अक्रॉस द ग्लोब। तो यूनानी ने भी करना, ये दोनों अपने ही है ना, मोसेरी बहने हैं, बेसिक फाउंडेशन वही है। तो मैं एक फंक्शन अटेंड कर रहा था कैंसर का, उसमें तिबिया का एक बंदा जो हमारे कॉलेज से पढ़ा था, सरफराज शेख, उसने प्रिवेंटिव बारे में मलिग्नेंसी कैसे प्रिवेंट कर सकते हैं, एंड ही स्पोक अबाउट द डाइट, ही स्पोक अबाउट द स्टमक, एंड देयर वर पीपल हु हैड कम फ्रॉम यूएस, दे अप्रिशिएटेड एंड दे वर टेकिंग डाउन द नोट। उसको बोला तुम्हारा नंबर मुझे दे दीजिए। So there is always a scope, and there is a tremendous scope. मैं आपका ज्यादा वक्त नहीं लूंगा, एक बात कहते रहूंगा कि मेरा जो लगाव यूनानी से है, हालांकि मैं आई एम एन एलोपैथी पर्सन, आई डोंट नो वेदर यू आर अवेयर, आई एम एमडी रेडियोलॉजिस्ट ट्रेन इन वेस्ट। मैं चाहता हूँ ये दोनों पैथी आयुर्वेदा यूनानी को प्रमोट करने की बहुत जरूरी है, क्योंकि हम में कुछ ऐसी चीजें हैं जो बीमारियां, उसका हमारे पास जवाब नहीं है। ये कोलैबोरेटिव एफर्ट अगर होता है तो हेल्थ केयर, और अगर आयुष एग्जिस्ट ना होता तो हिंदुस्तान की रूरल हेल्थ स्कीम वुड हैव कोलैप्स्ड। MBBS एलोपैथी डॉक्टर्स रूरल एरियाज में नहीं जाते, झोपड़पट्टी झुग्गियों के आसपास प्रैक्टिस नहीं करते। यूनानी और आयुर्वेदा वाले डॉक्टर वहां बैठते हैं और बेहतरीन खिदमत अंजाम देते हैं। एक बार ऐसा हुआ था कि एंटी-ट्यूबरकुलर बिल आ रहा था पार्लियामेंट में, तो आपके परचुरे साहब हैं, आप जानते होगा उनको, आयुर्वेदा के महागुरु पुणे से, वो मेरे पास आया एक बार कि ये गड़बड़ हो गई, आप हमारे साथ आएंगे क्या? बोले ऐसा, व्हाई डू यू वांट मी टू कम? बोले यू बी इन द फोरफ्रंट, यू आर फ्रॉम एलोपैथी एंड यू स्टैंड फॉर अस। तो हम सबसे मिले उस जमाने में, सुषमा स्वराज ये वो, तो सब हैरान थे। उसमें से वो मिसेस महाजन MP थी, उन्होंने बोला डॉक्टर साहब तुम तो MD मॉडर्न मेडिसिन में हो, इनके साथ कैसे आए आप? बोले इसलिए आया कि अगर इनके साथ नहीं रहूंगा, ये बराबर नहीं चलेगा, तो इंडिया की रूरल सिस्टम विल कोलैप्स। तो आपके एहसानात हैं इस मुल्क पे, और ये एंशिएंट मेडिसिन है, इसको जिंदा रखना है और इसको आगे बढ़ाना है। मुझ जैसे नार्टिस्ट से जो भी हो सकेगा, आप रिप्रेजेंटेटिव मौजूद है। एक रिसर्च का आपने एक बात कही, रेसिपी की,
बहुत बहुत शुक्रिया।
यूनानी फूड एंड रेसिपी की अगर आपको रिसर्च करना हो तो मेरे यहाँ 2 केटरिंग कॉलेजेस हैं विच आर वर्ल्ड क्लास, उसका प्लेसमेंट इज 100%। अगर आप रिसर्च वहां करना चाहते हो, आई विल मेक अवेलेबल द फैसिलिटीज फॉर यू। बहुत बहुत शुक्रिया। अस्सलाम वालेकुम रहमतुल्लाह, नमस्कार।
Thank you so much, Dr. Qazi Saab, for your encouraging words. This 2-day national conference and intellectual gathering has provided an important platform to reflect upon rich legacy and bright future of Unani medicine. Now, may I request guest of honor, Dr. M.A. Kasmiji, Advisor Unani, Ministry of AYUSH, to express his thoughts.
बिस्मिल्लाहिर्रहमानिर्रहीम। प्रोफेसर आसिम अली खान साहब, प्रेसिडेंट बोर्ड ऑफ यूनानी सिता सोवल इकबाल, मिनिस्ट्री ऑफ आयुष, गवर्नमेंट ऑफ इंडिया, डॉक्टर जहीर काजी साहब, अंजुमन इस्लाम प्रेसिडेंट, अंजुमन इस्लाम तिब्बे कॉलेज, डॉक्टर खुर्शीद मुराद साहब, हकीम खुर्शीद मुराद साहब, माफ कीजिएगा मैंने डॉक्टर कह दिया, आप पसंद नहीं करते हैं, और डॉक्टर मुंशी साहब, और यहाँ हाल में मौजूद तमाम हाजिरीन, मेरे दोस्त अहबाब। 2 दिन की कॉन्फ्रेंस हम लोग बहुत ही दूर दराज से आकर के यहाँ सुन रहे थे, और जाहिर सी बात है कि इनोवेशन पे एक कॉन्फ्रेंस थी। इस शायर ने कहा है कि आंधी मगरूर दरख्तों को पटक जाएगी, आंधी मगरूर दरख्तों को पटक जाएगी, बस वही शाख बचेगी जो लचक जाएगी। आंधी मगरूर दरख्तों को पटक जाएगी, बस वही शाख बचेगी जो लचक जाएगी, और आसमां छूने का हो जाएगा खुद अंदाजा जब जमीन पांव के नीचे से निकल जाएगी। अधिक दोस्तों, ये जो डिलिबरेशन 2 दिन की कॉन्फ्रेंस में हुई है, मैं उसको रिपीट नहीं करना चाहता हूँ। रियली ये बहुत ही एक्सीलेंट कॉन्फ्रेंस थी, और ये यूनानी डे जो हम 10 साल से मना रहे हैं, एक ऐसे शख्स की याद में मनाते हैं कि जब उसने ये देखा कि 1939 में देसी तिब्बों पर पाबंदी लगा दी गई, कोई प्रैक्टिस नहीं कर सकता था, तो एक दर्दमंद दिल उसने तमाम वैदों को अपने साथ में लेकर के और एक हिंदू महासभा के साथ उसने तय किया कि नहीं, इस सिस्टम को जिंदा रहना है और इस पैथी को हमें आगे बढ़ाना है। लेकिन उस जमाने का सबसे बड़ा मसला ये था कि जितने लोग भी थे वो खानदानी हकीम थे, जो प्रैक्टिस करते थे आमतौर पे एक लिगेसी के तौर पर करते थे। कोई ऐसा निज़ाम नहीं था जहाँ पे सिलेबस, रिसर्च और इन सब चीज़ों का नाम लिया जाए। तो हकीम अजमल खां के नाम से हम यूनानी डे क्यों मनाते हैं? उसकी बुनियादी वजह है कि हकीम अजमल खां साहब वो वाहिद शख्सियत थे जिन्होंने ये तय किया कि हमें जो है सिलेबस, इसका जो है कोर्स डिज़ाइन और फिर इसमें रिसर्च ये करेंगे तभी जा करके हमारा सिस्टम जो है रिकग्नाइज होगा, तभी लोग इसको वैल्यू देंगे। गवर्नमेंट ऑफ इंडिया ने उसके बाद जो है ये सब चीज़ें बन गई, उस डिटेल में नहीं जाना चाहता। गवर्नमेंट ऑफ इंडिया ने जब CCIM बनाई 1972 में, फिर उसके बाद उसमें ये सारी चीज़ें रखी गई कि उसमें सिलेबस बने, कोर्स, करिकुलम, कॉलेज, उसका स्टैंडर्ड, सब चीज़ें मेंटेन की गई। और इसके साथ ड्रग स्टैंडर्डाइजेशन के लिए भी उन्होंने काम किया गवर्नमेंट ऑफ इंडिया ने, और उसमें जो है PCIM, PLIM, फिर उसके बाद नए जो है हमारा बोर्ड, जिसके हमारे जो है यूनानी और सिद्धा के इस वक्त प्रेसिडेंट हमारे आसिफ अली खान साहब हैं। इससे पहले इन्होंने जो है रिसर्च काउंसिल के जो है एज ए DG इन्होंने काम किया है। तो वजह ये थी कि गवर्नमेंट अपनी जगह पे तैयार, और उसके बाद जो है सारी काउंसिल बनाई, और स्टैंडर्ड बनाने के लिए गवर्नमेंट ने लगभग 17 जो है नेशनल इंस्टीट्यूट बनाए हर सिस्टम के। यूनानी का भी उसमें रिसर्च इंस्टीट्यूट के साथ साथ नेशनल इंस्टीट्यूट बनाया, इसी तरह आयुर्वेद का बनाया, सिद्धा का बनाया, ताकि ये सारी देशी टीमें आगे बढ़ती रहें और ये बढ़ करके एक तरह से जो है संगमेल कायम हो। ये ना हो कि खाली यूनानी अलग हो जाए, एक दूसरे से कॉपरेशन, कोलेब्रेशन हो, और हर सिस्टम की वो सारी चीज़ें जो हमारे सामने आए और खुल के सामने आए कि किसी सिस्टम में क्या उसकी स्ट्रेंथ है, क्या उसकी ताकत है, और कैसे जो है उसको आगे बढ़ाया जा सकता है। रेख काजी साहब ने कॉलेजेस के बारे में और जो चीज़ें बताई, मुझे राशिद साहब ने बताया कि कॉलेज जो है हमारे चल नहीं पाते। उसकी वजह यह है कि एक्सपेंडिचर बहुत ज़्यादा है और उस तरह से आमदनी बहुत कम है। स्पेशली जो गवर्नमेंट के कॉलेजेस हैं उसमें ये परेशानी है कि आप फीस उतनी नहीं ले सकते जितनी जो है प्राइवेट कॉलेज के लेते हैं। तो जो प्रेजेंट इंफ्रास्ट्रक्चर है, जो मिनिमम स्टैंडर्ड कहलाता है, वो आसिफ अली खान साहब ने मुझे बताया कि इस वक्त जो है जगह जगह पे कॉलेजेस के साथ हम वो जो है रिवाइज करने की कोशिश कर रहे हैं, और उसकी लेगेसी जो है 6-7 जनरेशन से चल रही है। तो ये यूनानी के लिए और आयुर्वेद के लिए जो सिस्टम है वो इतना प्रूव करने के लिए काफ़ी है कि इस सिस्टम को सरवाइव करना है, इसको आगे बढ़ना है, और इसकी स्ट्रेंथ को कोई चैलेंज नहीं कर सकता, कोई भी चैलेंज नहीं कर सकता। कॉलेजेस पे मैं एक बात कहता हूँ कि आपको जो है 3.25 एकड़ लैंड दी गई, इतना बड़ा इंफ्रास्ट्रक्चर दिया गया, इतने लोग वहाँ काम करते हैं, जिसमें 47-48 वहाँ पे टीचर्स हैं। इसके अलावा पूरा जो है आपके पास एंसिलरी स्टाफ है। अगर आपके अंदर टीचरों के अंदर एक टीचर अगर 30 साल वहाँ जाके पढ़ाता है तो कोई एक कॉलेज ऐसा नहीं दावा कर सकता है कि मेरा ये टीचर है जिसकी बुनियाद पे इस कॉलेज में उस सराउंडिंग के पूरे लोग आकर के यहाँ दिखाते हैं। कोई एक भी कॉलेज दावा नहीं कर सकता, क्योंकि कॉलेज की इमेज वहाँ के स्टाफ से बनती है, कॉलेज की इमेज वहाँ के हकीमों से बनती है। एक भी कॉलेज कोई ऐसा नहीं है जो ये बता दे कि एक्स कॉलेज में एक्स प्रोफेसर, उसकी इतनी डिग्निटी है और वो इतना माहिर है कि लोग अपने आप खींचे चले आते हैं। तो जब तक कॉलेजेस को आप इस लायक नहीं बनाएंगे और इस तरह नहीं बनाएंगे कि जो है हमारे पास उस सराउंडिंग के सारे पेशेंट आपके पास आए, और ये मैं बता रहा हूँ कि ये जो है आपके पास जो है रेवेन्यू जनरेशन का भी बहुत बड़ा जरिया हो सकता है। जब तक ये चीज नहीं होगी तो आप सिर्फ गवर्नमेंट की एड पे, गवर्नमेंट की मदद पे, गवर्नमेंट के सहारे आगे नहीं बढ़ सकते हैं। हमारी रिसर्च काउंसिल है, जितने लोग भी अलग अलग पेरिफेरी में काम करते हैं, उतना बड़ा इंफ्रास्ट्रक्चर नहीं है जितना दूसरी काउंसिल का है। लेकिन अगर इसका जो है अगर हम इन टर्म्स ये देखें कि इसके रिसर्च, इसके पब्लिकेशन और फिर उसके बाद इसके लिटरेरी रिसर्च हो या इसी तरह मेडिसिन प्लांट हो, सारे उस पर काम हो रहा है। तो जो गवर्नमेंट की ऑर्गेनाइजेशन है वो मेहनत से काम कर रही है, चाहे आयुर्वेद हो चाहे यूनानी। लेकिन जब हमारे प्राइवेट कॉलेजेस की बात आती है या गवर्नमेंट कॉलेज की बात आती है तो मोस्टली ये है कि हाथ पे हाथ धरे लोग बैठे रहते हैं। तो आज अगर आपके पास ये सब चीजें हैं, अगर आज हम जो है अवेयर नहीं हुए, अगर आज जागे नहीं, तो मैं एक बात बिल्कुल खुले दिल से कह रहा हूं कि फिर उसके बाद पछताने के अलावा कोई जो है चीज बाकी नहीं रहेगी। हमें एक मर्तबा हर कॉलेज में, जैसे मुआवजात है, जितने भी क्लिनिकल सब्जेक्ट हैं, जो वहाँ का जो है मैनेजमेंट है, वही देखे कि हमारे इन कॉलेजेस में कितने जो है पोटेंशियल लोग हैं, उनको मोटिवेट करिए, आगे बढ़ाइए। और छोटे छोटे नुस्खे आप जो है 2-2, 3-3, मैंने हकीम साहब से भी बात कर रहा था, मैं गया 97-95 में शायद मैं गया था। आप यकीन नहीं करेंगे, बहुत उस जमाने में हकीम साहब का मैंने अंदाज देखा, बेहतरीन अधिक वो उसकी जो है मलमल का बहुत नफीस कुर्ता पहने हुए आप मतलब पे बैठे हुए हैं, मरीज आते हैं, बहुत संजीदगी के साथ उनको देखते हैं। मैंने देखा एक दिन रह करके शायद कोई मरीज हो जिसको अपने मरज के बारे में बताना पड़ा हो, वो खुद अपने मरज को जो है हकीम साहब बताते थे, बोलने की जरूरत नहीं है। फिर उसके बाद नुस्खा लिखा, 3-4 काउंटर है, अलग अलग काउंटर पे मरीज जा रहे हैं, और उसके बाद जो 600-700 मरीज जो है देख रहे हैं। तो एक कॉलेज जिसके पास इतना बड़ा इंफ्रास्ट्रक्चर है, छोटे छोटे नुस्खे आप बनवा सकते हैं, मुफ्रद दवाएं इस्तेमाल कर सकते हैं, आप उनसे पेशेंट से आप जो है आप चार्ज कीजिए। मैं मुरादनगर में हकीम यामीन साहब को जानता हूँ, उनके आज भी जो है 7 दिन के बाद 8 दिन के बाद नंबर आता है, और रेवेन्यू कलेक्शन आप देखिए कम से कम पर डे जो है 7 लाख 8 लाख का रेवेन्यू कलेक्शन होता है। तो यूनानी में अगर पोटेंशियल नहीं होता तो मुझे लगता है कि इससे पहले ही खत्म हो चुकी होती। आप किसी भी एरा की बात कीजिए, यूनानी अहद की बात कर लीजिए, उसके बाद जो है उमवी दौर के बाद चाहे वो स्पेन की बात कर लीजिए, उसके बाद आइए अब्बासी दौर में देखिए, उसके बाद जो है और आगे बढ़िए आप पूरे जो है ईरानी अहद को देख लीजिए। इसमें जो अतिब्बा है, जो उन लोगों ने कारनामे अंजाम दिए हैं, उनकी किताबें पढ़िए, उन्होंने क्या क्या एक मतलब अगर देखा जाए तो हर एरा में, अगर मान लिया कि बिफोर क्राइस्ट बीसी में अगर यूनानी अहद में अगर जाएंगे तो उसमें जो नतीबा की किताबें आज भी अवेलेबल हैं। अगर किसी और दूसरे सिस्टम में हो, जितना हमारे पास लिटरेचर है, चाहे वो मौलिजात का हो, चाहे वो लिटरेचर का हो, चाहे किसी और फन का हो, किसी और सिस्टम में नहीं मिल सकता है। मैं अगर अहद बहद यूनानी का अगर जायजा और उसके बाद आपको बताऊं कि किस अहद में क्या क्या किताबें लिखी गई और अतिब्बा ने कैसे कैसे काम किया है, तो एक हैरत अंगेज मुहय्यरुल काम हो। हमारे पास ये चार्ज लगता है कि ये वही तिब है जो है किसी चीज से नकल की गई है। आप भी देखिए कि अगर मान लिया कि यूनानी अहद है तो उसकी किताबें आपको लगे, यहाँ से उस जमाने में कौन जो है जा सकता था वहां दूसरे जगह पर। या इसी तरह जो है अगर हारून रशीद का जमाना है तो उसमें जो लोग ट्रांसलेटर थे जिन्होंने काम किया है, वो इतना जबरदस्त काम है कि वो सारी किताबें जब मंगोलों ने जो है पूरे उसको फतेह किया है और बगदाद को खत्म किया है, तो वो सारी किताबें उठ करके जो रुक गई हैं। तो अगर एक एक चीज को आप पढ़ेंगे तो ऐसा नहीं कि आपको लगेगा कि हम बहुत ही जो है ऐसे सिस्टम में आ गए हैं कि जिसमें जो है हमारा कोई वजूद नहीं, कोई एहसास से कमतरी हो। ये जो है आपको इब्न सीना कहता है कि तिब वो लोग पढ़े जिनके पास आला दिमाग हो। और आपको हैरत होगी कि 1000 साल में इतना बड़ा दिमाग का शख्स कोई पैदा नहीं हुआ इब्न सीना जैसा। तो सिंपली जो है जैसे काजी साहब कह रहे हैं कि एहसास से कमतरी, किसी को भी एहसास से कमतरी की जरूरत नहीं है। सिर्फ ये कि आप 10, 20, 25, 50 जो दवाएं देखिए और उसके बाद आगे बढ़िए, उसको लेके करिए, तो आपके कॉलेजेस बहुत अच्छे चलेंगे, आपकी रिसर्चेज आगे बढ़ेंगी, मिनिस्ट्री आपको सपोर्ट करेगी। आप भी देखिए कि मिनिस्ट्री ने इधर इतने सालों में हमने जो है NIM बेंगलोर बनाया 2004 में, फिर उसके बाद जो है इतने दिनों के बाद कोई जो है काम नहीं हुआ, और उसके बाद जो है इतना बड़ा सेंटर हमने गाजियाबाद का बनाया जिसमें गवर्नमेंट ऑफ इंडिया ने लगभग 600 करोड़ रुपया खर्च किया। इसी तरह सिलचर का इंस्टीट्यूट बनाया। आगे इस बार जो है अभी जो है काम चल रहा है NIM बेंगलोर का, उसमें 100 करोड़ का काम चल रहा है। तो गवर्नमेंट की तरफ से हर तरह की सहूलत है, हर तरह की फैसिलिटीज है। क्योंकि आप सभी लोग सब चीजों को जानते हैं तो आपके सामने रिवाइज करने से कोई फायदा नहीं। लेकिन चूंकि हमारे 2-3 मेहमान आप मैं ऐसा लगता है ना जैसे एक बात आप लोग जानते हैं, वही बात मैं आपको दोहरा रहा हूँ, लेकिन एक मोटिवेशन के तौर पर मैं कह रहा हूँ कि किसी एहसास से कमतरी की कोई जरूरत नहीं है। खुल करके जीजिए, खुल करके आगे बढ़िए, इंशाल्लाह ये टीम आगे बढ़ेगी, आगे बढ़ती रहेगी और गवर्नमेंट की हर तरह की सपोर्ट आपको मिलती रहेगी। खुदा हाफिज।
आपके प्रेरणादायी शब्दों के लिए बहुत बहुत धन्यवाद सर. And now, ladies and gentlemen, it's time to listen to the esteemed chief guest of today's function, Professor Asim Ali Khan Sahab, President BUSS NCISM, Ministry of AYUSH. I request sir to address the august gathering.
Thank you so much. Assalamu alaikum and a very good evening to all. On the dais, my colleague, my friend, Dr. M.A. Kasmi Sahib, Advisor Unani Ministry of AYUSH, Government of India. Very respected Dr. Zahir Qazi Sahib, who is the President of Anjuman Islam College, Mumbai. I have been told by Dr. Qazi again that it is a wonderful organization which has more than 110, 120 institutions, not only within the country, but across, beyond the nation as well. And I have the opportunity, hopefully tomorrow, that I will be there, inshallah. Very respected Hakim Khurshid Sahib, we were having a discussion just now. He has been doing wonderfully well in the Unani system of medicine in Bareilly. And not only that, he has a number of centers in Bareilly. I was talking to his son in Bareilly, in London, in Delhi, and they are ever expanding. My colleague from CCRUM, Deputy Director General, Dr. Munshi, and the gentleman, Dr. Masroor Qureshi Sahib, who has been working very hard also. My colleagues from CCRUM, Dr. Amena from Abu Dhabi, and distinguished experts, delegates, dear scholars, and dear friends. First of all, I would love to express my heartfelt gratitude to CCRUM and Ministry of AYUSH. They provided this opportunity to have interaction with all my colleagues here. Most of them, what I'm seeing is they all are the scholars from the CCRUM, except for some experts from Aligarh and some other institutions from Pune, but most of them are from CCRUM. I'm thankful to Dr. Zahir, the Director General of CCRUM, for extending this invitation to me. I'm here for the last 2 days. So yesterday we saw a wonderful function. Like always, CCRUM has been carried out in the main hall here. And we are very thankful to the Honorable Minister and Honorable Secretary AYUSH, Kotecha Sahib, that they graced the occasion and they found out time and they all traveled also from Delhi to here and beyond. It was a really wonderful platform, very meticulously planned, very gracefully organized, very structured program with all commitment from our colleagues. So thank you so much for organizing such a wonderful event. Team CCRUM. I also appreciate the release of certain books and reports. One of them was from the CCRUM, where we had conducted one survey for the female graduate students, and we wanted to know that what female graduates, how do they feel, how many of them are carrying and continuing their efforts into the same system, and if they are not, then what are the reasons why they're dropping out, and what are the concerns which we could cater to, which we could handle. CCI, NCISM, so that also we got released. Web portal, it was a very wonderful initiative yesterday, is for the ease of the scientists who are working collaborative research. So a lot of things yesterday we saw and witnessed. And I extend my heartfelt congratulations and to all my colleagues from CCRUM, because I know I have been working as a Director General for 5 years with you. And I have full trust in everybody. I have seen you working, I have seen your potential. You have done wonderfully well yesterday also and before that also. So there is a huge potential which I see in almost all scientists who are working for Unani system of medicine in different parts of the country. We have almost 23 to name, otherwise there are almost 27 as including co-location centers. We have been wonderfully well. We have some, our old guards also, Professor Mushtaq Sahib is sitting here. He has been, his contributions, and you can see, you can witness that Central Institute of Hyderabad has now been converted and uplifted into, because these people worked so hard for the skin disorders, particularly for the vitiligo and all that the whole world now recognizes the center, and Government of India are taking note of it, and it was very nice, the kind of Government of India, that they upgraded the center to the National Institution for Skin Disorders, specifically in Hyderabad. So a lot of things are happening, as Professor Kasmi Sahib was suggesting, and number of things are happening. We are very thankful to the Government of India for hand-holding in last 5-7 years. You saw what a growth we have seen in terms of infrastructure, in terms of getting our hospitals accredited. All hospitals almost of CCREM are now NABH, all of the laboratories are now accredited by NABL. We have all the factories which are now GMP certified. We have all good researchers. So scientists are also being trained and upgraded. New facilities have come up, like he referred to the 500 crores, 600 crores investment, a hospital, a wonderful facility in Ghaziabad, which is almost catering to almost 3,000-4,000 patients a day. And they have started the super specialized and specialized OPDs. We have Ministry of AYUSH also granted certain center of excellence. One, I was a DG, we could have one from Ministry of AYUSH to one center in Srinagar, our regional center there in Jammu and Kashmir Ministry and Kashmir University, where they are doing wonderfully well. One center of excellence, there was a scheme Ministry would provide to Jamia Hamdard. And that center, I don't know how to say it is here, the director or not, I mean, it's doing wonderfully well. It's a highly equipped center, a state-of-the-art center, and wonderful researches are happening, including zebrafish, and all high-end equipments are available in that center. I think it's one of the state-of-the-art facility. For anyone, believe about Unani or any other sciences, this is a wonderful facility, which has been really served. The purpose has been served. We were talking, Zahir Qazi Saab had identified some very important points. He was asking for the motivation. He was asking in a way that we all have to own the system. Seems to be there is some disconnect. Maybe some of the people who are working in government, they think in a different way. The private people, they think differently. The private practitioners have some different targets to achieve. I think the important thing is benefiting the people. We were talking about Dr. Zahir Qazi Sahib also, he set the tone for that, and then Dr. Kasmi Sahib took off that, and he continued in that same spirit that there is no reason that we shall have to be considering somehow as a second grade or somehow to look down. I have a different idea otherwise, sir. My idea is, because I have been traveling quite often to different parts of the world. Students starting almost most of the places I have been. And in government also I have seen what government is thinking about. I have worked with my colleagues in the CCREM and as in Hamdard earlier. So I know the potential of the physicians, the potential of scholars, and how it is transforming, and how the opportunities are available of late as of today in this 21st century era at the moment we are living in. To my understanding, there is a complete paradigm shift. Paradigm shift in the sense, I will request to all my colleagues who are performing wonderfully well, कि वो कमतरी का तो बहुत दूर की बात है, कि मुझे डर है कि वो बर्तरी का शिकार ना हो. To be very honest, universities in the institutions who are working for the validation studies of the pharmacopoeial medicines also. This is our in-house team. There are certain things which we are getting somehow impatient also, in a way that we don't have that much of time that first we will do this. We are taking a number of things parallelly. Parallelly surveys we are doing, parallelly we are expanding the literature, parallelly we are also doing the collaborative research. I don't think any leading institution in the country at the moment is, including the CCMB, Professor Sahib is sitting here, including the CCMB and IICT in Hyderabad and CSIR and other international institutions, where we don't have the collaborative researches going on by the CCRM or CCRS. So what we do is, the model is that we invite as an expression of interest that this is the demand of the health at the moment in the country. Anybody who is expert out of it kindly come forward in a structured way to apply for the projects. And then it is not a kind of a sponsored project, it's a kind of a collaborative project, wherein you have your expertise, My scientists in CCRE and other places have an expertise. He will be the principal investigator. You are the principal investigator. We will provide the funding from the ministry and kindly do the needful. Come up with the wonderful publications. I have been seeing when as a director general at that time also. Publications earlier, it was not a culture. A question is if a research council, which has been funded by the government of India just to do researches, how can we justify that work if we do not publish the work? Research council means research publications. And research publications is not in any communication of this kind of a paper. We have to publish in good impact factor journal, not because impact factor journal means that people have the visibility of the journal. So that people take it, something we will carry forward, somebody else take the lead and he does the research so that we can go. So these things are happening. We have recently done in WHO almost 7 years before. It has really given me that jump that we did an MOU with WHO. And under the MOU, a lot of activities happened. I was witnessing to that. Almost 22, 23 countries we participated as stakeholders who are doing the AYUSH in different parts of the country, wherein almost more than 70 or something like that activities happened and meetings happened in different parts of the world, including Malaysia and India and many other countries. And we could manage one thing that we could develop 3 documents, important documents that we could land in the International Classification of Diseases in the chapter 11. We are there already. It has been done. Second is that we have developed the benchmark for practice and training in Unani system of medicine like in Ayurveda and Siddha, where in the whole world, if somebody wants to start a Unani practice, small, big, college, training, what shall be the parameters for that? It has been given to almost 180 countries now. Everybody's having access to that. We have also come up with a standardized, for example, I'm ASIM or ASIM or ASIM or what. We have developed this standard terminology document once and for all by the government of India with the WHO support. So all these activities are already happening. All hospitals are now getting converted into the AHMS system where information management is available. We have developed for the pharmacovigilance, we have the strong support, for example, central pharmacovigilance area, institution, then regional, then peripheral, and some intermediary. So a lot of activities we are in the process of doing, a lot of activities are going on. My only concern is the people who are sitting in the peripheries, who are the colleges, who are the factories of bringing out the products, who are the tomorrow's doctors. As a national commission, we are trying our best to develop the standards, for training, for research, for everything, so that people could implement. Of late, what has happened, what Kasmi was also referring to, that of late, why we started earlier, it was that we used to make the laws and the regulations and guidelines, and people were simply blindly they had to follow. There was no option to the people. Now we are reaching out. Last week, I was in Mumbai, and I had an opportunity to meet some of the 7 or 8 colleges of Unani also from Pune and Mumbai, and your college was also there. We could meet. I think more than 100 colleges of Ayurveda and their management. So we are listening to the management, what difficulties they are finding in running those colleges, what difficulties they are finding in establishing such kind of facilities which we are asking them to do as regulators. And similarly to the students also we are talking that whatever the syllabi we are making, whatever curricula we are making, are you really comfortable? Is it overdose? Is something much on your plate? Are you able to carry forward this task? See, we are talking to the teachers also, and we are going out to different parts of the country. Like we went to Bangalore, there's more than 100 colleges. We came to Maharashtra and Mumbai, where almost more than 30 colleges were there. Their management, their principals, their students, their teachers. Every simply stakeholder we were talking separately because sometimes students don't speak in front of teachers, sometimes teachers don't speak in front of management. We are recently in near future, hopefully within 5-7 days, we are going to Lucknow East Side. We are talking to the principals there. I'm also doing the same exercise because my responsibilities for Siddha and Sovarip also. I'm reaching out to Sovarip doctors and professors. I'm reaching out to Siddha, Chennai, hopefully by 21st, 22, we are having in Chennai also, for all Siddha doctors. So we are coming up to understand what kind of issues and concerns they have. Accordingly, we will look into this. We will examine the whole process, not only one day. So that kind of approach government of India at the moment is having. CCRM has done a lot of patents. I'm very thankful to them that during that process, I think more than 200, 300 publications. This is the now number which as a CCRM really. Every year, almost more than 300 publications are going back to journals, including literary research. I was witness to the literary research people that started sitting here, last started sitting here, team sitting here, that they have, I think literature is not easy to bring those high impact factor journals. But I saw the work, almost 5, 6, 7, 8 impact factor journals, the papers of research institution of my literary institution were published. So this is wonderfully well they are doing. Very wonderful work you are doing. The only thing is kindly keep that zeal. Kindly be motivated, remain updated. All the people, if you see the tone, what we are seeing from this side to that across the board, everyone is interested that passionately we shall practice, learn and practice passionately the system. People are in need. People are looking towards us in the name of cure, in the name of wellness, or whatsoever, which we have a huge strength, which government is supporting. Government is ever open to provide any. I always say, this is my fond sentence, that trust my words, that whatever the projects I have been taking to Minister Sahib and Honorable Secretary Sahib in those days, I don't think any project was turned down or even for any reason. Everything was approved. The only thing is you have to work hard. You have to work hard to develop the proposals. And my team was, I'm thankful to all the team because nobody can do alone. All the team members, they did this so much wonderful work. And all the proposals, whether establishing the colleges or upgrading institutions or center of excellences or NABH or NABL or any number of activities, hundreds of activities are happening in this area. So they are doing, in the colleges also, they are, I request all the colleges, particularly, I think I can see you only here, I don't know other colleges that they are participating or not. So you are also requested, through you, I am speaking to them, that kindly come up with passion, understanding, with vision, work hard, have a, वो क्या कहते हैं हिंदी में, तो एक भाव होना चाहिए, सेवा भाव. To my understanding, being on earth, I don't consider anything. I speak to my students, so I'm sorry because I speak too much when I be the teacher earlier. So my point is that that we have to be having on earth. I don't consider much an achievement, sir. I consider there is all given. I have something to strive. I have only to struggle with whatever understanding I have been given. Giving or not giving is in the hands of Almighty. So when everything is given, we should try our best to serve. We are here to serve. So you have a wonderful facility as doctors, as researchers, so kindly use that potential, grow and let others grow, keep the society healthy. I will not take much time. Beyond this, may our continued efforts lead to a very healthier world, very enriched by the wisdom of traditional knowledge and strengthened by the power of scientific innovation. Thanking you so much for providing this opportunity.
Thank you so much, Professor Asim Ali Khan Sahib, for your enlightening words. As we are moving towards the closing, I personally would like to thank Dr. Masroor Ali Qureshi Sahab for introducing me to this beautiful Unani family, and many thanks to Dr. Munshi Sahab, Ghazala ma'am, Farah ma'am, and the whole organizing team for cooperation. It was pride and pleasure to come here for this Unani Day and 2 days कॉन्फ्रेंस. इसके बाद आभार प्रकट करने हेतु मैं आमंत्रित करती हूँ डॉक्टर मसरूर अली कुरैशी साहब को, रिसर्च ऑफिसर यूनानी, नोडल ऑफिसर जेजे को लोकेशन.
Respected dignitaries on the dais, honored guests, distinguished delegates, colleagues, media representatives, and dear friends. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening. First of all, I extend my heartfelt congratulations to everyone on the occasion of the Unani Day 2026. It gives me immense happiness and pride that this important national celebration, along with the two days scientific conference, has been successfully organized here in Mumbai. Thank you very much, everyone. I am deeply thankful to the Central Council for Research in Unani Medicine and the Ministry of AYUSH, Government of India, for giving us a valuable opportunity and a responsibility to organize this prestigious event in Mumbai. At the outset, I express my sincere gratitude to Shri Pratap Rao Jadavji, Honorable Minister of AYUSH, Government of India, and Shri Baba Sahib Patel, Honorable Minister, Ministry of Cooperation, Government of Maharashtra for their encouragement, presence, and continued support towards the promotion of the traditional system of medicine. I also extend my appreciation to our Secretary Vaidya Rajesh Kotechaji, Secretary Ministry of AYUSH, for his visionary leadership and constant guidance. My sincere appreciation also goes to Ms. Mona Lisa Dash, Dynamic Joint Secretary, Ministry of AYUSH, Government of India, and Dr. Mukhtar Qasmi, Sahab Advisor Unani, whose encouraging presence and constant support greatly motivated all of us and strengthened the success of this event. I express my sincere gratitude to Dr. N. Zahir Ahmad, Director General CCRUM, for trusting RIUM Mumbai with the responsibility of the organizing this prestigious national program, Unani Day and 2 days conference. I am thankful to Dr. Manisha Upendra Kotekar, Chairperson, National Commission for Indian System of the Medicine, and Professor Asim Ali Khan Sahab, President Board of the Unani Siddha Sovarimpa, BUSS, whose gracious presence and inspiring words added dignity and academic strength to this program. My special and very special thanks to Dr. Iftekhar Yunus Moishi Sahab, Deputy Director General CCRUM, and his entire team for their trust, guidance, and continuous encouragement. Sir gave us complete freedom and confidence to organize this event smoothly despite holding such a high office. He worked tirelessly alongside us like a true team member. He remained available for us 24/7. Even late night messages received from replies and permissions and the sanctions were issued without delay. Whenever any difficulty arose, he would reassure by saying, Masood Sahab, don't worry, मैं हूं ना. और इसी मोटिवेशन के साथ फिर हम दोबारा काम करने के लिए शुरू कर दिया करते थे. These words gave a confidence and a strength. The success of this event is largely because of the constant support and leadership. I thank him for the core of my heart. Shukriya Moishi Sahab. I am grateful to the CCRU team, entire team, especially Dr. Ghazala Javed Madam, Assistant Director, Dr. Pawan Yadav ji, Dr. Pardeep Sahab, Dr. Usama Akram Sahab, Amanullah Sahab, and Nikhat Anju Sahiba, Dr. Asma Sattar Madam, for their continuous professional guidance and support throughout the event. और सेक्रेटरिएट में तो आप लोगों का रोल तो गजब का था. बहुत बहुत शुक्रिया. Thank you very much. Thank you. I extend heartfelt thanks to Mr. Sadakat. Just a minute. I sincerely thanks to Dr. Rashid Qazi Sahab, Principal Anjuman Islam Tibia College, and Dr. Jalil Ahmad, Vice Principal ZBM College, for their constant cooperation and support. Really, thank you very much. Thank you, Dr. Jalil Sahab and Dr. Rashid Qazi Sahab. My gratitude also goes to the Vice Chancellor of the American University, Dr. Zahira Qazi Sahab, President Anjuman Islam, and Dr. Munira Madam, Principal, for their encouragement and the institutional support. I extend heartfelt thanks to Dr. Sadakat Sahab, Deputy CEO, Administration and Accounts, Hajj Committee of India, Mr. Shanawaz Sahab, CEO, Hajj Committee of India, for graciously providing a space at the Hajj House and extending full cooperation for the arrangements. My sincere appreciation goes to Mr. Parvez Sahab, Accounts Department, CCRU, and his team. Thank you very much, Janab Parvez Sahab and his team.
I extend heartfelt thanks to all the staff of the RIU Mumbai. RIU Mumbai के तमाम लोगों का मैं शुक्रिया अदा करता हूँ जिन्होंने दिन और रात एक करके इस इवेंट को सक्सेसफुल बनाया. From the RIU Mumbai, Dr. Humaira Banu, Dr. Nikat, Dr. Nirmala Devi Madam, Dr. Irfan, Dr. Adil, Mr. Shah Alam Sahab, Dr. Ziaur Rahman, Dr. Zaki Ahmad, Dr. Ansari Shabnam, Mr. Piyush Yadav, Mr. Ratan Kumar, Mr. Rahul Tripathi, Mr. Zoeb Shoaib, Mr. Hassan, pharmacist, Mr. Pinky, housekeeping, and all my colleagues. I am really thank you. Shukriya. Special mention for Mr. Mushahid, pharmacist, and Mr. Munawwar, MTS, Mr. Vishal, my institute driver, and every member of institute who worked day and night tirelessly to make this event a grand success. I am thankful to the media representative and auditorium staff for their cooperation and the support. Most importantly, I express my sincere gratitude to all the dignitaries, speakers, and the resource persons who traveled from the different parts of the country and enriched two-day conference with their knowledge, experience, and valuable contributions. In the concluding session, I extend my heartfelt thanks to the Hakim Khurshid Sahab, who graciously joined us despite his busy schedule and honored this occasion with a valuable presence. This event has clearly shown that when the teamwork, dedication, and the sincere intentions come together, success becomes inevitable. Let us continue to work collectively for the promotion, strengthening, and the global recognition of the Unani system of medicine. I am also thankful to Mr. Salim Sheikh of the Saina Production. इस पूरा जो इवेंट किया है हमारा वो साइना प्रोडक्शन ने किया है, उनके लिए मैं जोरदार क्लैपिंग की दरख्वास्त है. I am also thankful to the Vedan Guru, especially Dr. Amit Murad Khurshid Sahab, for graciously hosting a delicious dinner in Islam Gymkhana. Thank you very much. I would also like to sincerely appreciate Dr. Murmai Madam for anchoring the program so beautifully and gracefully. Her excellent communication clearly the presentation added charm and the smooth flow of the entire event. Thank you for conducting the session with such professionalism and the elegance. And Dr. Murmai Madam, she is a homeopathic graduate. Part of the AYUSH system. Thank you. Before I conclude, I would like to sincere apologize if I have unintentionally missed mentioning any respected name of if there has been any shortcoming of the inconvenience during the organization of this program. We tried our best to conduct this event in the finest possible manner. As a human being, we are not perfect. Only Almighty Allah is perfect. Therefore, I humbly seek your understanding and the kind request you excuse unintentional errors. Your goodwill and the support means a great deal to us. Last but not least, thank you to my family, my wife, and my kids. जिनको मैंने बहुत ही सताई हुई दिला. Thank you very much. मुसाफिर हैं हम भी, मुसाफिर हो तुम भी. मुसाफिर हैं हम भी, मुसाफिर हो तुम भी. फिर किसी मोड़ पे मुलाकात हो. Thank you very much.
Assalamu alaikum, very good evening. With permission of chair, dignitaries on the dais and respected audience, कल अंजुमन इस्लाम डॉक्टर MIJT यूनानी मेडिकल कॉलेज में नेशनल यूनानी डे का सेलिब्रेशन है और एक वन डे कॉन्फ्रेंस है, हाइब्रिड मोड पे है, जिसमें हमारे प्रोफेसर आसिम अली खान साहब चीफ गेस्ट है और एम.ए. कासमी साहब भी है, मुंशी साहब भी है, और मैं हमारे प्रेसिडेंट सर के बिहाफ पर वेदांता ग्रुप के चेयरमैन को भी इनवाइट करना चाहता हूं। सर आप भी प्लीज इस ओकेजन को ग्रेस कीजिए, और मैं आप सब लोगों को इनवाइट करना चाहता हूं कि आप जरूर इस कॉन्फ्रेंस में आइए, और जो आ नहीं सकते वो हाइब्रिड मोड पे ज्वाइन कीजिए, हमारी हौसला अफजाई कीजिए। और मैं CCRUM की बहुत मुबारकबाद देता हूं, बहुत शुक्रिया अदा करता हूं। थैंक यू वेरी मच।
Thank you very much. We close the ceremony with national anthem. I request everyone to kindly rise for the national anthem. Shall we start or please start?
जन गण मन अधिनायक जय हे भारत भाग्य विधाता। पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा। विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा। तब शुभ नामे जागे तब शुभ आशीष मांगे। गाहे जब दया गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता। जय हे जय हे जय हे जय 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 हे।
Thank you.